I wasn't watching the time, so we're running just a little bit here behind. And now we're going to catch up pretty quick. So we will start off with follow-up information from our November 17 meeting, and we'll start with the right of order. Good morning.
Good morning, Madam Chairman and members of the committee. We have some items that we've provided for you. Once we clear these out, the only thing left in your packet will be the report, so we'll get through this pretty quickly. The first thing is the green sheet of paper is a follow-up information from David Jordan, who's the CEO of United Methodist Health Ministries, and there were several questions posed to him about the report that was done by the Governor's Commission on Racial Equity and Justice, and so that is provided to you in the green document. Next is the lavender, and it's a memo that's a survey of the interstate licensure of counselors and marriage and family therapists that was put together by one of our staff members. We have the NCSL responses to questions that were asked of him, and he provided quite a bit of information about interstate licensure compacts and provided an overview, so that's next in your packet. Then you will see a legal-size document in on white that's the Behavioral Health Professions Wage Comparison for Kansas and neighboring states, and this is from the U.S. Bureau of Labor Statistics from May 2020, which was the most recent data available. And we've compared the median hourly wage, the mean hourly wage, and the annual mean wage by professions using the occupation code, so we were hopefully able to compare apples and apples. So. Next, we have the Mental Health Modernization Reform Response from DCF for requested information. So they've provided that here on white sheet that's available to you. We have information from Sheriff Easter, who spoke to us at the last meeting regarding the integrated care team, and we asked for a financial impact report. So that has the header at the top with all of the badges there. We provided also an Oklahoma map with the certified community behavioral health center locations, just showing the counties and by region there where those are located. And next is the Missouri Department of Mental Health map on their certified community behavioral health organizations. And they have, on the back is a list of the counties and the towns where those centers are located. But the map will indicate those that have those organizations. We also have a response to some of the fiscal questions that were asked, and those were on the blue sheet, that's blue memorandum that's before you. And then this one's not included on the list. It was just provided yesterday after the agenda was published, but this is the history of KDAD's mental health expenditures, and we've been updating that as we go. So if you have questions on that, please be sure to talk to Matthew Moore. And then we have the crisis system service funding and delivery model that was provided to us, and it shows the funding from House Bill 2281 and what it could be used to cover on page 2, on the second full page. And finally, from the Office of the Reviser Statutes, we have the statutory provisions related to suicide prevention programs. And that's all for me. If you have any questions, Madam Chair, I'm happy to answer.
Committee, are there any questions with what she's gone through? Senator Hawk.
Thank you, Madam Chair. I'm not sure this is a question for you, and I'm not sure I should know this, another one of those things, but I keep feigning back on the fact that I'm new to this committee. So I would like to have somebody explain to me the new certification procedure that we passed for community mental health centers, how that will translate into more salary dollars for them. And I think in some of the earlier testimony we had, some of the, and I'm looking at this sheet, some of the differential in pay with surrounding states was because they had done that before we did. And I'm just kind of curious how long it's going to take us to get more money into our community mental health centers so that that's reflected in the salaries. And that may not be a question that's answerable, but if a staff member or somebody who's on our committee has sort of a estimate of how that impact will be and roughly how much it will be and how soon it will be to close that gap. It seems like that's one of our issues. If our professional people keep migrating to surrounding states, because there's like this top one is a huge differential between Kansas and Colorado on the clinical psychologist. So just curious about that question sometime as we deal with that today.
Okay, well, Andy, is that something that you can respond to, or do I need to would you mind stepping up? So, all right, we'll just have a little bounce back and forth if you're okay with that. Tell us who you are and who you're with.
Yeah, Andy Brown with ks. I'm the Commissioner for Behavioral Health Services. So I think the best way I can address this is that as part of the CCBHC system, when a CMHC is certified, they have the opportunity to provide in their cost report projected costs. And those projected costs are where the CMHC has the opportunity to include additional new salaries, additional new positions, and the sort of overhead and indirect that comes with those positions. So during that cost reporting process, we anticipate that the majority of the CMHCs will probably increase their staffing by, probably somewhere in the neighborhood of 20%. So then what would happen in terms of time-wise is we passed that bill in a way that allowed for that to be incremental over the next 3 years. So we're going to certify our first group of CMHCs in May of '22, and that'll allow us to immediately start to have them hire new staff as needed and do pay raises and increases for their staff at that time. And then by the end of year 3, we'll have all 26 of the CMHCs involved as CCBHCs.
Senator Hawk.
So do you think at the end of that 3-year period of time, when I look at some of these pay gaps on this big sheet, will we close that gap, or will we still always be behind because we've started later than surrounding states?
Well, I think this is probably our primary opportunity to close the gap. I don't have a crystal ball, so I'm not sure what'll happen 3, 4, 5 years down the road, but this is really, I think, going to be a significant opportunity for our CMHC system to close that wage gap and become more competitive with other states.
And I'm assuming that lets us draw down more Medicaid money.
Yes.
To help fund that, but we'll also be investing more state general fund dollars as match money.
Yep, that's correct.
Thank you, Madam Chair.
Yeah, it's just because of the size of the fiscal to try to bring them all on at the same time. So if you're familiar with the FQHCs, so this works just like the FQHCs. So that'll put them at cost. To me, I simplify it. It's now at cost instead of our Medicaid reimbursement. Are there other questions on this issue or anything else that are Ida? You're welcome. Representative Arnberger and then Representative Reese.
Thank you, Madam Chair. I don't know if this is an Andy question or for research. I'm looking at the annual mean wage on that same form. It looks like Colorado is surpassing us a couple times. Their funding mechanism, I guess I'm just curious if they have a special funding mechanism, only because marijuana is legal there. I'm curious if any of that goes to mental health.
I'm not aware, Madam Chair, I'm not aware of that information as to what the funding mechanism is, but I'm happy to look into that and get back to you on it.
Representative Reese.
This would be directed to research. On the purple sheet, there's a lot of things here about the interstate compacts. Another thing to look at, I'm trying to see if it's on there.
Everyone else not hearing anything anymore from the committee room?
Don't hear anything.
No, I'm inquiring.
I must be having some technical issues. Hey, everybody. I just heard from Connor Stengler from KLRD. He says that if you want to hear what's going on, the Harmony audio link on the legislature's website is working, so we can tune in there.
We present to that link too.
We cannot present to that link. You could also watch on YouTube as well, but until they get WebEx fixed, we cannot present.
Hi, Hannah, this is Shauna. Is there any way we could put that link in the chat here?
I am unable to chat everyone on WebEx. It is IT staff that's local. However, I can navigate you if you go to ks.legislature.org.
Okay.
And then in the upper right-hand corner near that search the site, you can, there's a button that says audio video, and you can go to State House Live and Archive.
Thank you.
Mhm.
Lost that one too.
This is not going well.
No,
Do we think it's the winds? I wondered
Maybe.
about that today.
I feel bad for Carrie now. I should have driven to Topeka. only December 15th with 70-degree weather and super high wind speeds.
And we'll probably have tornado warnings tonight in December.
It's pretty weird, all right. There we go.
Decisions are consensus, and consensus is not defined in the percent says this is exactly how I would have written it, but it does mean this is a recommendation towards arrived at consensus of the full group. Expertise of working group members who know about that particular recommendation. So we didn't have like up and down, but and along. Most we did in those working groups is basically thumbs up. Again, the recommendation rubric, which you'll see represented a little bit in the updates that we'll be walking through, was used last year. Similar, actually the same rubric was used this year to help both with new recommendations, and that was. Yes, we have to hold on. I just got text that maybe we lost harmony, have we? Okay, so we're just going to stand still because without harmony, we're public violations. Eat anything later. Saying it back, it's back. I'm gonna wait till our IT people tell us we're back. Yeah, perfect record on no violations, so I tried not to take it. Well, now that you brought it up, Senator Hawk, I think I'm going to direct them your way. Oh, yeah. Now they're telling us that we're back up, but we're kind of going in and out, so people just kind of monitor, because we go down, I want us to stop our committee process. So you can flag me, whatever. All right, thank you. So I believe that we're back up on harmony. So for those of you that are just tuning back in, we paused everything until we could get our audio at least back up, and I think they're still working on the new issues, so you can hear us but not see us. All right, Carrie, go ahead. I think you're good. Thank you. Just FYI, I get some text to people who are concerned that they don't have the ability to get the folks who are presenting on WebEx. So when we get to that point, might be another issue. So, okay. Where were we? We were talking about the recommendations rubric. So in Appendix C of this report, it includes that rubric. And basically, that's just sort of a checklist of the kind of criteria that the working groups considered when they thought about these recommendations and how to characterize recommendations as either being of immediate action or strategic importance. So in that rubric, it asks questions such as, hey, is this recommendation a program change, which in the scope of recommendations is probably the most straightforward to accomplish? Or does it require a complete brand new program? Or does it fall somewhere, is it a pilot program? Does it fall somewhere sort of between there on the spectrum? So those kind of questions the working groups consider. And just to help, again, with the characterization, the more likely it's a new program, the more likely it may take a little bit longer than the 2 years to get fully implemented, for example. Potential for high impact is another consideration that working groups look at, and that includes, will this recommendation impact a large number of people, or will this recommendation impact maybe a smaller number of people, but it has a huge impact on the folks. So they can, either one of those things could be scored as a high impact for the recommendation. And if it has maybe
Did we lose him again?
I'm still here.
change, the committee members change, you know, hopefully we can keep this process going because it's just been so on target. Because last year we actually checked off, I don't know if Kyle Kessler's out there. Oh, yeah, Kyle, can you hear us? Can you
I
talk
can,
to us?
Madam Chair, but
Oh.
I'm getting quite a bit of feedback.
So that's kind of Senator Hawk where we're headed is for, that's why I.
Let's try it now, Kyle.
Yes.
Okay, do you happen to have that list? And if not, I bet research has got it somewhere of what we said that we checked off last year?
The last checklist that I had worked on, I believe legislative research has, but I can also try and hunt it down.
Well, we'll take a look at it and then we'll compare that with what you guys think happened and get us all on the same page with it, so.
Are the Appendix B that's recommendations considered complete was drawn from the spreadsheet that was presented at the first meeting. So if that has a starting point potentially of that checklist, then updated with what agencies reported, that's what was included.
Is it B?
I believe it's Appendix B, which is on B1, which is probably, yes, recommendations considered complete. So for example, it has recommendation 1.1, 4.3,
Okay.
5.2. Another
But
thing
I
that,
still like having those.
Yep.
Those boxes, because that's a simple,
yep.
yeah,
And I think that's an easy modification.
right. So it's like what you were talking about, Senator Hawk, is the information's here, it's just how are we taking, compiling it? This is our second year for this committee, so last year, I mean, it was a crash and burn and learn as we went, and I think it's just gone incredibly smooth, between the help with what KHI has done and our revisers and research staff has just been awesome, so. Senator Hawk.
That may accomplish what I was suggesting, and certainly that's helped make me more aware of how that accountability piece is in there, so thank you.
Yeah, because in the House last year, because we got the CCBHC, having that extra letter is still throwing me today, legislation through, and then we started with the 988, and we hope to complete that next year. And we don't go out and introduce things in both chambers. We try to move through with just one big bill, so.
And Madam Chair, I probably would defer to KLRD, but another thing we did discuss is that potentially the committee's report would include that document that was presented at the first meeting. So it would have not only those things that were reported as complete, but you'd have all of the progress updates, even of those recommendations that aren't being revised this year.
I've just been excited with how this report's gone because then I don't have to look at report after report after report. And if you actually view this online, the other important factor in here is all the hyperlinks. So anything that we've talked about or any behavioral health group that we could find out there or all these different meetings that are happening, we bring those links together. So people have really one source to go in there, you know, whether it's the governor's mental health or behavioral health, whatever the title of that is. And then we have 3 or 4 others. We try to look at those reports, but we also hyperlink them back to this report so we can get it all in one place. So we're looking at the picture, not fragments of the picture. Any other questions? Representative Lynn.
Thank you, Madam Chair. I have a question about Figure 3 on page 10. You have the mental health in America rankings listed, and in looking that up, it looks like it's mostly about the statistical data, which is great and necessary, but I think it's just one piece. Do you know if there's any ranking for states or about the policy or mitigation strategies or something beyond just the pure statistical data?
So so a ranking from an organization, and actually I think some of the mental health in America, and Andy could correct me or Kelsey Torres could as well, some of the overall rankings, some do include not just quantitative, but also some, policy rankings as well. We had a memo that KHI did last year for the special committee that talked specifically about the Mental Health in America rankings and describe some of it, because there's some data lag and all that stuff, which is part of the reason there's the new recommendation about outcomes data too. So we could revisit that, but I will pause and see if Hina or Kelsey, or maybe even Andy, if he wants to talk about any other rankings that may be more qualitative, basically, sort of policy-based. And did I represent Mental Health in America correctly? Oh, there she is behind me.
Good morning, Madam Chair and members of the special committee. My name's Hina Shah. I'm a senior analyst at KHI, and yes, I showed up once WebEx crashed. You're correct. It is statistical data. There's about 15 measures in the Mental Health in America rankings. Other rankings that we've looked at are America's Health Rankings and County Health Rankings. They all have other composites that they put together, but they also have different elements. So for example, America's Health Rankings has 4 domains: behaviors, clinical care, social and economic, and physical environment. And so I'm happy to send along a handout that KHI has that explains at least the Mental Health in America, America's Health Rankings, and County Health Rankings to see if there's any data you would want to see out of there. There is a little bit of qualitative, but it's mostly statistical data from national studies.
Thank you, Madam Chair. I was just mostly curious about what kind of programs the other states are finding a lot of success in.
I would recommend NCSL and a few other sites that pull that together.
Thank you. Thank you, Madam Chair.
Actually, we think Kansas is leading right now, so. Was there anyone else that had a question? Senator Erickson.
Thank you, Madam Chair. And this piggybacks on Representative Lynn. As I'm looking at Figure 3, and I know that Recommendation 7.6 deals with data collection as well. And when I read the data profile information on page 9, if we're using this to assess our behavioral health system in Kansas, and I look at the data that is in here, can you kind of expand a little bit on, it looks like there's some data in conflict, I'll put it that way. For example, when you look at statewide age-adjusted mortality rate for suicide year, looks like the U.S. is going down, Kansas is going up a little bit, which is not good. And then you look at the 2022 rankings, and I know that the data year may not be necessarily matching because it's, you know, retroactive or they don't match exactly, but then we're ranked 17th for, you know, I don't know, it just looks like there's a lot of data in conflict. And how helpful is that? Are we going to be looking at maybe more congruent data to help us assess and get a better, maybe accurate picture of behavioral health needs?
That is an excellent question, and you're correct. Those are different data sets and different lags in years, and so you're not comparing apples to apples at that point. It is apples to oranges. And so the recommendation that's being put forward would help to streamline so that you could actually make comparisons year after year using a similar data set versus kind of piecemealing a few different data sets together to show based on what data is available. So when this data profile was first put together, there was a team of agency staff that came together and looked at what are all the data sets and data points that are available in the state that could be reported related to behavioral health. And so remember, this is that systemic, high level, snapshot there. But you are correct that they are from different data sources, which will have different lags in years. And so it's not just, real time or from 1 year. And so the new recommendation could help this committee and others to come together and say, here are the 5 or 10 data points we want the state to really report every year and make sure that it is the same data year so there is consistency in the data.
Absolutely, because, when you have data that is different, you can make it say anything you want. So if one group comes in and says, oh, no, we're doing great, look at this data set, and another group says, no, we have a big problem. So it just will be nice to have that, and I appreciate the focus on that. So thank you very much. Thank you, Madam Chair.
Well, and one of the things is like to look at, Kansas death rates and the suicide numbers and everything. We will have 2020 about this time in 22. And every state's a little bit different. So actually, I think those come out in what, like November, October, somewhere around there, I think? Yeah. So, thank you very much.
Okay, thank you. Good questions, and look forward to talking about that recommendation as well. So I think our co-chairs are all available on WebEx now. So again, I will reintroduce the three co-chairs of the Services and Workforce Working Group, and they'll be tag teaming, going through recommendations starting on page 11 and kind of winding through the middle part of the report. So with that, I think, Dr. Warrens, you are first to kick it off.
Thanks, Carrie, and Madam Chair and members of the committee. My name is Will Warrens. I'm one of the co-chairs of the Services and Workforce Working Group. The first and I should explain first, like Carrie mentioned, I will be tag teaming with Shane Hudson and Charles Bartlett, the other two co-chairs of the working group, at, issue by issue as we go through our recommendations. But the first one that we have up is recommendation 1.2, access to psychiatry services. And I should double check with all of the problems we've been I mean, can everyone hear me okay?
Yes.
Okay, sorry about that. So this was a 2020 recommendation, and it came out of, it came up because we know that psychiatry services is a critical, the shortage is a critical problem here in Kansas. But there was appropriate concern amongst the committee, you know, about not wanting to invest more resources into tactics and strategies for recruitment if we don't have an idea if they're working. And so we wanted to have a KDHE study to look at the strategies we're already using in Kansas and see if they're working, if they're being successful. So when we met in 2021, we decided to revise this recommendation to make it more specific as to what we're actually going to look at. And also, we were given some advice that perhaps a legislative post audit would be a more effective means by getting the study done than a KDHE study. So the new language says that we request a legislative post audit, and this is to review Kansas recipients of the National Health Service Corps. So that'd be one recruitment strategy that's already up and running in Kansas, as well as Kansas recipients of the State Loan Repayment Program, which is another tactic that's already being used here in Kansas for the last 10 years. We wanted to look at what professions had been awarded those awards, what communities those individuals practiced in, how long their practice in those communities was financed through those programs, and then whether those individuals continued to work in those programs after they exited those programs. We wanted, because those programs are larger than just psychiatry, they also include social workers, psychologists, and other behavioral health professions. We wanted to expand to include those professions, not just psychiatry. We also would like an exam or an analysis of best practices in other states, including, you know, practices for urban, rural, and frontier communities, which we in Kansas have all three, and the solutions for all three may be different. To see if there were some best practices that give us some guidance on where to invest in the future as we look at our recruitment strategies. Also, in addition, we do have some residency training slots here in Kansas, and we want to look at where our future psychiatrists are training versus where they practice. There's a hypothesis that I think is supported by research that if you want psychiatrists to practice in a certain area, we need to train them in that area. And so that can give us some data to look at to see if the development of more residency slots in Kansas would be a good investment in the future as well. So with those revisions, we gave this an ease of implementation score of 8, potential for high impact of 6. We developed some measuring impacts, percent or number of mental health care professionals participating in the Kansas State Loan Repayment Program, the number of Kansas counties recognized as a mental health shortage area, and the number of adult and child adolescent psychiatric residents in Kansas. So if there's any questions, that is recommendation 1.2.
Committee, are there questions for Dr. Lawrence? Senator Hawk.
Dr. Lawrence, could you clarify, you mentioned this is not just for psychiatry, but it sounds like most of your recommendations are looking at those positions, but you mentioned social workers, psychologists, et cetera. So how does this touch those other professions?
Yes, that's one of the reasons is because the National Health Service Corps and the State Loan Repayment Program is giving awards outside of just the psychiatric profession. They're giving awards to social workers and psychologists in the behavioral health field. Not just.
So to clarify, you're wanting to include those in the post-audit, looking at those other areas?
Correct. I think it also makes sense too, and this is just how rapidly this problem is developing, that, what used to be just, psychiatrist shortage now seems to be expanding across almost the entire behavioral health workforce. So it seemed to make sense to expand the look to other professions in the behavioral health arena as well.
And Madam Chair, I totally agree with that.
So what we can do, Senator Hawk, after we go through all the working group stuff, and I'm making notes here, and I hope everyone else does as well, so if I miss something, is that we come back and revisit this item, because I think it's a good action item for us, and then we'll clarify this language. So just because you see this report, that's not the final language until we decide what it is. That's what came out of the working groups. So the goal in this language was to have everything that we needed for the legislative post-audit. So thank you for that. Any other questions for Dr. Lawrence? Seeing none, pass it, do whatever, whoever's next, I'll let you lead.
Good morning, everybody, and Madam Chair. I'm Charles Bartlett. I'm the Director of Adult Services at ks Behavioral Health Service, and also serve as the liaison to the Governor's Behavioral Health Service Planning Council and all of those subcommittees. And I will try to go through this fairly quickly because I know we're crunching time. What I'm going to talk about now is 1.4 Workforce Investment Plan. This recommendation, the state of Kansas should make a long-term investment plan for behavioral health systems workforce by increasing funding for training, recruitment, retention, and support to effectively attract and retain high-quality staff. The specific steps in new language that we went with this year is the state should establish a university in Kansas to partnership to develop the comprehensive investment plan, including a focus on high school internships, mentorships, and free continuing education courses, building on the model of special committees heard about from what the Nebraska initiatives were. We also recommend that the seed university programs to develop and expand bachelor and graduate programs in behavioral health, that they create a pool of funds for behavioral health providers that could assist to support and retention and recruitment. This goes along with developing a career ladder for clinicians, such as through the development of associate level practitioner roles, and to take action to increase workforce diversity, including diversity related to race, ethnicity, LGBT, and the ability to work with those with limited English proficiency. The rationale for this is that work group highlighted that there's a dire need for investment in behavioral health workforce, requiring immediate steps to long-term action. Behavioral workforce shortages has significantly reduced access to behavioral health services for many across the state, and working group members specifically identified challenges in recruitment and retention as the key to resolving these problems. The work group embraced a grow your own approach in which workforce reflects the diversity of the community. Although working group members noted changes associated with long-term commitments to recruitment and retention, including but not limited to potential high cost creation of new programs and the work of multiple legislative sessions. This recommendations has a high potential for impact. Work group members said many Kansans will benefit from this implementation and recommendations, particularly in our rural and frontier areas where there exist significant shortages of psychiatrists and behavioral health workers, as well as other populations that lack access to behavioral health services. The working group called for a creation of a funding of a Kansas organizational model after the Behavioral Health Education Center of Nebraska, which is known as Beacon at the University of Nebraska, and that group did present to the special committees. The impact here to implement was a 1, potential of high impact was a 9. And so cost may be a barrier to implementation, could involve changes in legislative sessions and federal approval process of agencies' budgets and developments of grant, but it would impact a very large number of the population. The measurements for this would be workforce retention rates, the number of behavioral health providers practicing in Kansas by age, race, and ethnicity, number of students enrolling in post-secondary behavioral health education training, and the number of community colleges offering behavioral health. Lead agency for this would be KDADS. With that, I'm going to turn over to her questions, and if no questions, then I will refer to Jane Hudson for the next issue.
Committee, are there questions for Charles? Senator Fagg.
Thank you, Madam Chairman. With us knowing that there's a shortage, the question I have is how many people do we need in the workforce? How many people are we trying to recruit? Just to kind of get a feel of that. Has any numbers ever been thrown around?
I don't have any numbers as far as where that would be. I know that we do have long wait lists for services, both in the SUD centers and in the community mental health centers. And that our shortage is not just a shortage in Kansas. I serve as the vice president for the National Treatment Network, which is made up of people in similar position to me in all the states and territories. And this is a national crisis and not just a state crisis.
Senator, I think if we were to try to guess out there, I'd say it's in, it's definitely in the hundreds, if not in the thousands.
Thank you.
Representative Lynn.
Thank you, Madam Chair. Do you happen to know if Beacon or another group has any sort of mentoring program that they use for high school students that maybe mentor middle school or other high school students?
I'm not sure that I could answer that question. I know that from the meetings that we did have with Beacon prior to the pandemic, they talked about their efforts in high school and middle schools and the promotion there that help people enter the workforce once they start a career path, but I don't know of their actual programming in Nebraska.
Andy, do you have some info on that, please?
This is Andy Brown with KDADS, and we can provide some additional follow-up with that, but I will say that they sort of have this grow your own model where they go into the high schools and rural areas, get them connected through programming where they present on career ladders and how students can go from a high school degree to junior college at a local college, and then on to remote learning at their universities. So they have 5 universities in the Nebraska state system, I believe, and they're located around different points, but they're all one university. And so in Kansas, it would have to look a little different because we have multiple universities around our state that are part of our system. But I think we've seen good examples of how, like Fort Hays has been able to do expansion for social work training. And I think there's ways that we could link those colleges to the junior colleges so that people are able to get those sort of extra credits that would transfer over to the four-year colleges. And I think that's a big part of the system, is just making sure that we do the in-reach into the communities at the high school level, do our recruitment, make sure that there's an actual path that they can achieve while they're remaining in their community, and then transition that into a four-year degree over time.
Okay, thank you. I just know how important it is for peer mentors, and if we can get them engaged at a younger age, not only would they be able to engage with their peers, but then hopefully develop that interest and love for the for mental health. Thank you.
Committee, are there further questions of Charles? Okay. All right, and Representative Reese, you're going to have to really raise or slide this way a little. Delphi, you'll slide this way a little bit because I don't want to, I'm not trying to miss you, but I don't always turn over this way. So, okay, Charles, thank you very much. And who's up next, Dr. Martins?
Shane Hudson is next.
Thank you, Madam Chair and members of the committee. This is Shane Hudson. I'm the CEO at CKF Addiction Treatment. We provide addiction treatment services and integrated addiction healthcare services across the state of Kansas. I'm reviewing recommendation 1.3, which appears on page 13. It starts at the bottom. There was a focus initially on MAT, medication-assisted treatment, for patients who require that type of medication along with treatment services who are working to manage their addiction, focus on capacity and access, which was really narrowed down to a tighter focus on provider training. Now, above and beyond provider training, when you're speaking of capacity and access, looking at the number of patients getting MAT now in Kansas, which has grown over the last few years, and there was federal funding that really helped with that, the federal opioid response grants and the funding that flows to patients to get that care. There's this need and this gap that gets created as soon as that funding ends between that funding and what comes next. And our discussion was about getting some funding stability in there. How do we keep those patients on medications long-term who need to be on those medications and not drop them from a service when funding ends, getting more funding connected to patients who don't have the ability to pay and who are uninsured. For agencies like CKF who've grown that service and agencies who want to start providing that service, that would also get them interested to provide the service knowing that it's sustainable. For instance, our location has 175 patients on medication-assisted treatment, and we need to continue the patients who are going to be on those medications long-term past the end of that federal funding. Another focus to ensure access to the service is pairing with CCBHCs. So ensuring that the CCBHC model can partner with substance use disorder providers to ensure that access to MAT is available, and those partnerships can help strengthen the model to ensure patients get a really good service from partner organizations. Discussing the requirement for CAN-CARE managed care organizations to report regularly to the Bethel Committee on Home and Community-Based Services, adequacy for MAT services. So the state can also use the CAN-CARE 3.0 contracting process to emphasize the need to expand access and capacity to MAT. And then the last thing mentioned there was the recommendation 1.5 family engagement practices, requiring more funding than initially allocated for implementation. The process ultimately needs to be flexible, simple, and user-friendly to access. Are there any questions?
Committee, are there questions? Senator Alley.
Thank you, Madam Chair. Could you talk a little bit about your success with these MAT programs that you've been working with?
Yes, so first of all, you'll see that very few people with addiction are actually showing up in treatment settings. And when you talk about addiction as a chronic disease and you talk about medications available being paired with counseling, you can compare it to maybe other things such as diabetes and a patient who is taking insulin but also has to manage their diet, so behaviors, thoughts, feelings, all these things along with medication they're taking. So we've created access for patients to get referred from healthcare facilities to take medications for opioid use disorder and alcohol use disorder, along with counseling that's addressing those other layers of addiction and managing the addiction long term. I don't have our current success rates as far as that goes. I know nationally, when you look at addiction, it's about a 50% success rate, and there's reasons for that. There's lack of medications historically in addiction healthcare. There's lack of follow-up care and reimbursement for that. Once a patient is sober long enough, they graduate from a healthcare service that's helping them manage a chronic condition, which doesn't make any sense. So through this service, we're able to work with patients longitudinally. And some patients require the medication and take the medication for a short period of time, let's say 6 months. And some patients may take it for their entire lives as they would other medications for other chronic conditions or other illnesses, and managing that with their physician. So it's helping that brain process for someone who basically the chemical balance, et cetera, and the brain process needs this aid to help them function in a healthy way without having symptoms and criteria met for a substance use disorder or addiction. So we've seen great benefit from that. We've seen our clinic grow from about 30 patients 3-4 years ago to 175 currently, and patients don't stay in our clinic forever. And if they're on the medication long-term, they can actually be transferred to primary care, but we need more primary care partners to help patients manage those conditions long-term.
Thank you.
Thank you. Committee, are there further questions? I have one, and I'm thinking this is going to be for Andy, because they made mention in this recommendation that the CCBHC model will allow to collaborate with our SUD providers. We have that now, don't we? And I guess, would that be correct, Andy? You can shake your head, yes or no, or maybe. Okay, he's going to talk.
Andy Brown with KDADS again. I do think that the CCBHCs, the way that we have our bill, includes the SUD integration as part of the criteria. We do have several CMHCs that already do SUD services. We have several that currently do not and just work with community partners. So the overall integration of the system, I think, is still something that we would recommend we continue to move forward on as a path.
So is there anything that we need to maybe modify in our CCBHC legislation that we passed last year to make sure that this happens? Because obviously this was important to this committee.
So and I'll try to clarify, but the MAT services and the SUD services are part of the criteria that we referenced in the legislation.
All right, I just wanted to make sure. So does that help, Shane, a little bit that we can watch that going forward?
Yeah, so just a clarification that the support for partnering with SUD facilities and the process for that funding mechanism or partnerships is allowable.
And that's how you see this moving forward, Andy?
Yeah, okay. So in CCBHC terminology, a partnering organization that's providing a service is considered a DCO or a designated collaborating organization.
Okay. And I think it's probably something we just kind of keep our eye on and make sure that as we progress forward that we come out of the chute with every tool in our toolbox. All right. Senator Hawk.
Madam Chair, just a clarification. So there's no red in this, in the report. Does that mean nothing really new?
Carrie.
Or?
Carrie Bruffett with KHI. So this issue was talked about by the Services and Workforce Working Group, but there was not a separate recommendation or revision, but the working group wanted these concerns noted in the report. So that's why they're included.
Gotcha. Thank you.
Are there further questions? All right, so I think what we take from this is the only thing out of 1.3 would be to make sure that the data from the MAT training gets reported to the CanCare oversight. I think that's our action item out of that. All right. What do we got next, Dr. Warrens?
Okay, Will Warren's back here again, Madam Chair, and I think if I'm reading this correctly, we are up to recommendation 2.4, suicide prevention. So in this recommendation, we drew heavily on the existing 2021 to 2025 Kansas Suicide Prevention Plan.
Dr. Warrens, and because you're the first one out of the chute, you get the instructions, is if everyone will not only give us like you did the 2.4, but what page that's on, that will help all of us to shift gears real quick.
Okay, sorry, Madam Chair. I have it on page 16.
Well, we all have it on page 16, so we're good. Okay. Thank you.
Okay. So a lot of work has already been done on this topic, and so our recommendation, we tried to figure out how to best support. There were many different recommendations in the Kansas Suicide Prevention Plan. Some of those have already been accomplished, but we felt when we looked over the Suicide Prevention Plan that two recommendations that could boost it forward more substantially would be to the first, to improve the data that Kansas is collecting on individuals that have completed suicide. So improving suicide data, making suicide a reportable condition, and proposing policy to ensure consistent data collection across the state, including for diverse populations. And one of the reasons why we mentioned diverse populations here is the data does show that diverse populations are hit disproportionately sometimes when it comes to suicide. And diverse populations, can be minority status, but it also can be age, gender, and geographic location. We also wanted to, let's see here. We also wanted to designate KDADS, the single state authority for federal mental health and substance use disorder programs, as the lead agency for the implementation of the state suicide prevention plan. Even though they would be the lead agency, the expectation would be that they collaborate heavily with the Youth Suicide Prevention Coordinator in the Office of the Attorney General. And then to help provide some scaffolding for the work on suicide prevention, adding $1.5 million to KDAD's budget to implement additional recommendations and strategies from the state suicide prevention plan, including $250,000 for the coalition and $90,000 for a full-time state suicide prevention coordinator. So this coordinator would be population-wide, so all ages, all individuals, not just youth. And the remainder for providing grant opportunities for local communities to pilot and spearhead local ways of addressing suicide prevention, as well as implementing a statewide media campaign. We also wanted to require KDAD submit an annual report on the status of their work to the Governor's Behavioral Health Services Planning Council and its prevention subcommittee. Let's see if we scroll down further. So there has been talk, I believe, in other committees that one potential funding source for this would be the telecommunications surcharge. That's not something this working group made up. I think this is something that's actually being discussed. Ease of implementation was considered a 5. Potential for high impact was considered a 10. And then we have some measuring impact measures, age-adjusted mortality for suicide, and some other measures that you can read down there at the bottom of the page. So if there's any questions, that's what we had for this recommendation.
Committee questions, Senator Alley.
Thank you, Madam Chair. Has there been coordination with the Attorney General's office in this new position and a new, basically, suicide prevention plan under KDADS versus what they are doing with the Attorney General's office?
I guess the best way to respond to that is that we know the importance of that, and that's why we put language in there saying that that's the expectation. I don't know. I guess I can defer to Andy Brown and others as whether there's already been some coordination ongoing.
Dr. Warrens, we'll have Andy step up, and that's one of the things that, Senator, we have to kind of resolve as we move through this process. We've got all these little in different agencies. Where do we bring that together? So that's an excellent question.
The main concern that I had on that, are we duplicating services here, having one with the Attorney General's office and one with KDADS?
So Andy Brown with KDADS again, and no, Senator, I don't think we're duplicating. So the KDADS has been part of an interagency suicide prevention work group that includes the Attorney General's Office, KDHE, Kansas Department of Corrections, and the Department for State Education, right? So there's a lot of agencies that are involved in suicide prevention, especially around youth. And so I think there is continued value for the Attorney General's office to work on the youth issues that they're addressing, but we also need to work on lifespan. The majority of people that die by suicide in Kansas are not youth. The majority are in an older age category between 35 and about 55-ish. And we want to try to coalesce our efforts and provide infrastructure. And one of the challenges that I think we've had is, right now, a lot of the funding that comes into the state for suicide prevention is really just federal grant opportunities. And so when an agency isn't resourced to respond to that, the result is that those funds end up in different places. And then we're working hard to coordinate all of that, but it'd be a lot simpler if we had one state coordinator that was responsible for the overall state plan.
And so you're recommending that KDOTS be that overall, and has that been agreed to by the Attorney General's office is the question?
Yeah. So I believe the answer is yes.
You believe? Thank you.
Yeah.
You might remember, nothing's in stone in this process. So one of the things that was a mission for this committee was to reduce the fragmentation that we have with having the same thing or similar things or look-alike things in all different committees, and how do we bring them back together to work? So we're not going to leave any one group out on this. But because of the work that's done on the suicide side within KDADS, and I didn't realize how deep it was till I got involved with the CCBHC stuff.
Yeah. And I'll point out that, the reason I said believe, Senator, is because we worked very closely with Attorney General's office while Gina Meyer Hummel was in that position. She recently stepped down from that, and they've yet to identify their new state coordinator.
Any further questions, Senator? Okay. Senator Hawk.
Thank you, Madam Chair. Just a couple quick questions. And I think one of the issues we have in this area, and I agree with Senator Alley, is we get this in a lot of different agencies, and then we have the problem of trying to coordinate it. But is not the Attorney General more focused on youth suicide and social media as the way they're addressing that? I still think while there might be grant opportunities, and I hadn't thought about that might flow more easily to the Attorney General, I still think we want to make sure that we don't duplicate, and it has never made sense to me that we would have two efforts going on in two separate agencies when you could be more efficient and more effective. So we may be stuck with funding and opportunities, but I would hope that ultimately we'd try and get it under one umbrella that would make more sense, that could really coordinate it. So, and I think we're kind of heading that way, but it will probably forever bother me that we've got one effort going in the Attorney General's office and another major effort going in KDADS.
Right. Well, and I think what we've learned as we go through this process is that what's happening in each different agency that may have what appears to be a duplication is they're pulling different types of information. So having a coordinator for all of that, probably makes sense. It's kind of like when we look at, our data vital statistics. What is mined is incredible, but it doesn't necessarily mean that we have it where it's in a understandable, usable, good report. Are we using all the data to its fullest extent? That's something we've struggled with for years. So, Representative Arnberger.
Thank you, Madam Chair. I'm glad that my name was written down by the ranking.
One for Barbara.
Hey, I have a couple questions. One, did we ever, I think it was last meeting, I asked a question to Revisor Scott Abbott. Is he on WebEx?
No, he's with Sunshine, not us.
Oh, okay.
But we have Eileen here.
So I asked the question of, is it written in statute about the Attorney General having the coordinator and the funding to go with it? And he looked it up, and I thought he said yes, but he didn't announce it to the whole group. Does that ring a bell, or I don't know if,
Okay. Well, why don't you just ask the question of Eileen, and Eileen
Okay.
can research it, and we can come back to it. Are
Okay,
you good,
so-
Eileen, with her question? And just come back whenever.
Okay,
Okay,
so-
we'll come back around to it.
So then, my question is, if it's written in statute in that they were supposed to be funding the Attorney General, Attorney General's office, what happens if KDADS is the lead and then there's some disagreements with the Attorney General? Does KDADS dictate how Attorney General office has to spend their money? No? Okay, because that was my concern, is if there is some disagreements on how to utilize that money. And then second, I believe that we put in funding for the Attorney General's office to create an app. So then, are they the only one who gets to utilize that app? Can it go over to KDADS? And how is that app going to be utilized, not just for youth, but for every Kansan?
Do you know that one, Andy?
Yeah, I'm walking a delicate line here because I'm talking about stuff with the Attorney General's office, but, so currently what the plan is with the application is that the Attorney General's office is still pursuing that. But we are, I mean, that's intended to be an app that serves the entire state, right? So the data that comes from it would be shared as part of our interagency coordinating meeting that we have on a regular basis. So we wouldn't have direct access to the application or the back end of it. That would all be done through the Attorney General's contractor.
Okay. And then the last question I have is it in the recommendation? If it is, maybe I just don't see it, with the fee on the telecommunications? Is it in the recommendation, or they just discussed it in the working group and it's not written in here?
I'm sorry, I was talking to the revisor. What was your question again?
About the fee on the telecommunications, they discussed it to fund suicide prevention. Is it in the recommendation, or they just discussed it in the working group?
I believe, and Carrie or Hina can probably answer, I think it was more of a discussion, because there's also an issue, and Andy, you can nod or whatever, is what the fee in the 988 legislation can be used for. And it's our understanding, meaning myself and I believe the agency, that money has to be used for services for anyone that calls that 988 line. It's not for services of what we have currently out there. So if a person calls that 988 hotline, they have to receive services, and that's what that money pays for. It also pays for follow-up on anybody that calls that 988 to make sure that they actually did get services, and if they didn't, why not?
So can it not be duplicated in the same language as 911? For how the fee has to be utilized?
The feds, and Andy, I'm probably stepping over and out of an area that I don't belong in either, but we've had to, between the telecoms and working with our feds, it's been, the telecoms don't believe that we can use any of that money for services. When we talk to the federal government and we read the federal language, we're convinced that it's a black and white issue, that we will provide services. So as we've talked about it, like we did last year in the Health and Human Services Committee, and the sheet that Andy had broke out, how much does 50 cents raise, here's where the money will go, that's what we're projecting type of a deal. The telecoms were in disagreement. I can tell you, out of the 3 big telecoms, 2 of them have come to the table and are willing to negotiate. We only have 1 holdout right now.
Okay. The reason I ask is I was looking at our business Cox bill, and it's 90 cents that we pay to 911. And so, and it's a flat fee. So that's why I was curious, if we're already doing it, can we not just duplicate that language? Because I don't know what exactly 911 they are allowed to do and not allowed to do, I guess, to kind of go in your realm of the 988?
911's, a totally different animal in this process. This here becomes kind of unique.
Okay.
And I agree with you, because in 2019, I may have my dates wrong, but I believe it was 2019, that this legislature passed out a 41-cent increase for 911 for infrastructure, and nobody batted an eye.
Right. Can I get you on record that you agree with me?
No. That's not going to happen, Representative Arnberger.
Andy, do you have anything to add to our discussion that we?
He wants to know if I misspoke, is what she's saying, Andy.
Well, what I would say is that we do have an active 988 bill in the House that's in committee. And so there'll be lots of opportunity during the session to debate the bill and look at language that's in it. And I'm sure we'll be able to present multiple times during the session about how the funds may or may not be used. But ultimately, that decision's up to the legislature. So I feel like we're sort of hedging our bets. We're trying to make sure that there's funding that's going to be available for this through multiple sources. And the 988 bill, I feel like, is a valid one. But the legislature might not end up deciding that that's the case.
Okay, thank you.
All right, and I believe that Eileen Maw does have an answer to your Scott Abbott question, and then we're going to go to Representative Ballard.
Thank you, Madam Chair. First, I want to send kudos out to my colleague Arida, because the email that Scott sent me said that Arida had notes from a previous meeting that referenced Representative Arnberger's request to the committee. So Scott had sent me an email saying that Representative Arnberger had made the request and Scott had followed up with her, but had neglected to follow up with the committee. He provided a memo, which is in your packet. So if you flip towards the back of your packet, that is his answer to the inquiry.
Representative Ballard.
I was going to ask a question about that, but you clarified it for me anyway. But I think where I'm a little confused right now is that the Attorney General's office has the responsibility of appointing someone, a coordinator of the suicide prevention program. But KDADS is not in statute that they even have to deal with that topic, like appoint someone. Am I correct?
Representative Ballard, this is Andy Brown again with KDADS. And so KDADS has a federal role in suicide prevention. We have the state suicide prevention coordinator role at the national level for the state of Kansas. So that has traditionally been filled not by an FTE position, but rather by just assigning a person to be responsible for that. Which has created, I think, a lot of lack of infrastructure and resources to deal with it. And I'm sorry, I'm a little emotional about it, but the reality is that when we're working with the National Suicide Prevention Resource Center, it's KDADS and SAMHSA, and the role that KDADS has with SAMHSA is the state mental health authority at the federal level. So, I mean, we work with every agency across the state on suicide prevention issues. I don't want you guys to feel like this is a territory issue. It really is about just trying to streamline things so that there is an agency that's responsible for tracking things and reporting to the legislature about it.
Thank you. Madam Chair, I can appreciate that because I'm sensing that that's part of the problem. It's like, okay, so one department is being designated as having to do it, but on the other hand, there are services within KDADS that really says that they should be doing the suicide prevention, but yet you're not designated. And I think earlier the question was asked, is it a duplication of services? So I understand why the senator was asking, is there a duplicate of services? But they serve different functions. And I think that's what we need to make sure that we identify that what the functions are that KDADS would be doing versus the Attorney General in terms of enforcing or maybe doing a combination. And that's where I just want to make sure that we get a better understanding that suicide around the state is such a large issue that more than one of our organizations and services should be provided by maybe multiples to a certain degree, as long as we identify why we are in that process. Does that make sense?
Absolutely. And I'll follow up and just say that, like, the Attorney General's, like, realm of influence over this is derived from the Child Death Review Board, which is another part of their statutory responsibility. KDHE works on it through their vital death and review statistics for NVDRS and vital statistics, and as a public health issue. And KDADS obviously is interested in the intervention, prevention, and treatment that will ultimately help us with suicide prevention. So, I mean, all the agencies have a role, and I don't want you to feel like we're trying to take that role away from anybody. All we're trying to do is help coordinate the state plan, which all of the agencies were involved in drafting.
Thank you, and I can appreciate that. And Madam Chair, maybe it's up to us as a committee to make sure that we clearly define, to as much as we can, that it's not territorial. It's more in terms of how effective this program can be if we're working together on it without someone saying, well, no, this is my domain, because I think the functions are very different. And in the process of backing off, then we have Kansans that are going to suffer as a result. Thank you, Madam Chair. Thank you, Mr. Brown.
All right, thank you. Dr. Warrens, back to you.
I believe I am handing off now to Shane Hudson for recommendation 3.2. And that's on page 18.
Madam Chair, members of the committee, Shane Hudson, CKF Addiction Treatment, and yes, 3.3 foster homes on the bottom of page 18. The previous or original language around the recommendation was focused on training and support, so increasing funding for supplemental training on behavioral health needs around kids going in through foster homes have serious emotional disturbance, or SED. And during the discussion this time around, there was a focus on ways to improve systems to support foster families. And in some communications with our group and DCF, some additional recommendations are noted there in red, which would be supporting families navigating child welfare and Medicaid programs, continuing investment in recruiting, preparing, and supporting families to serve high acuity and older youth, and in recruiting, preparing, retaining, and supporting African American families, providing in-home therapeutic parenting services for families to meet high acuity needs, and ensuring services are available across the continuum of care for youth discharged from inpatient or psychiatric residential treatment facility settings, or PRTF. The ease of implementation went up a little bit as we looked at systems, but we thought that these are very important recommendations to add. So it's a 5 under ease of implementation. Potential for high impact was rated as a 7. And then we've got some measuring impact marks there with placement stability rates to be focused on for children entering care, and also percent or number of foster youth on the SED waiver. I'm definitely not a content expert in this area, but I know we have someone on the line who participated in our group who could probably answer questions as they come up.
Committee, questions for Shane? Senator Hawk, I believe you had your hand up earlier. Do we need to go back?
I had a question on suicide prevention funding, and I'm sure it will come up again.
Okay, it will. It will. All right. Seeing no questions, thank you, Shane. Appreciate it.
And I will go on to the next recommendation on page 19. It starts at the bottom. It's 3.4, community-based liaison. And the focus there was looking at kind of those gap filling services as reentry is occurring and pre-release planning, that there is someone who can engage with individuals as they're coming out of the criminal justice system and engaging in community services. And really, as a discussion about fee for service was brought up, and then the discussion around CCBHCs and that model, it was just looking at ensuring that we could expand locations where community-based liaisons are available to help connect individuals to treatment and support services throughout the community. So the addition with the modified language that we could support expanding the availability of the service to other geographic locations and provider types would support that process, including SUD providers.
Committee questions? All right, seeing none, thank you. Next.
This is Charles Bartlett again. The next one is on page 20, and it's a new and a recommendation regarding 4.5 trauma-informed care. Our new recommendation in looking at trauma-informed care in the state is that under the auspice of the Governor's Behavioral Health Service Planning Council, we would convene a work group of providers who have implemented trauma-informed practices to make recommendations for a pilot program or other initiatives to expand trauma practices statewide. We saw this as launching a pilot project with select behavioral health providers who would increase the understanding and adoption of trauma-informed practices. We would be able to take the lessons learned from the pilot and existing programs to look at strategies statewide. All KDAD's funded agencies would be trained with the basics of trauma-informed care upon hire with new annual updates, and that also would create common language across agencies and communities in Kansas to think about trauma-informed approaches in all aspects of care. As far as implementation, I have already met with the subcommittee of evidence-based practice under the council, which would take the lead on organizing the pilot group. They were to look at providing the language that has come from these recommendations into a charter that they will present and how they're going to organize that group and what they're going to do, and present that to the council in the first quarter of the 2022 for approval on that process, and then move forward with a work group that would be membership of current providers with implementing trauma-informed programs, other providers in the state, and recommendations also from programs that have started at the state hospitals, and also include persons with lived experience that have received services in the state to make those recommendations.
Committee questions? I've got one for you as I'm looking at the measuring the impact, and it talks about establishment of a work group in the first quarter. What was the discussion around? Who's this work group? What were the thoughts on who would be included?
That is the work group that would be commanded through the evidence-based practice subcommittee, and would include current providers that have worked on their system of trauma-informed care within their agencies, and then recommendations for other agencies across the state to be participant in that from both SUD, mental health, and other services, as well as to bring in some consumers who have experienced the services and also experienced services in those agencies that are trauma-informed.
All right, thank you. Committee, further questions? All right, seeing none, thank you, Charles. Dr. Warrens?
I think the next one is also under my recommendations.
Oh, okay.
Chairwoman. And this begins on page 21, and it is prevention and education recommendation 4.6, promoting social isolation as a public health issue. This recommendation would create strategies to disseminate the importance of social isolation as a public health issue using social media and media campaigns, education providers, and encourage adoption of a screening tool. This special committee discussions on social isolation, particularly as experienced by older adults, people of color, and people in rural residents, both before and during the pandemic, and a working group received materials related to social isolation and its linked to this as a serious health condition. The recommendations would include treat social isolation similar to other public issues, and then create strategies to disseminate the importance of social isolation on health throughout public service announcements. And also we would make available open conversations about loneliness and its importance in physical health, mental health, and the potential for suicide. Some existing screening tools that we have identified, and that we would look at how the process of utilizing these screening tools along with a media campaign would help to make the recognition of these social isolation issues a public health issue, as well as to incorporate ways that people can link to existing ways that they can have that social interaction. This cost may be a barrier to implementation. We require creation of a pilot program or new programs over several years, but the impact could be very great. Its benefits for a large population, general public would be included, and people of adults, older adults, people of color, and lower income families would certainly benefit greatly from this. So it has a high potential for cost savings to the general public in the long run. And so we would also, in doing this, we'd look at the number of adapters of the screening tool, and also the hopefully reduction in suicide rates because of increased social interaction. And we have enough questions.
Committee, are there questions? All right, seeing none, proceed.
Okay, again, the next area that I'm going to cover is on page 22. Again, this is prevention and education recommendation, and that is that of normalizing behavioral health discussions. What we are recommending is, in lieu of discussing stigma, build on the recent success stories such as 988 Lifeline, Mobile Crisis, CCBHCs, to publicize behavioral health as health, creating a culture in which mentions of depression, anxiety, post-trauma, addiction, and other common illnesses become as mentionable as diabetes, heart disease, and migraines. And with this, our recommendations of the special committee would be to raise the issue of stigma related to mental health and addictions as its impact on access of behavioral health services. The working group provided a select national materials about stigma. The members proposed two distinct recommendations. One is to publicize helplines to encourage people to get help before they're actually suicidal or in crisis, and increase access to therapy and medications for the uninsured. And second, to talk about mental health, not stigma, but to create a culture in which mention of depression, anxiety, post-trauma, and other common illnesses become as mentionable as diabetes, hypertension, and migraines. Their survey revealed that the support for both of these concepts, and the working group co-chairs proposed combining them cultural appropriate outreach campaigns, including social media campaigns and public service announcements. And again, cost would be a barrier here. It may require some program changes, but it has a high potential, again, for large populations, particularly those in foster care, rural and urban communities, and those with limited English proficiency and low-income individuals. And probably create cost savings for both general public and the safety net programs. And I would stand for questions.
Committee, are there questions? Representative Ballard.
Thank you, Madam Chair. Mr. Bartley, when I'm looking at the potential for high impact, I see we have an 8. But by taking a different format, instead of just addressing stigma, you're using more the success model as stories, but yet we know stigma is still a big. Did you think of that in terms of a 9 or a 10 in terms of the impact? I only mention that because I think in terms of what we have seen recently with athletes, especially if we think about Biles and some of the football players and all the others in terms of it's very public about their mental state, that I think the more we talk about it, it's a higher impact. Could you comment on that, please?
I certainly agree with you. I think that it's just like when people used to not talk about cancer, but now it becomes part of the conversation, and it has changed the stigma of cancer to that as a health issue that people have to be aware of. I think I'm going to give an example of a similar campaign that occurred in Kansas and across the nation, and that was teaching people how to use recovery language to talk about their recovery and substance use disorder, where they began, instead of not talking about their disorder and their recovery, but to publicize it by making introduction as I'm a person in long-term recovery and what that means to me, and as a result of that, how it affected my life. And now you see people introducing themselves that way often as they begin to talk on substance use disorders and recovery. And I think we can have the similar thing when it comes to mental health issues, as we start to really look at the issue as a public health issue, and that recovery is a probability when a person takes those measures, dealing with it like a health issue. So I think that those people in our population, such as former Senator Kennedy and others who have, Representative Kennedy, who made knowledge of their own problems that they've had with mental health or abuse and their recovery, it normalizes those issues as a health issue, and then it can be talked about. And I'm going to say that this can really change the whole concept of people seeking help, because then they know that they're no different than going to their doctor because they're having chest pains.
Okay. Thank you. Thank you, Madam Chair.
Further questions? Senator Alley.
If you will, Madam Chair, I'd like to go back to 4.6, and that was the promoting social isolation as a public health issue. Are we seeing this as an increase as a result of what happened in our nursing homes, where they're locking down patients and not having visitors for 2 years? Is this increase because of that?
If I don't know that I can say that it's a direct result of any one thing. I think that it has been a systemic issue across our system, and with the pandemic certainly made that worse. And I think, again, that goes to the recognition of the importance of peer-to-peer supports and the abilities to involve families and communities in our social interaction as a place of belonging and our own self-worth.
Do you believe that, obviously there was an issue in our nursing homes when they couldn't see their loved ones, and I do think it caused a mental health issue. And so are we taking that in consideration for any public policies we may use when the next pandemic comes, when the next issue comes? I think that was a big issue in our nursing homes. I've had several people that have told us about those issues with their parents. And I believe that brought it up. So thank you.
Well, and keep in mind,
Thank you.
I'm not a clinical person here, but the social isolation has been an issue that we've watched increase over the years, just kind of a slow creep. And everything that occurred with the COVID 2020 has exacerbated the social isolation issue. And people that have never dealt with it before are dealing with it today. I think if we were able to actually get into talking to individuals that have not gone back to the workforce, we'd get some social isolation answers on why they're not back yet. So it's been there forever. It's just exacerbated now. So there's been a lot of negatives with COVID, but there's also been positive. It's highlighted some things that have needed to be highlighted. It's advanced some things that wouldn't have advanced as quickly without it. That helps. Yeah, COVID kind of brought it to light for us, is what it did. Representative Lynn?
Thank you, Madam Chair. I'm looking at 4.7 and 4.6 almost together, and it looks like both of them, the ease of implementation is pretty low, I think mostly due to the cost. And I'm wondering if this is a good opportunity for us to kind of come together and partner with private organizations as well as different influencers who might be able to help us be a voice that people could recognize, whether they're athletes, social media stars, YouTubers, that I'm thinking about my kids, where maybe this shouldn't be as difficult as we think it could be if we can just partner with people who have those lived experiences that might be able to come with us and do something so that maybe we aren't looking to just do this all on our own when it comes to cost.
Well, we're reaching out to our communities. It's as we have the discussion about the, regional facility, it's not, that shouldn't be just a state responsibility. That needs to be a community responsibility, whether it's the counties or the cities, the surrounding counties, the community city. So, people have to keep, kind of the direction that we're taking on things is let's get stuff back to our community. The state can be a partner, but the state isn't the answer for everything. Senator Erickson.
Thank you, Madam Chair. An observation. I find it a little bit ironic in my mind that we're talking about in 4.6 social isolation and social media as one of the tools to help alleviate that, when in my mind, social media is one of the causes of social isolation. We need to put down social media and gather face to face. And so I just find it kind of interesting that that's seen as one of the solutions when I think that's probably exacerbating the problem. Thank you, Madam Chair.
Further questions? Representative Ballard, last time.
Thank you, Madam Chair. It's not so much a question, but something that I learned about a month ago that I wanted to respond to what you said about nursing homes. I visited with our nursing home, and they informed me that because families could not come in and see them, but they had been vaccinated, they could visit with each other, and the people that had family that came became more empathetic for that group of people that never had anyone come and see them. And because they felt for the first time that isolation that they had never felt before, they became very empathetic with the other people in the nursing home that didn't have visitors and began to visit more with each other. And they said, had it not been for the fact that they didn't have their people coming on a regular basis, they wouldn't have thought or empathized with how those other people felt, either because families lived out of state or they didn't have anyone else to see about them. And I hadn't really thought about that, but they have built a different community as a result of that. So I think there's always maybe a positive to what the negative impacts were. And they were very proud of themselves that now they've become more of a family unit. And I thought, that's interesting. But I just wanted to share that because I found that pretty inspiring, that they were now turning to each other instead of just the visitors or their families or their loved ones. Thank you, Madam Chair, and I'm sure I will have other questions.
You had a statement, so you're safe. Are there further questions, committee? All right, seeing none, let's proceed. Dr. Warrens, are you there?
On mute.
Up.
I'm sorry. This is Charles Bartlett again, and I will again present on the next issue, and this is on page 24, and this is Prevention and Education Recommendation 4.4, Behavioral Health Prevention Revised. The revised language to add to this is that increased state funding for behavioral health prevention efforts to support additional evidence-based primary prevention and grant opportunities for community prevention activities. And this rationale for revision is that the original language of the recommendation, which was to increase state funds for behavioral health prevention, substance abuse disorders, and prevention, suicide prevention, was considered very broad by some working group members. And they thought that we should be more concise. And so the working group asked KDADS for suggested language that would highlight how the recommendations could support. And the recommendations to support with this additional language is to look at how new funding could increase evidence-based prevention by providing grant opportunities for our community coalitions to implement these prevention activities within the communities that receive grants for those coalitions to stand up these projects in. And with that, I would stand for any questions.
Committee, are there questions on this? All right, seeing none. Next.
Okay.
Okay.
Next is to Dr. Warrens.
All right, thanks, Charlie. Thanks, Madam Chair. So we are a little bit further down on page 24 now, recommendation 5.3, frontline capacity. So back in recommendation 1.2, we were talking about how to recruit providers. This recommendation is how to spread behavioral health knowledge amongst providers. So fully fund a statewide psychiatric access program that includes linked specialty teams and high levels of expertise. So the thought behind this is that regardless of your specialty, primary care providers provide a form in which they can access how behavioral health specialists are making their decisions and maybe pick up some skills to help improve their treatment of mental illness. I think one of the thoughts is that for mild to moderate symptoms, hope to increase the pediatricians, internal medicine doctors, OBGYNs, family practitioners to be able to treat, when they're comfortable, treat more of those conditions themselves if they're able. And so we do have two programs here in Kansas that we've highlighted, Kansas Connecting Communities and Kansas Kids Map. And we do have some experts online, which we may need to get additional information from them, Kelsey Torres and Dr. Rachel Brown. But those programs only have funding, I believe, into 2023. And so we have in our recommendation to ensure continuation of the current program starting July 2023, fiscal year 2024. And then on top of that, to expand those programs so they could work towards getting to more of the entirety of the behavioral health population, as opposed to just postpartum or just children. So down under ease of implementation, which we have as a 5, there's an estimate that 1.18 million will be needed eventually to continue those programs as is. And then there's some additional costs to expand those populations to include autism, IDD individuals, and then also to include adults with mood disorders. And those numbers are down there in the ease of implementation box. We have ease of implementation 5 and potential for high impact 6. And then we have some measuring impacts that we've developed. And the lead agency is KDHE. I think that's designated that way because that's who it is right now. And then also key collaborators, KU School of Medicine, which is what it is right now. So I stand for any questions on that recommendation.
Okay, before I open it up to questions, I'm going to go to our staff with KLRD, Connor, because he was staffing the Care Oversight Committee, and there were some of these things that were mentioned here that were addressed yesterday. Would you have those that you could share with our committee, and maybe we can say, all right, these are things that we can start looking at action on, and if you don't have them readily available now, we can have them for this afternoon when we go into discussion. Is that good? All right, because some of these were already discussed. Committee, are there further questions? So Dr. Warrens, you'll be happy to know that we'll be discussing at least 1 or 2 of these items this afternoon. So that was in this. Please proceed.
Very good, Madam Chair. I'm handing over to Shane Hudson again for recommendation 6.6 at the bottom of page 25.
Madam Chair, members of the committee, correct, page 25, it's the 6.6 Medicaid postpartum coverage recommendation, and the request that the Bethel Home and Community-Based Services and Care Oversight Committee review extending the Medicaid postpartum coverage period to 12 months. And our group spoke a lot about the benefits to the mother and the child when this is extended to a 12-month period. During COVID-19, through this process, there was a temporary move to extend it past the 60 days that Kansas would usually allow, and their support for the 12-month period to be covered for mother to access the right services as she's in the postpartum period. The ease of implementation score was put at a 10. The potential for high impact, a 9, and the measuring impact, maternal and morbidity rates, with the action lead on the legislature and key collaborators with KDH&E. I do have a couple of people from our group on the line who can assist with questions on this.
Carrie?
Madam Chair, just a point of clarification too. I think in this report, there's a reference to a cost estimate of $10.5 million, and it's listed as SGF. What I heard yesterday in the Bethel Committee is that's $10.5 million all funds, if I recall correctly. So we can get that corrected in the report.
So staff, we need to make sure we make that adjustment. So we break that out. Let me make that a note so I don't forget. Questions, committee? Senator Erickson.
Thank you, Madam Chair. Was that 10, if I remember correctly, 10.5 all funds and about, was it 4 million SGF?
No, 10.5 off, yeah, so SGF would be around 4,
Okay.
4.5. Because you can, even though the numbers, the real numbers are a little less than 60%, we kind of do a 60-40 when it comes to Medicaid dollars.
Okay, just wanted to verify.
So you can do 60-40 and be pretty close.
Thank you, Madam Chair.
Are there further questions? Seeing none, let's proceed.
Okay, this is Dr. Warrens, and I believe this is our last topic that we're talking about, and this is just some extra language that is in the report. So the 2020 strategic framework included recommendation to expand the Medicaid waiver for individuals with intellectual and developmental disabilities, and a specific interest in addressing the autism waiver. And when the working group looked into that, it appears that there is work just starting on those efforts, and that is in the autism task team, and that report is due in January 2022. So
where are you at, Dr. Warrens?
Oh, sorry. Page 26.
Right.
Bottom of page 26.
Thank you.
under special populations related activities. And so this is language only. This is not a recommendation or anything like that. This is just referencing the Autism Task Team's work and to keep an eye on that. And then also, in addition, this, in similar fashion, the Governor's Commission on Racial Equity and Justice, whose recommendations are either just about to come out or just came out, just referencing that group's work.
All right, questions, committee? All right. Oh, Senator Hawk.
Just a quick question. Do you know how many children are identified with autism and are either not served or underserved? Did your group look at the scope of that issue?
No, we did not, Senator.
Okay. I'm curious about that. I don't know that we know that, but.
Well, and I can tell you that in discussion yesterday, and Connor's going to have to help me with this, but we had some discussion on the autism and needing more. I think it was, well, anyway, let's have Connor pull the stuff from the discussion yesterday, and then that will help us in our discussion. How's that? All right, Carrie?
Madam Chair, Carrie Bruffett with KHI. A couple points on the autism task team. One is that task team was convened by KDADS, was a report to KDADS, not a report to like a legislative committee. So that's just a note for the committee, so that if you're expecting that to show up in this committee or others, and that actually goes to KDADS. And then the second note is that there was some data that the autism task team has talked about related to underserved youth that are diagnosed. I think it's from 3 years ago. We could make that available afterwards as well.
All right, thank you. Further questions? All right, seeing none, please proceed.
And I believe that concludes our working group's presentations, Madam Chair.
All right. I will make the committee aware, obviously, we're about an hour behind of where we had planned to be, but these questions are really good. And I don't know if I have informed the entire committee. We will have a working lunch, so lunch is being brought in. We can thank Kyle Kessler with our CMHCs for that. And then we are going to try to possibly work late to see if we can finish up this report today so that we do not have to do tomorrow. So if you've got plans and you can shift those, it would be greatly appreciated, because even if we had to go till 7 or whatever, my preference would be to wrap it up tonight and not have tomorrow to deal with. So Senator McGinn, I'm sorry.
Thank you, Madam Chair. And I just, before we shift and go to the next topic, I stuck on, and I think Andy left, but when he talked about the suicides being the majority of 35 to 50, I was just curious, and looking at page 10, which doesn't tell all the story there either, but do we know of those people 35 to 50, how many have insurance and how many don't? Is there a way that we can, because I'm also looking at this integrated care team, and I look at Sedgwick County, and I know the district quite well. I used to represent that in local government. And looking at the high call distribution, high call, and then hearing that number, and I was just curious about insurance.
You know, I think one thing we could do is look back to the report that I think KDHE epidemiologists were presented early on to the special committee. It had several factors that it was reported on related to suicide. And so we might go back and revisit that. I really just don't recall off the top of my head if it included insurance status, but we can check and confirm.
Okay. Thank you. Thank you, Madam Chair.
And Andy will be back. He let me know that he had another meeting he had to attend today, but he'll be back, especially when we go into recommendations. So any questions that you don't get answered, you may have those available. Okay, Carrie.
Well, speaking of Kyle Kessler, not only is it sounds like he's going to be feeding the committee, he's also going to be presenting the system capacity and transformation recommendations. And so, Kyle, I'll hand it off to you.
All right, and Kyle, I think what I'm going to do here is we'll get through all of the presenters unless there's just like a really aching question on each one of the issues. And we'll take questions at the end.
Okay, sounds good. Thank you, Madam Chair. Thank you, members of the committee. Thank you, Carrie. And it's our pleasure to buy lunch. If I could buy everyone lunch before I talk, it feels like the least I could do. I think that when we look at page 14, recommendation 2.6, and I should say Laura Brake with KDADS was the other co-chair on this working group for system capacity and transformation, along with myself, and we appreciate the opportunity to serve in those roles. The first item being 2.6, expanding mental health intervention team program. That was a new recommendation. What I will do is hit on the recommendation and a couple of the key points. Rationale is pretty long, and then get into some additional data that I had found in the last couple of days that might be of interest to the committee, and then continue on unless there are pressing questions. But the recommendation was to expand the mental health intervention team grant program to additional school districts, support continuity, and provide a way for students to access services when schools are not open by extending the times of services at schools, utilizing CMHCs or other mental health providers. Some of the points that were made were that working group members called for future investigation into a long-term plan for the program, including the possibility of incorporating the mental health intervention team program into the school finance formula for future sustainability. And then in the short term, working group members recommended expanding the pilot program to other school districts interested in participating. A couple of interesting statistics that came out of the State Department of Education were, as it relates to the current number of participating districts, it started with 9 in the 2018-2019 school year, and now just in its third year, we're at 55. So it has more than quintupled. And then the total number of students served has gone from a little over 1,700 to a little over 4,700, so a little over 2.5 times increase. Number of foster students served, which was also one of the priorities of the program when it was commenced, what is a little over 200 in its first year, and now in its third year is not quite 600. So we've not quite tripled the number of foster students who are served by that program, which I think is very exciting. Outcomes that have continued to improve or be very strong. I will go ahead and go into the ease of implementation and potential for high impact, if that's all right. The ease of implementation was seen as a 7. Cost being a barrier to implementation, although schools could participate financially in the cost of the building liaison. Also, it would require an expansion to the pre-existing pilot program in the short term. Long-term implementation will require more resources, certainly. And then the potential for high impact was a 9, because it would impact foster children, rural communities, urban communities, limited English proficient persons, low-income individuals, children and students, serve those disproportionately affected. The two measuring impacts, as I've kind of alluded to already, number of school districts participating in the mental health intervention team program, as well as the data elements currently collected by the State Department of Education for mental health intervention team participants. That includes attendance, academic performance, and behavior. One of the interesting notes that I saw was related to the number of who have participated in the program and dropped out of school officially. Total number of students served in the first year, a little over 1,700, saw 5 who had officially dropped out that had participated in the program. 3,266 in the second year, so not quite double the program, but saw 13 who had dropped out of school. And then lastly, a little over 4,700 this year or last year, and that number was also was 15, so it had just gone up a little bit. So we've seen a lot of really positive things out of this program, and obviously this was large part of why the working group recommended expansion. You want me to continue to recommendation 2.2, Madam Chair?
Yes, if you would, and then we'll just come back on, talk it all up together.
Sounds good. And so recommendation 2.2, addressing inpatient capacity. Also, this is on page 15. The recommendation is to implement and fund a comprehensive plan to address voluntary and involuntary hospital inpatient capacity needs while providing all levels of care across all settings, supplementing the traditional state hospital setting with regionalized facilities accepting both voluntary and involuntary admissions for persons in acute services as well as longer-term and tertiary specialized care. An ongoing analysis should be conducted to identify geographic areas of needs and gaps in levels of care. Our working group has presented this to this committee already at least a time or two because of how we had combined it from the 2020 recommendations. Previous 2.2 is addressing inpatient capacity, and then also recommendation 9.1, which had to do with developing a regional model. And those seem to tie together pretty well, and that's why we've combined those items. So if we move on down to ease of implementation, the score on 1 to 10 is a 3 because we're combining two of the biggest challenges in behavioral healthcare today, which are cost and workforce. So cost will be a barrier to implementation, and then the contracting cycles could implementation. But then you look over at the potential for high impact, it's a 10 because we've known for several years. I know I had been in front of Senate Ways and Means when Senator McGinn was chairing several years ago, and we started having conversations about this issue in significant depth at that time, and it would impact a large population and could produce cost savings via reduction in transportation costs and lower costs in other systems, including emergency medicine and corrections. Probably one of the things that's most notable about this recommendation is that we've seen a transition or a change over time. And we would have talked about South Central Kansas being, one of the real divides or the areas of have-nots in terms of inpatient several years ago. And now Via Christi has really successful units inpatient psych, as does KBC, have a very nice children's inpatient psych unit. And that doesn't mean that we couldn't use a South Central Kansas facility that would help offset or provide relief to both Osawatomie State Hospital as well as probably Larned. But it's something that would need to be looked at on a statewide level now rather than just an individual region. But we are doing more regionally as well with the state institution alternatives. So the committee noted that. On to recommendation 2.3 on page 16, which has to do with the reimbursement rate increase and review, which was revised and called for immediate action. This recommendation was to implement an immediate increase of 10 to 15% for reimbursement rates for all providers of behavioral health services after increasing reimbursement rates and establish a working group to regularly review the reimbursement structures for behavioral health services for both the uninsured and the Medicaid population. This is to address what has long been observed or recognized as very stagnant Medicaid rates for behavioral health reimbursement over really the last couple of decades. And it was one of the things that led to the community mental health center system working towards the CCBHC model. And then, as has been mentioned by Commissioner Brown and I think Shane Hudson and Dr. Warnes as well, the discussion of partnerships with the designated collaborating organizations and SGD providers as well. But it certainly, with how much time we have to implement, or how much time it will take to implement that system on a statewide level, and even after that, addressing the Medicaid rates is probably a priority for the working group transformation working group, on system capacity and transformation. So that, I apologize. So getting into the next recommendation would be page 18, which that is actually not a recommendation, but rather was referred to last year and this year as a high priority discussion on Medicaid expansion. And last year, there was language that talked about, the potential for expansion of behavioral health care to an estimated 130,000 to 150,000 Kansans through expanding Medicaid through the Affordable Care Act. We had similar conversations this year, and then there were references to ARPA money, and so the decision in our last and how some of the additional I apologize, expanded match opportunities that might appear under the ARPA and other stimulus legislation might affect that. So the decision in the last working group was to revert to last year's high priority discussion language for the committee to discuss. The next recommendation is page 23. Recommendation 4.1, and that's the 988 Suicide Prevention Lifeline. And I can go into some of our conversations, which are not that much different than some of the conversations you've already had, Madam Chair and members of the committee. So if you would like me to, I would be basically repeating some of the conversations you've already had, or we can go back to this when there are questions. Is there a preference?
Let's go back to questions because we had a little discussion on that.
Right. Very good. Page 27, data systems recommendation for outcomes data. And this was to work with the State Epidemiological Outcomes Work Group, or SEOW, to establish an annual legislative report on state behavioral health outcomes using existing data and outcome measures. This, on ease of implementation, was seen as a 6 because of cost as a barrier, and then implementation potentially requiring an overhaul or creation of a pilot program and or program change. So again, that was seen as a 6. Potential for high impact was seen as a 5 because it could benefit a large population and also impact foster care children and specialty populations, rural communities, urban communities, and others. And then it would also help in assisting in measurement of disparities. But it does also get into the category of being able to help with outcome measurement and data management that has been discussed in quite a few committees in the legislature over the last several years, and also in the legislative mental health task force, as well as some in mental health modernization and reform last year. Also, I'm checking to see if Judge Winnell has made it on yet, because I was going to, I think he was going to present over the interactions with the legal system and law enforcement on some of the court reforms, and I don't see him yet.
I haven't logged in, Kyle.
He's actually in person in the building, unlike you, Kyle. I'm just mentioning.
I've been shown up. That's what's happened.
He came from Johnson County, but I'm sure you're going to be here for lunch.
Fantastic. Okay.
All right.
I'm happy to hand these recommendations over to him then.
All right. Welcome, Judge Ronell.
Thank you, Madam Chair, members of the committee. It's a privilege to be here today. I know we are behind, so I'll try to be very direct on 3 quick points that I would like to make. The first is the recommendations. As you can see from your packets, I have recommendations 8.5 and 8.6. I will begin with 8.5. Recommendation 8.5 deals with the idea of a potential regional specialty court. It has a call for strategic impact, an ease of implementation of 3, and a potential for high impact of 10. I want to focus on the very first word of the recommendation, and that is explore. And the reason that I say that is because this is a complicated issue. Clearly, when we look at the barriers and the issues of cost and judicial districts that may not have access to specialty courts, we want to address if this is the right route. There are obviously some benefits to the idea of a regional specialty court, but we also have to consider transportation issues, ease of services in the community. This is a big issue that's going to require a lot of work to look in, and I haven't even addressed the issue of potential venue transfer in these types of situations. So for that reason, the committee has a recommendation that the collaboration come from the legislature, but that this matter be deferred to the Specialty Courts Committee within the judicial branch for exploration of could this work. And on that note, when we look at the Specialty Courts Committee, I think that brings us to the issue of House Bill 2361, which I will discuss briefly in the second recommendation. When we look at 8.6, that is a recommendation as it relates to the potential creation of specialty court coordinator positions. And I would be happy to entertain questions when we're done. And in the questions section, as it relates to what that role is, the need for it, and are the specialty court coordinators
currently working in that role busy, and how are they funded? But this particular recommendation carries with it.
Judge, did you go from 8.5 to 8.6?
I did. I tried to transition.
Yeah, don't do it too fast. I'm a little slow on things here, so. Okay, now you can go ahead.
Thank you, Madam Chair. On 8.6, this is the idea of a specialty court coordinator position. We've listed it as immediate impact. The ease of implementation is a 4, and the potential for high impact is a 9. When we look at the barriers, again, we have the cost and funding issues, but the issue we want to look at is the ability to equip specialty courts with specialty court coordinators. And specifically within the recommendation, you'll see some discussion on House Bill 2361, which, as you're aware, House Bill 2361 has passed the House and is waiting in the Senate Judiciary Committee. And the issue becomes whether or not the creation of specialty court coordinators might also be something for which the advisory committee created under House Bill 2361 might be best to look at the use of funding and where they are allocated. House Bill 2361 would establish a committee that is truly a 3-branch effort of representatives on the committee to look at the allocation of resource funding in addition to seeking grant funding from various organizations. So ultimately, the recommendation of the committee is for the Specialty Courts Committee or the Specialty Courts Resource Advisory Fund Committee in House Bill 2361 to look at these issues. And so as it relates to action items or support, letters or indications of support from this committee to the passage of House Bill 2361 with the Senate Judiciary Committee, as well as any increased assistance to the fund or to the Specialty Courts Committee once created. Those are the recommendations. I did indicate there were 2 other very brief points that I would like to make before I stand for questions or sit down until we're done with this section. And that is to let Representative Ballard and Representative Lynn know that on your comment on platform and athletes, we've secured the team clinician from the Chiefs and Ryan Lefevre from the Royals to be a part of our summit that's going to be happening in April because of their platform. And I had a meeting last week with the Vice President of Player and Mental Health Wellness for the NFL through the team clinician at the Chiefs, asking how the NFL might talk about potentially supporting our summit. So we are definitely looking into platforms that people listen to when we're trying to advance this message. My very last point, and then I will stop, is last week I went down and spent the afternoon at Osawatomie State Hospital. I met with the doctors, I met with the nurses, I met with the patients, had some great conversation with some of the residents there. And obviously asked them a lot of questions, heard a lot of their answers, and I'm not going to relay all those right now, but I would relay an invitation to anyone that's available, and I'd be happy to join you to go down there and take the same tour that I did. There was a lot I didn't know, and I sign orders that tell people that they have to go there, and I wanted to go down there and see what it was like. I wanted to see the intake process. I wanted to meet with the doctors and the residents. I would love to join you on the same tour, and I've okayed it with not only Andy, but also with Deputy Secretary of Housing and Facilities, Scott Bruner, who said he would be happy to coordinate a tour. So those are my 3 points. I would stand for any questions. Seeing none, I'll sit down. So.
Boy, he's going to be busy here in a minute, Kyle, so let's go ahead and finish. No, wait a minute. Well, I want to get through all of Kyle's group. Kyle, are you through then? Was that the last one?
No, there's like 5 more.
All right, let's go ahead and finish those up, and then we'll come back to all of our questions. And the first person we'll have up will be Senator McGinn when we get back, so.
Okay. Thank you, Madam Chair, and thank you to Judge Winnell. It's been fantastic. I should say, as a side note, it's been fantastic to have Office of Judicial Administration and the courts involved, and Spence Kane involved in the working group. I think it has really added an additional level of partnership and discussion that we might not have considered before, or certainly didn't consider as much. So page 29, interactions with the legal system and law enforcement, recommendation 8.7 is the next one I have, competency evaluation and restoration. The recommendation is new and is to provide funding for CMHCs to conduct mobile competency evaluation and competency restoration. Quick note on the rationale: with an average wait time for competency evaluation of 170 days for males, with some waiting up to 360 days to complete. This highlights the need for competency restoration. Additionally, KDAD's highlighted the potential for mobile competency evaluations to help reduce long waiting periods, but said this will not serve everyone. The working group called for immediate action to remedy unjust waiting periods and proposed other options for increasing capacity to be explored, including the potential for telehealth and Osawatomie State Hospital or CMHCs to assist in the completion of competency evaluations. A lot of this is done at Larned State Hospital currently. So we get into the ease of implementation. We had as an 8. That could be high, as I'm finding out through some recent conversations with CMHCs. We need to get a better idea of what the full treatment process is and how that would be implemented. So cost is certainly a barrier. The recommendation does not currently include strategies for continuity, and implementation will likely require a pilot program. Potential for high impact is also an 8. It will not benefit a large population, but will have a substantially high impact on those who have long waiting periods for competency evaluations. It was noted that some people actually wait longer for competency than they would if they were sentenced to the maximum sentence for what it is that they had been incarcerated for. It will impact foster children, rural and urban communities, limited English proficient persons, and low-income individuals and children, and will produce cost savings in other areas. Certainly jails, state hospitals, and those were the key pieces. Interactions, also, this now is on page 30, interactions with legal system and law enforcement. Recommendation 8.1, correctional employees. This is to expand training provided in state correctional facilities, local jails, and detention centers to allow employees to better recognize those with substance use disorders, use a trauma-informed approach to identify other mental health needs, and connect those with needs to available resources. The working group recommended revising the language of the recommendation to clarify that training should include staff of local as well as state facilities. Next recommendation is 8.3, also on page 30, and that is for law enforcement referrals. The recommendation is to increase utilization and development of evidence-based SUD referral, as well as treatment and recovery services among persons with law enforcement contact, which could include securing funding to increase access to inpatient, residential, and outpatient services for this population. And the recommendation was revised to ensure it is interpreted broadly to include funding to support access to residential services, as well as inpatient and outpatient services. The next recommendation, and I think we're down to our last 3, recommendation 8.4, defining crossover youth population. This was a revised recommendation, which was that future efforts should include behavioral health within an operationalized definition for youth with offender behaviors at risk or of entering foster care, as well as including diverted youth in the definition of the broader juvenile offender population. And was also revised to include the comment that to coordinate with juvenile corrections advisory boards, or JCABs, to ensure local implementation aligns with statewide policy team recommendations. Part of the rationale, real quickly, was that since the 2020 special committee meetings, the Kansas Department of Corrections completed this work and established statewide recommendations for working with crossover youth. Ideally, these recommendations are implemented by local juvenile corrections boards, which operate in each judicial district. However, working group members advised that local agencies have not uniformly adopted these recommendations. Next recommendation is under system transformation and is 9.3, recommendation 9.3 on integration, and it has been revised as well. The recommendation is to increase integration, linkage, collaboration, and identify care transition best practices among mental health, substance abuse, primary care, and emergency departments across the state. For example, adopt coding practices allow for the integration of services across the continuum of care domains, including but not limited to primary care, SUD, and mental health, to provide more integrated services to clients with co-occurring conditions. Last one that I have for our working group is system transformation recommendation 9.5 on family psychotherapy. And it was revised, and it would enable utilization of Procedure Code 90846 in Medicaid as a tool to support youth in foster care. This would allow therapists and practitioners to have discussions without the youth present. And that is another item I know that has been discussed quite a bit with this group as well as with Cane Care Oversight. And I believe Medicaid, that Director Fertig mentioned yesterday that they are in the process of undertaking this and working on the state plan change. So with that, Madam Chair, I would conclude our presentation. Again, thanks to Judge Winnell, and we'll stand for questions from you all.
All right, committee, what I will go ahead and open it up to questions. What I will ask is if you will identify the issue by number and then the page so we can all stay together on this. Senator McGinn.
Thank you, Madam Chair. I think my first question is for you on 2.6. If this is successful and we are able to expand it, can we put in the bill a new name instead of calling it a pilot program?
I would love to get rid of the pilot out of that program.
I think we should after all these years.
Yes.
My next question is on 2.2, so probably be for Kyle or you, Madam Chair. This has to do with I'm glad we're doing the regional model. I've been pushing for that for a long time, but those are more for the short-term respite beds. And I really think we need to have a harder discussion about long-term mental health hospital beds. Sedgwick County is in great need. Sedgwick County drives to Larned. A lot of those individuals are at Larned. We know Larned has employment challenges, but yet they have great facility. Osawatomie, I'm not sure since COVID, I haven't checked if they're having employment problems, but they have facilities that certainly need some work. And so, Madam Chair, I'm kind of asking, how can we heighten this conversation? Because Sedgwick County has an increased amount of parolees that are dumped in our area. And that's because we have employment opportunities. But yet, we have the most amount of people that are going to these facilities that take a couple hours to get to, and we cannot seem to get, say, 50 beds. I'll just use that as an example. It's been an example I've used for a few years now. So I don't know if you want Kyle or Judge Warnell to answer, or if you would like to chime in, Madam Chair, since you're from the same county.
On the regional?
On the hospital beds, because I know somebody brought up Via Christi. Via Christi, they're struggling to keep up, and so and KVC, I heard the other night that it's full, almost.
It is full.
And are we going to continue? As the largest city in the state of Kansas, to drive our folks 2 hours all the time? Or can we finally look at a hospital for some of our folks there at home?
Andy, is that something you can respond to, or do we need to see if we can get the secretary or someone from KDADS over here?
I would recommend.
Recommend?
I would recommend talking to the secretary about it.
Okay. Would you like to get in touch with her and see if she's got someone she could maybe have come over here and visit with us today?
Yeah.
At some point, I know whether it's her or someone that can answer our questions, we don't care which it is.
I mean, I'm happy to talk about our current programs, but as to whether or not there'd be a new state hospital opened, I think that would be a secretary level discussion.
Right.
I would, and I believe that, and I'm putting a lot on Connor here today, but there was some discussion of that with the Cane Care Oversight Committee issue. We did get word that in 2023, we're finally going to get the beds back for kids back in the Hayes area that we lost. But people are recognizing a need, and in conversations I've had with the secretary, I know that they've been looking at it. I just don't know that a lot of progress. So getting her or someone over here would be a good idea. So if you'll do that for us, Andy, we'd appreciate it.
Absolutely.
Thank you.
And that's all I have right now. Madam Chair, I'll let others to ask questions. Thank you.
Madam Chair, I'm sorry.
Yes.
Can I comment on that as well, just real
Yes.
quickly? Because it is an issue that certainly our association and others have weighed in on for several years now in both the subcommittee that Senator McGinn chairs, as well as the Social Services Budget Committee with Chairman Carpenter. And we absolutely recognize the same thing that Senator McGinn mentioned. I think that when we even now look at the Osawatomie State Hospital waiting list, it ranges maybe from 3 or 4 patients waiting to 20 to 25, depending on what factors are going on, and so this is something that I've not known whether the cart was before the horse on this conversation, but it's something our association is supporting as it relates to spark money. When we have a chance to visit more about that, it seems like the infrastructure opportunity that exists to building something in another part of the state that would help act as a relief valve or as a more localized or within someone's home community, the number of people from South Central Kansas who end up having that 2.5 hour drive to Osawatomie, being in the Osawatomie catchment area, it's extremely rough on the patients and the families and the transportation providers. And with how full the state hospital has been, it's not been uncommon for some of those people to be just adjusting to the medications that they might be on while on a 2.5 hour drive home. And that's something that I think that could be avoidable if we can add to the infrastructure of our state hospital system. And that's all I wanted to mention about that.
All right, committee, further questions? Well, I've got a few of them, so I'll try to go through here. Okay, I think, and you may have stepped out, Connor, but the reimbursement rate list that was discussed yesterday with KenCare, that's something that we're going to need later on this afternoon. That was on 2.3 on page 16. And on the regional hospital, that is a major issue, so we'll hopefully get someone from KDADS over here to talk about that one. On 7.6, page 27, the outcomes data, what can we actually do? And maybe the solution was there and I did not see it, Kyle. 7.6 on page 27.
Yeah, my apologies. Had my speaker on mute. I think that it has to do with just getting involved with the state epidemiological outcomes work group. And so that may be as simple as a proviso or a recommendation with the executive branch. But that I could be that Carrie or others are greater experts on that than I am.
Okay, was cost discussed at any time?
No,
okay.
I don't remember hearing a cost estimate associated with it.
Okay. Are you on this issue or the previous one?
This one.
Okay, go ahead.
So this is Andy Brown with KDADS again, and I was just going to let you know, like, the SEOW and what we're attempting to do with that is really kind of refers back to some of those previous discussions we had during the last working group report out about the data, right, and identifying what sort of data, the information in that report would look like, right? So if we can, our hope is that we can use the SEOW to do that. I don't think there would be any additional costs.
Okay, that's good news. Yeah. Representative Carpenter, you had a comment or question?
Thank you, Madam Chair. Yes, back to 2.2, I was sitting here asleep and you went on to another subject, but, and I believe 100% in this. I think that unfortunately these aren't silver bullets, so to speak, and my biggest problem is, or concern about this is staffing. You know, we can build the hospital that holds whatever, but if we look at Osawatomie, we look at Larned, you know, if we can't staff it, we still can't serve people. So anyway.
Yeah, it'll take us a while to build it, so maybe by then we'll be able to staff it. Okay, then I hit on so it looks like to me that on 8.5 on page 28 on the specialty courts, that perhaps this committee needs to send a recommendation that this be studied and reviewed with the Judicial Council. Is that kind of what I got out of that, Judge?
That's correct, Madam Chair. And yes, I don't normally talk as fast as I did earlier, but yeah, that's what I said.
Okay.
Usually it's because my court reporter's throwing things at me, telling me to slow down, but
Oh, I don't blame her. That was tough. And some of those court reporters are pretty fast, but, okay. And then on 8.6, page 28, on the specialty court coordinator, that bill is sitting in the Senate Judiciary Committee. And so that's just the recommendation is to encourage them to advance that, correct?
well, yes and no. The working group talked about the idea of a specialty court coordinator position specifically, but when we look at House Bill 2361, it creates more of a broader funding advisory committee for specialty courts. So the recommendation potentially is that maybe the coordinator position, if the funding is there for the funding advisory committee to advise on, might best look at how to assign or utilize specialty courts as part of the overall broad specialty courts allocation, if that makes sense.
I would make a very strong recommendation if we can make this happen, and I know it's very hard for judges and their schedules, is if you or someone would be there to testify on that and then bring this issue up to them.
Absolutely.
Now, I'm not sure, Ida, how we make that recommendation in our report, but you guys do miracles, so I'm counting on you here later this afternoon. I will talk about, and I'm sitting here thinking, because you brought up the summit earlier, something's telling me you may have to change your dates and find another location. I think this thing is going to be bigger than what you realize, and you're not going to be able to do the capacity of where you've had to shift gears.
Well, and you're we're pulling the curtain back here. You're seeing some planning committee stuff, but the venue that we selected might potentially have some additional capacity. So, yeah.
All right.
Yeah, so I'll definitely look into that.
All right. And I think, because I had someone say, well, can we attend? It's like, yeah, you got an invitation last time, but for those of you that may have forgotten, the summit went out. We were going to do it last year, but because of the COVID increase, then we put everything on hold until this next year. But we've got April, tentatively.
April 13th and 14th, Wednesday and
tentatively-
Thursday.
Tentatively. We keep running up against other little barriers, but I think it's going to be exciting.
We think maybe we finalize that today, but I think it's appropriate today to say tentatively, yes.
Yeah. Representative Lynn.
Thank you, Madam Chair. On that 8.6, you mentioned accessing the wraparound services, and it's specific for those in the court system. I know, at least in Johnson County, we at one point, a couple years ago, were talking about a family justice center, which is more of a focus on the survivors rather than those in the court system. Is that something that you've talked about?
Well, I don't have experience with the Family Justice Center, so I can't speak on that. And would very much like to talk about that issue of wraparound services and availability either in the criminal system or outside the criminal system. I mean, obviously, technically, when I'm doing my involuntary care and treatment cases, they're not in the criminal system, they're in the civil system. I actually spoke to him as I drove here this morning, engaged in many discussions with Tim DeWeese, who is the director for Johnson County Mental Health, as well as the staff, about what does this look like, not just from a potential comprehensive behavioral treatment court standpoint, but the wraparound services. I will tell you briefly that when I see services being provided to particular cases where I've signed orders, most of those services are available to the general public as well in Johnson County. So it's a big answer, but yes, we're looking at that, not necessarily just limiting it to the criminal system.
Committee, further questions? Senator Hawk.
Thank you, Madam Chair. I think this is for Kyle and maybe Andy. And it sort of follows up my question earlier when we started today about the salary disparity and how we recruit and retain employees. So it's recommendation 2.3 on page 16. So one of my questions is this recommendation, and I was on the subcommittee, should have asked it then, but can this be reached with the CCBHC certification, or is this just adding more general fund and Medicaid money and others in terms of reimbursement rates?
Madam
2.3
Chair.
on page 16.
Madam Chair, I can start by responding if that's okay, and then Andy can fill in all the gaps that I leave.
Yes.
My response, Senator, would be that the CCBHC model gets us to a cost-based reimbursement, which would for sure close the gap on this for CCBHCs. But for other behavioral health service providers or even the CMHCs that are 2 or 3 years away from this, then this closes the gap while they're in the holding pattern to achieving the CCBHC certification and implementation of that model. Does that help?
Yes, and then I have a follow-up question, which I may never understand budget neutrality, but I know we're supposed to ask about it. Does raising the reimbursement rate affect the issue of budget neutrality?
Let me, Sarah, just a moment, Kyle, on that. Sarah Fertig, are you online? She was going to try
Yes,
to
Madam
pop in and
Chair,
out.
I am.
Okay, because I know that you have to come in and out, I think, just like what Andy does for some meetings today. So can you respond to that for Senator Hawk?
Sure, and Senator, I believe the question you asked was whether or not increasing the amount of money that we're paying to CCBHCs will impact our 1115 waiver budget neutrality. Did I capture that correctly?
Yes, generally, or payment for mental health services to people who are even outside community mental health.
Thank you, Senator. And Madam Chair, the answer to the Senator's question is yes. Generally, anytime we affect the amount of money that we're paying Medicaid providers, that does affect our 1115 waiver budget neutrality. We are in the process of asking CMS to correct some of the errors that they made in calculating our budget neutrality limits. And because they currently artificially constrain how much budget neutrality wiggle room we have. So we're in the process of seeking approval from CMS to correct those errors. In the meantime, we did receive some promising news from our actuaries last Friday that our budget neutrality picture has improved somewhat. So we are in a much better position than we were about 6 months ago based on those calculations. And so while it's something we always need to worry about, Madam Chair, I am sleeping more comfortably with the updated estimates that we have from our actuaries.
Great news. Glad I asked the question now.
All
Thank
right.
you.
Representative Rees.
Thank you, Madam Chair. This question has to do with the interactions with legal system and law enforcement section.
Okay, which item is that and what page?
It's not an item, but it's a general kind of question, if I may.
Okay. Is it going to enhance or add to this report we have?
I hope it enhances.
Okay, who's the question for?
I don't know if it's with Kyle, maybe it's the judge. He'll be more familiar with this. Regarding the mental health first responders that are associated with police departments, I'm aware of the one in Johnson County. Was there any discussion about that and I know Sedgwick County has a program there. Was there any discussion about that and how we could enhance that?
So to answer your question as it relates to the working group, I don't recall that being a discussion in our working group on the mental health co-responders. It is an important discussion, and I participated in a ride-along this year and actually was on a scene when a co-responder was there. I think it's a big discussion and very important, and one that law enforcement generally tells me that they are extremely in favor of. But I don't recall a specific discussion in the working group on it.
Thank you.
Actually, Representative Rees, I think we hear a lot of that discussion in the 988 legislation with our mobile crisis. So we're kind of, not that we're wanting to take away from what, because different counties have got, programs. We're not wanting to take, we're hoping to enhance what they have because most of them only work certain hours. And the mobile crisis units would be 24/7, 365.
Right. The one thing I want us to remember is the one thing that Sedgwick County does that's different is they also dispatch EMS. And they're the one county that does that, and that's a huge transportation saver for law enforcement.
Right, and I think we've got everybody pretty much involved in the the mobile crisis unit so that they can dispatch accordingly, yeah.
Thank you. Thank you, Madam Chair.
If not, we'll be working on that. And Andy's like, oh, more on my list. Okay, I'm going to ask a couple more questions, and I think Representative Ballard, did you have one?
Yes.
Okay. I guess on the 9.3 on page 31, I'm just not quite sure what the coding procedure issue is and practices, the coding practices. What do we need to, what needs to be done on that? I'm just not familiar with it to know what to do with it. 9.3,
Wow.
page 31.
While Kyle is maybe getting ready on that one, 9.3, the revision there actually was the inclusion of those words, for example. So the point of the revision that the working group had was the issue of coding practices, which was in last year's recommendation, adopting the coding practices that allow, it's opening certain codes, including Medicaid codes, that was one example, not the only way to achieve integrated care. So I think that's what the working group was trying to communicate. Kyle, you can correct me if I'm wrong, but it wasn't a change to the recommendation related to coding practices, which is just, again, about opening codes that allow billing for integrated services.
Okay, and I can tell committee that that was a lot of discussion and can care oversight yesterday. And I'm sure Connor's adding all that to his list now as I continue to give him more. And then on 8.4, page 31, not quite sure what we do to address the crossover youth issue.
Yeah, and Madam Chair, this is Kyle. I think that was just, again, continuing the conversation because we've seen with juvenile justice reform, more youth are ending up in psychiatric residential treatment facilities, whereas they might have been in juvenile justice residential treatment centers or something of that nature previously. And so that has also, I think, we didn't do a great job in this recommendation by pointing out the additional strain that this has put on our PRTF system, which already has over 150 kids on the waiting list or youth. But I think we need to continue this conversation, and I don't know that we came up with an actual action item or language to put into a proviso. But I anticipate the item continuing to be discussed, and hopefully the JCAPs or Juvenile Correctional Advisory Boards can be part of that conversation as well.
All right, thank you. Representative Ballard.
Thank you, Madam Chair. I'm on 8.7, Judge Warren, competency evaluation and restoration. All right, if I'm reading this correctly, in order to get a competency evaluation and competency restoration, it can actually take up to 5.5 months to a year.
So that recommendation was from Kyle. I'll let him start, and then I'm happy to comment.
All right, thank you.
Yeah, and in fact, this is Kyle Kessler again, and Representative, the quick answer is yes, but Judge Winnell deferred to me, and I may defer to Commissioner Brown because I think that he had added to this conversation quite a bit as well. But we were hearing in the working group and district attorneys were also a significant part of this conversation as well. And the concern that, there is a combination of treatment and due process issues that roll into this, I think was a big part of it. But right now, there's just not timely access to competency restoration or even competency evaluations.
Ma'am, proceed. The concern that I have by just looking at this is this has implications also for like foster children. And I'm thinking in terms of schools, if you don't have the competency and they don't get the records, what do we do? But what about court trials? What the delay is? I mean, is that what all of this is about? Because I'm looking at it, you say immediate action, which indicates to me this is something we need to do something about like yesterday.
Well, yeah, and some of that had to do with, again, comments that were made by folks from the courts and district attorneys and also practitioners and law enforcement that people are awaiting competency evaluation and competency restoration to stand trial so that they can have their day in court. And sometimes they may have kids that end up in the foster care system or in child welfare system as a result of them awaiting trial and competency evaluations and restoration. But certainly the judge or Commissioner Brown might want to add to that.
And the last comment I will just make, when you're saying that maybe you could get help by telehealth, also Watermead State Hospital, which we heard a lot about that yesterday in terms of what part would be voluntary, but priority will go to involuntary, and then CMHC's assisting in this process. So is that what the pilot program would be like, to see how this would work?
Yeah, yes, I think that that's right. So it would be more localized or localized competency evaluations and restoration for CMHCs that are able to provide that at a local law enforcement center or local or at the CMHC, maybe even. So I think that that's the conversation that we've been having some with KDADs.
I can appreciate that. Go ahead.
Just briefly, Representative Ballard, thank you. I will tell you that you didn't hear the statistic incorrectly. And when I jumped into this world in the fall of 2019, that was the one statistic that got me the most. I just finished an article for the KBA that will be published in their next publication talking about some things, and I quote that statistics. I quote a national statistic that it's over 10,000 people in the United States who have been charged with a low-level misdemeanor, nonviolent felony, and their wait time nationally, their wait time for their competency evaluation exceeds the maximum sentence for the crime if they were found to be guilty. And I focus on that in the article, and it's one of the things, once I heard, has really prompted me to want to be involved in this particular issue. But my only comment, and I will turn it over to Andy, is that you didn't hear that statistic incorrectly, and it does happen in Kansas.
You know, and when reading these recommendations, I mean, we could have skipped over it. Not that the other recommendations are not important, but this one has implications in so many different areas, not to mention people of color, low-income people, people who can't afford their own attorneys. And I mean, this just goes on and on.
And my last comment will be, I specifically, everyone I met with at Osawatomie last week, and I asked them that question. We all hear about competency. What do you think? And I'm not going to relay their answers right now. I received a variety, but I asked them, and I received some very interesting responses. And yeah, I'll stop at that.
Thank you very much.
Can we get a, you say it is published or is going to be published? We'd like to have the copy of the article.
So your name's in it, but don't tell anybody. No. Yes, we just finalized the final version, sent it. I don't know the exact date, but I'll reach out to you and give you a copy of it before it goes
I just think it would be interesting information for all of us, and I hope you're kidding about that.
I mentioned you in a really good way. I mentioned this committee. And I know we're behind, but just participating in this committee and seeing through the summit and the three branches.
Gracious and just say thank you. Go ahead.
Thank you.
Thank you, Judge. Andy?
Andy Brown with KDADS. And I will say that, like, I do consider this to be a very serious issue. We've seen recent lawsuits in other states that are connected to this. And we do feel like it's something that Kansas is vulnerable to and we need to address. So, you know, in addition to the human aspect of it, there's also potential financial liability associated with it as well. So we really are trying to address it. We've been working with the governor's office and Council of State Governments with their Justice Committee and some other groups on trying to find solutions to this. And I think these recommendations are an extension of that, and we want to continue to work on it.
Thank you very much. Thank you, Madam Chair.
Committee, are there further questions? Senator Fagg.
Thank you, Madam Chairman. This is kind of along Representative Ballard's line. This is on 8.7, page 29, the long waiting periods. And mentioned in here the 170 days for males. So when I read that, my question is, is females, what, are they a longer set or a shorter set?
Madam Chair, this is Carrie Bruffer from KHI. Scott Bruner with KDADS did provide a presentation to the working group, and so we can, what was that even, to the special committee, that had statistics, male and female. So yeah, it had it by numbers. So for the rationale, just some key data points were pulled out, but they do have it for all and for different categories of assessment.
Is the problem worse for males and females? I mean, just to highlight? Or about the same?
I don't want to try to misremember. So I do think the highest number of the largest number of days was males, but there were still high numbers for women as well.
Thank you.
Sarah Fertig, are you still with us? Sarah? No, Sarah's not. And perhaps, Connor, let's add the issue that was on 9.5, page 32, which is enabling the 90846 code, when you bring us back all that information, and we'll go through all of that together. Committee, are there any further questions on this? All right, seeing none, thank you very much, Kyle. Okay.
Thank you, Madam Chair.
Okay, I know that we are an hour, well, a little over an hour behind now, but this stuff is just so important to us. Is there anyone in the telehealth group that can't stay with us, that absolutely is going to have to leave before we might get through all of this? Sunny, how is your time?
I can stay.
All right, thank you. Is there anyone online that's going to face an issue with that? All right, committee, here's what I'd like to do is if we can, we're going to break then for, let's try 15 minutes, which probably means 20. Lunches are provided for you outside, and then we'll reconvene here at 12:30. Wow, this is a lot of
Hi, how are you? Good. What they would have done for my. Okay, you see,
Minutes. And for those for those out there that are watching us, we will apologize eating in front of you, but we've got a lot to cover, and it's not good to have hungry committee members. So, our last working, no, it's not, yeah, it's our second to the last. Yes, the telehealth, our last big working group committee, a very big one. So, Hina, we'll let you lead us down the path of who's who and what's what, and welcome to have you here in person. We appreciate that a lot. Thank you.
Thank you, Madam Chair. Again, Hina Shah, KHI. The telehealth working group met 5 times during the interim session to develop and revise their recommendations. And so I have Sunny Mickle and Dr. Shauna Wright is on WebEx, who are both the co-chairs of this working group, and several other members of the telehealth working group that will either present revisions to the 2020 recommendations or be supportive to provide any other context around the recommendation and also to answer questions. So with that, I will turn it over to Sunny Mickle.
Sunny, welcome to committee.
Good afternoon, everyone. Madam Chair, as you know, this is a new working group, and the topic is one that crosses over beyond behavioral health services. So we actually explored this from what medical surgical telehealth services are being performed out there, as well as what's happening in the behavioral health world. We had the benefit of having elected officials, representatives from different state agencies, as well as provider, hospital, and insurance company representatives as part of the working group. And I can tell you that right off the gate, we decided to walk through and get a better understanding about the Kansas Telemedicine Act, because there is a lot of confusion and misrepresentations on certain provisions within the act. We also had the opportunity to hear from several subject matter experts. We had Eileen Ma from the Revisers of Statutes Office speak with us and walk us through the Telemedicine Act. We also had Dr. Dorothy Hughes from the University of Kansas Medical Center, and Dr. Hughes presented data that was on her survey research with 14 different providers around the state and their telehealth usage. We also had Kyle Zebley from the American Telehealth Association speak to us about how the American Telehealth Association has been tracking telehealth payment parity in other states, also what's happening at the federal level in regards to reimbursement for Medicare. And I'm going to make sure that I turn things over to Dr. Shauna Wright in case she has anything else to add before I walk through our actual vision statement. Dr. Wright?
I think you've covered it all, Sunny. Thank you. This is Dr. Wright with the K Center for Telemedicine.
Okay, well, great. Thank you. So if everyone can turn to page 32 in the report, in the middle of the page, we actually have a revision to the vision statement for the telehealth work group. And basically, we settled on a modernized behavioral health system will deliver technologically current telehealth services with the Kansas Telemedicine Act as a foundation, as a strategy to provide meaningful access to care across rural, frontier, and urban areas, and regardless of socioeconomic status. These services will be high quality, integrated with other modes of care delivery, and ensure consumer choice and privacy, in addition to supporting the full spectrum of behavioral health care. And as you can see, we amended that after having some of these conversations with the subject matter experts. Are there any questions about the vision statement?
Committee questions? Seeing none, proceed.
Okay. Well, the next, at the bottom of page 32, I want to point out to you a new recommendation from the telehealth working group, and this is recommendation 10.6, and that is a telemedicine committee. The recommendation is that the Legislative Coordinating Council shall establish a special committee on telemedicine modernization. And the rationale for this is that the working group realized there's so much more that needs to be discussed, more data that needs to be gathered, and look outside of COVID era telehealth usage. Right now, telehealth usage is still very high, but it's fluctuating each month based on the pandemic. And Post-pandemic, we're hoping to have more consistent data, but also have the opportunity to talk more about rates and usage. If you take a look at page 33, we walk through the ease of implementation for creating a new telemedicine committee. And the ease of implementation is scored at a 2. And that's really because the committee may be easy to set up if the Legislative Coordinating Council establishes this, but the actual conversations that the committee will be reviewing and their decisions are going to be quite challenging. We do think there's a high impact, though, coming from a new telemedicine committee. So we scored this at a 10 due to this recommendation having a strong potential for helping out people with large populations, limited mobility, and those lacking vehicle transportation. And also, we believe there's a potential for cost savings depending on the decisions that are made by the committee. And you can see there we also included some action leads, feeling that, again, the Legislative Coordinating Council and the Legislature. Key collaborators are coming from those in the community, including the employers, especially those that are self-funded, since they will have a say about how they are covering and reimbursing for these services for their employees. And with that, I'm going to pause and see if there are any questions about the new recommendation 10.6.
Committee, are there any questions? All right, seeing none, proceed.
Okay. Well, next, I would like to introduce Dr. Sandra Berg. She's going to talk to you about recommendation 10.1. Dr. Berg?
Good afternoon, committee and Madam Chair. I'm Dr. Sandra Berg with United Healthcare. I'm the Behavioral Health Director here, and I'll be walking you through our revised recommendation 10.1 for the Telehealth Committee. This is the quality assurance recommendation that we made last year, and this is on page 33. We made a few changes to the recommendation in light of what we learned around the Kansas Telemedicine Act. So one of the changes was to add the language of develop quality assurance standards to ensure high quality telehealth services are provided, which would include establishing consistent guidelines and measures for telehealth in collaboration with our licensing and regulatory agencies, and then allowing telehealth supervision hours to be consistent, which was part of our recommendations last year. And then what we added was language around the telehealth, the Kansas Telemedicine Act to bullet number 3. It was a combination of other language, and we felt like this made it more concise and aligned it with the Telemedicine Act. And then we added language in the 4th bullet to improving provider and patient education around telehealth literacy in relation to privacy, efficacy, and access and cybersecurity practices to better align with what we were trying to get across around our quality assurance. The reason we made some of these changes was we identified some key barriers for implementing the previous recommendation of the telehealth quality assurance, including some of the confusion with the Kansas Telemedicine Act and the gaps in provider training around maintaining a standard of care in telehealth setting. So to address this, the working group proposed increased provider and patient education around the appropriate use of technology, and then to ensure the same quality of care, both in person and with telehealth visits, and to improve e-health literacy in relation to the privacy efficacy and the access to those services. So the working group members also wanted to increase the training in relation to cybersecurity for best practices when we created the guidelines in collaboration with licensing and regulatory agencies. And so this recommendation scores high for ease of implementation because there are many providers that are already familiar with telehealth services. Some of us had to learn by trial and error through the pandemic. And now we see this as an opportunity to go back and relearn and expand on that, urgency that we went through during the pandemic and really hone those skills and through the work that we are recommending in the new telehealth work group that we can continue to carry out the telehealth services in a more quality assured way. Any questions?
Committee questions for Sandra? Nope. Go ahead.
I think the next one goes to Jason, is that correct?
Oh, excuse me, just a moment. Senator Erickson.
Thank you, Madam Chair. Just a quick question on terminology. Can you just explain, I think I have an idea, the difference between telehealth and telemedicine? Thank you.
We had quite a discussion around that, Senator. And I may have our committee members help me with this, but we kind of went back and forth around how it's interchanged. And I think we settled on telemedicine to align with the Telemedicine Act. And Shauna, you want to help me out here because I think I'm going to mess this up. One's an umbrella term and one kind of falls under it. So I'm going to kick it back to you, Shauna.
Sure. Thank you. This is Shauna with KU Center for Telemedicine and Telehealth. And Sandra is right. We want our language to be consistent with the Telemedicine Act. When we train and talk about terms in terms of educating providers about telehealth versus telemedicine, we generally see telehealth as an umbrella term that is inclusive of both direct medical or clinical care as well as other means of engaging technology to improve healthcare. So that could include educating professionals. It could include public health announcements, just anything that leverages technology to improve or address healthcare issues. So telehealth is a broad term, where telemedicine really typically really reflects the direct clinical care through telemedicine, whether that is the live video, audio, synchronous connection, or even our asynchronous connections where someone might read a radiology screen at a different time than it was actually taken. So telemedicine is that direct care. We might find other terms such as tele-oncology, telepsychology, other specialties that we can put the tele on. All of those words would fall underneath that umbrella of telehealth. But Sandra's right, our work group really wanted to remain consistent in our terminology with the Kansas Telemedicine Act, knowing that most of what we're discussing here really falls back to direct client or patient care.
Thank you, Madam Chair. I just want that clarification. Thank you.
Go ahead, Sunny.
Okay, thank you. Our next recommendation, 10.2, is actually going to be discussed by Jennifer Finley with the Kansas Hospital Association. Jennifer, are you online?
I am. Good afternoon, everyone. So recommendation 10.2 is a recommendation that was included in the committee report last year. We've made just a few minor modifications to the language. We've added clarification that this recommendation as a whole talks about Medicaid reimbursement codes and continuing to allow the changes that were made during the public health emergency to continue those in perpetuity, as long as CMS rules will allow for that. So simply, we just added a little bit of language to clarify those kinds of provisions, to point out the importance of the access that is provided to Medicaid recipients by having telemedicine as an option available. This is something that KDHE is currently doing, so we feel like it's going to be a pretty easy one to maintain, but we thought it was important to still go on record noting how important we thought it was that we continue these kinds of options.
Committee questions? All right, seeing none.
The next recommendation, 10.3, is actually going to be discussed by Dr. Shauna Wright with the KU Center for Telemedicine and Telehealth.
Thank you. Good afternoon. We want to recognize that with our 10.3 telehealth for crisis services, that our work group really sees that this recommendation has been met, and we want to recognize that the Medicaid state plan amendment allowed coverage of mobile crisis services. That was submitted to CMS in October with a proposed effective date of October 1 of 2021. So we want to recognize that. However, our work group felt it was important to make some revisions to this recommendation to continue again along those lines of quality assurance and to make sure that these crisis services continue to be accessible throughout the state. So with that, our recommendation or our revision to this recommendation was to continue coverage of telehealth for crisis services. And then the last point that we added is that we really wanted to focus on engaging our professional associations and providers to adopt appropriate education so that providers, practitioners, and even law enforcement officers that may be utilizing these services have some training with telehealth. We recognize that across the state, our providers and law enforcement officers experience a variety of resources as well as barriers when it comes to using telehealth to support the work that they're doing. We want to address their specific needs and not consider it to have a one-size-fits-all, and also to look at what our existing resources may be. We may not need to reinvent the wheel to identify and adopt training, but we may need to look at the specific needs in different geographies and locations with different resources to make sure they have the telehealth support they need to support the crisis work. So our work group gave this an ease of implementation score of 6 because we may require some program changes with it. But the potential for impact, we scored it a 9 because this recommendation may impact a large population, particularly when we look at individuals who are homeless or may have limited English proficiency, as well as children in foster care. So those were our revisions to this. We want to recognize the great work that's been done, but continue to recommend that we're educating those who are going to be using telehealth so that it's done in an effective and efficient manner.
Committee questions? So, Sunny, do you know, or do we need to, or whomever can answer this, and maybe it's a Sarah Purdy question. Is this continuing under our current plan? Has that been adjusted, or do we know?
I was told, this is Sunny Mickle from Blue Cross Blue Shield of Kansas, and I was told that during one of our work group meetings that there was a plan in place to continue this, but I believe that has to be decided at another level or another meeting.
Sarah, are you still with us?
I am, Madam Chair.
Can you answer that for us? Did you hear the question?
I heard part of it. I just hopped back in from another meeting.
Okay, that's fine. I knew you had to go in and out with us today. It deals with telehealth for crisis services and a Medicaid state plan amendment to allow the coverage to continue, et cetera, et cetera. Does that now ring a bell?
Yeah, so we are working on a couple of state plan amendments kind of surrounding the mobile crisis and crisis services generally. And so, yeah, we do intend to continue that for crisis services.
So we're trying to adjust our state plan, or we have gotten the approval?
We're working on it for mobile crisis services. That's kind of a separate issue there. But yeah, for crisis services generally, we do intend to keep the same rules that we have in place now going forward.
Okay, so if I heard you correctly, then crisis services and crisis mobile services are two different things.
That's right. That's right. And I believe that the question related to crisis services, not mobile crisis services.
Right, I'm just trying to distinguish the differences. So, all right, committee, are there further questions on this? And Sarah, we appreciate you bouncing back and forth. That's very helpful for us today. All right, proceed.
Okay, if I can ask the committee to take a look at page 36 at the bottom of the page for telehealth recommendation 10.4. This is about originating and distant sites. When the working group began its first set of meetings, participants expressed concerns about the provider confusion around the Kansas Telemedicine Act's definitions, specifically around the originating site and the distant site, as well as existing interstate compacts. After clarification, the working group understood how the existing originating and distant site definitions of the law actually apply. And you can see here our recommendation is the following items should be addressed to ensure individuals receive and providers offer telehealth in the most appropriate locations. Examine issues related to the providers practicing and patients receiving services across state lines, such as by exploring participation in interstate licensure compacts. Generally, behavioral health providers must have a state license to practice in the state that the originating site is located when the distant site is out of state. And to clarify, the originating site is where the patient's located, and the distant site is where the provider is located. Interstate compacts also create an opportunity for licensed behavioral health providers on interstate compacts to practice and deliver services from a distant site in another state. And the working group believes these compacts should greatly benefit a large population, particularly those in rural parts of Kansas where they have limited access to care. So we scored this with the ease of implementation. You can see this on the top of page 37. We scored this with a 10. We do believe this will require a program change, but that has to be looked at a little bit more closely. And then for potential high impact, we gave it a score of 10 also, due to high impact having increased access to care for everyone in the state, whether they're in urban locations or rural locations. Are there any questions about recommendation 10.4?
The one I have right off the bat is there a distance, or is there a difference between facility site fees originating in distance?
Yes, there are. So I can't speak for others, and I'm sure they'll jump in and give you more information. I cannot speak for how Medicaid pays that today or what other private carriers are doing. But for example, with Blue Cross and Blue Shield of Kansas, we do reimburse the provider at the distant site for services that they are performing under telemedicine. And then if the patient is at an originating site that happens to be a facility or a medical clinic or a behavioral health clinic, if that originating site is serving for that patient, then Blue Cross will reimburse a facility fee to that originating site because they're using their staff, they're using their EMR systems, their equipment, and you typically have a medical provider or behavioral health provider that's actually physically interacting still with the patient.
So then facility and originating are the one and the same?
You don't always pay a facility fee. So a facility fee, though, typically refers to something that occurs at the originating site.
So what is a facility fee then? I mean, to me, it's like originating facility, I'm at a facility that I'm.
The originating site could actually be someone's home. It could be their car. It could be a school. So it really is anywhere the patient's located. The facility fee comes into play when there's a need to reimburse the providers that are actually working with the patient at the originating site.
But if it's at their, and I'm probably getting in the weeds here, but I think this has been a complicated issue for a while, is if I'm at my home, how could there be a facility fee for the provider?
That's a great question. And in that case, I can tell you from Blue Cross's perspective, we do not reimburse a facility fee when the patient is at home or in a non-clinical setting.
So is there something that, Sunny, that we can look at out there that will tell us what these fees look like, kind of when they're charged? I think, we need to get a clearer picture of what's going on with these fees, because these fees here are on top of what the medical visit is.
That is
or
correct.
Yeah, so let's say the doctor charges $50 for their service, whether I'm in-house or out, via telehealth. This would be a fee on top of that $50, correct?
That is correct.
Okay.
And there's a difference, again, based on different carriers today, because that's not something that's currently in legislation. There's no mandate for insurance companies or other payers to pay that facility fee, so it is a little bit different depending on who you talk to. I know Director Fertig may have some information to share on how that's handled today for Medicaid.
Sarah, can you enlighten us a little?
Sure, Madam Chair, I'd be happy to. So currently Medicaid does not provide that additional facility or site fee for telehealth services. We do not currently pay that. We will reimburse the provider for at the rate for the service itself, but we do not tack on an additional payment to cover those overhead costs for the provider at the facility or originating site.
Okay, thank you. Committee, are there further questions? What? Go ahead.
This is Jennifer with the Kansas Hospital Association. Medicare does typically pay a facility fee, just so that you know that. And it's usually paid to the hospital because there is a nurse that is in the room with the patient helping facilitate that visit.
So then does Medicare do that for a office call? Telehealth office call, or do you know?
Well, it would only, again, as Sunny had explained, it would only occur when there is actually additional support being provided at that originating site. So if the patient was at home, it would not apply. All of these intricacies of how all this works is, goes back to our original new recommendation is we need a committee to dig into the weeds of all of this because it is really complicated and confusing to understand.
Well, yeah, people try to simplify it with the word parity, and that's a very complex issue when we get into it. So and I don't want to take up the whole committee's time on this, but I think there has to be a clear picture drawn for legislators to understand what that means and what that's included, because I believe if I recall correctly, my words in the discussion on this working group was I believe that it's right for transparency that the end user understand what their expenses are going to be if they're using telehealth. And telehealth appears to me, because of distance, originating facility, whichever term we want to use in there, has a cost on top of their regular charge if they had walked into the doctor's office that they wouldn't have. Would that be correct, Jennifer?
I think it still depends on the situation because it doesn't always apply. But this recommendation that we made about this was really about looking at where the providers are located if they're out-of-state providers. So the issues you raise are really important issues, but they're not directly part of this recommendation that we're looking at right now.
It's in here somewhere.
Representative Landwehr, this is Jason from the University of Kansas Health System. It's in 10.6.
Okay, then we're going to get there. I just jumped ahead of it. Thank you.
No, sorry. We actually covered 10.6 at the beginning because that was a new recommendation.
Okay. It's just not to me, it's as clear as mud. Representative Arnberger.
Thank you, Madam Chair. My question actually is with 10.6. I thought of it after we already moved on. For the committee, the special committee, would it be set up like this special committee, or would it be like a Bob Bethel special committee where they meet every year?
It depends upon how you want to structure it. If I had my druthers, it would always be done by the LCC, and the reason for that is because then you can structure the committee and shift as you need to as things move. For example, last year, we started with 3 working groups. So first of all, we had no format. We just knew that we were going to have about 50, possibly 60 people involved in this. How do we make this work logistically? And then that's where KHI came into that. That would have been tough to do if the committee had been designed in statute. Then we would have been operating within the statute walls. We had flexibility so that we could bring KHI to the table, set up the structure that we felt was in the best working manner for the process going forward. We started with 3 subcommittees. Telehealth kept brought up in committee after committee after committee. So we were able to form within the existing group a 4th subcommittee. You can't do that if you put it in statute. So my question to staff as we wrap up is how can we make a standing letter that goes to the LCC to ask for this committee to remain structured the way it currently is versus putting it in statute? Because I feel, and I think I can speak for some of my colleagues here that have been on this committee now for 2 years, this structure and flexibility has moved this issue further than we ever could have. And I think we have one of the most meaningful reports by the time that we're done here. And we're constantly reviewing that and updating it and tweaking it. And Yeah, so.
So what is the process to have this committee created? So as you are chair, did you write a letter to the LCC to create this committee? Or could you educate us on the process of how the special committees are created each session?
It's a recommendation, a letter that goes to the LCC, and I have absolutely wonderful staff that I get to work with all year long, and they help write a letter that laid out the format, and we formed it. The LCC approved the letter.
Okay, thank you.
Now, last year, it was actually led by the leadership team in the House, but this year I had to issue a letter.
Thank you.
Further questions?
Representative Landwehr?
Yes.
This is Jane Adams with Keys for Networking. I wasn't aware until just this now that there is an extra charge for telehealth. And so our families, like whose children are on Medicaid, are they asked to pay a fee that if Medicaid doesn't pay for it?
No, what I heard from Sarah is Medicaid recipients do not pay, Medicaid does not pay any fees, and because we don't have the individual in there with a copay or something like that on it, the Medicaid recipients are not paying that fee. It is, the people paying this fee are those that are insured, people that pay cash because either they don't have insurance, they're not on Medicaid, so they're paying cash, or individuals that have high deductibles that are probably paying cash. Those are the ones that are paying these extra fees.
This is Shauna Wright with KU Center for Telemedicine. I don't know that there's always an additional fee for telehealth. I think we would need to look back and talk with maybe some of our payer sources. Oftentimes telehealth is billed at the same physician fee as an in-person service, and there aren't additional fees tacked on. There are some providers, some insurance providers that do pay or reimburse a small fee to the originating site. Like Representative Landwehr said, it's a very complicated issue. And sometimes when we talk about the facility fee outside of the originating site, but the facility fee perhaps where the provider is actually working, if the provider is in a hospital and the facility where that provider works has costs associated with maintaining their organization, that's where that facility fee comes from. But in general, most bills that go out are for the physician fee, and there isn't an additional cost for telehealth. I don't know, Sunny, if you could add to that, but my understanding in hearing Jane speak was that her assumption in this conversation was that there's additional fee for telehealth, which I don't believe is accurate.
Well, and her question pertained to the Medicaid, and that's the population that she works with.
And if you'd like me to clarify just one more time, too. As Jennifer Finley from the Kansas Hospital Association explained, when we're talking about the facility fee being reimbursed, and this is the CMS definition of a facility fee, it's for when the originating site, that patient is sitting at an originating site that happens to be in a medical facility, a hospital, or a behavioral health clinic. That's when the facility fee is reimbursed by some private payers. But again, there's no regulation or state law right now that actually dictates reimbursement.
Representative Reese.
Thank you, Madam Chair. My question has to do with interpreters, setting aside Medicaid recipients, so everybody else. Is there an additional fee for that, that the patient will incur?
If there is an interpreter, I am not familiar with how that is actually billed today. In some of our provider offices, they may have someone who's a translator, but I don't believe we're being charged at Blue Cross for those additional services.
This is Jason from the University of Kansas Health System. We do not bill for interpretive services. Just like any other encounter, that is a accommodation that we make, and it is not in excess to the normal bill that goes out.
And this is Jennifer with KHA. I'm not aware of any hospital that charges for those services. It's a condition of participation with Medicare that we provide those services to patients, and that gets extended to all patients.
Thank you.
Further questions or comments? Now we all understand why it's complicated. All right, proceed, Sunny.
Okay, well, I have one more person to speak, and that's Dr. Sandra Berg with United Behavioral Health, and she's going to introduce and talk about recommendation 10.5.
Thank you,
Dr. Berg?
Sunny and Committee. Again, this is Sandra Berg with United Healthcare, and our last recommendation is a review of the child welfare system in telehealth. This is a revision. We added one word to the recommendation, and that is the word explore. How the unique needs of parents of children in the child welfare system can be met via telehealth. And the reason we added that one word was to look at how there are opportunities within this population that telehealth can aid those parents of children in the system, and how we can address the needs that they have, looking at the mobility of those folks, sometimes even with the children getting moved around and the parents being able to access services and getting the continuity of care that they need. We felt like this was a 10 in ease of implementation and a 10 in the impact of that population. We felt like the utilization of telehealth would be a way to measure the impact of this within the foster care population. We can look at when a child comes into care or goes to a new placement. We could look at how quickly they could get into therapy services, maybe within a 72-hour period. We could look at the percentage of children within the SINC population under the age of 17 and how quickly they could receive crisis services, and then also look at whether they were resulting in a inpatient admission or were avoiding an inpatient admission because they were getting into services. And then also looking at the SINC children that received those therapeutic interventions and whether they were also getting into an inpatient admission within 30 days prior to a screen. So we just felt like the population for foster care could be impacted, but we needed to explore this further and didn't have any specific recommendations on how that would be. Any questions?
Committee questions? This to me kind of makes a lot of sense if we can, figure out some of these items, because when those kids, it's one of the reasons the mental health initiative program in the schools was started was because of disconnect with a worker at school, and then maybe a worker if they found someone outside of the system. So having continuity is a big deal, especially in the mental health arena.
One other thing I'd like to add, Madam Chair, is as far as medication, we see a lot of children change medication providers, and if they could maintain some consistency within a medication provider, that would really benefit them as well.
That's a very good point. Further questions? All right, seeing none, thank you. What's our next one? That's it?
Yes, Madam Chair, Hina Shah, KHI, that is the end of the telehealth work group recommendations.
Wow, that's incredible. All right. So we have nothing else from working groups, that's it. All right. Connor, would you like to? We're going to let Connor step up to that, and then we do have Scott Bruner has joined us from KDADS. The secretary's traveling, which I didn't mean the secretary had to be, just someone that she knew would, so she sent Scott. So I appreciate you coming over and joining us.
Thank you, Madam Chair. Connor Stengler, Kansas Legislative Research Department. You asked for just a brief review of several topics we touched on yesterday at the Joint Bethel Committee. So first, the Autism Task Team. Carrie Bruffett did address this briefly today, but KDADS yesterday in their update stated Secretary Howard asked KDADS to work closely with KDHE and DCF to establish the Autism Task Team. A contract was secured with KHI in August, like Carrie said, to assist with facilitation. The first meeting was held in August 2021, and the task team will produce the report submitted to KDADS by the end of January 2022, so next month. I also wanted to briefly review the recommendations that the Bethel Committee made yesterday that are related to topics that we've talked about today. So I'm not going to read all the recommendations, but I will read the ones that were related to topics connected to this committee. So recommend the state submit a state plan amendment to add 90846 as a billable Medicaid code that would allow billing for therapy without the patient participating, and request a cost estimate for that code, which I'll get to in a second. Recommend the legislature expand postpartum coverage to 12 months for new mothers enrolled in CanCare and direct KDHE to provide data on the number of women who have used the first 2 months of postpartum services and could benefit from the 12-month extension. Request, and this relates to the integrated care and the primary, the Medicaid codes that were referred to today. Recommend the state Medicaid director review and report, including producing cost estimates and historical comparisons on raising a host various Medicaid reimbursement codes as percentages of Medicare, including for emergency medical services, EMS, pediatric primary care, certified nurse midwives, and submit that report to the various health-related committees and subcommittees of the legislature. Request the LCC establish a committee to study the intellectual and developmental disability waitlist and long-term needs of the IDD community, similar to the structure of this committee, actually 2021 Special Committee on Mental Health, Modernization, and Reform. And finally, recommend appropriate legislative committees that deal with perinatal behavioral health, monitor current funding sources for Kansas Connecting Communities. And since I mentioned Kansas Connecting Communities, I'll just summarize them real fast. Bethel Committee heard a presentation from them yesterday. KCC, their mission is to develop and maintain guidance on screening, implementation, and intervention best practices through provider toolkits as it relates to perinatal behavioral health. Yesterday, they reported the barriers to care include the fact that frontline providers are not always reimbursed for screening for mental health, and that limits psychiatric providers in the end. KCC also helped develop a provider consultation hotline for perinatal behavioral health. And related to that recommendation, so again, the recommendation, I know I'm going kind of quickly, but the recommendation was to recommend appropriate committees that deal with perinatal health monitor current funding sources for KCC. And the KCC funding sources, they are supported by HRSA grants through 2023 currently. The recommendation is to establish a committee to monitor those funding sources. On the issue of state hospitals, we did receive an update on state hospitals and state institutional alternatives, also known as SIAs, yesterday from KDADS, and Scott Bruner can speak more to this. But this relates to our recommendation, mental health recommendation 2.2. So yesterday, KDADS reported that they're focused on enrolling community hospitals as state institutional alternatives, which are inpatient facilities around the state in the community that provide inpatient psychiatric treatment. According to KDADS, 8 hospitals are approved to be SIAs right now. 5 have enrolled with Medicaid. 6 of the 8 are accepting admissions, and 2 in addition to those 8, are planning to submit applications to be an SIA. And right now, from late August to early December, utilization of SIAs, the data on that is 95 adults and 270 children in those SIAs right now. I also wanted to mention, I spoke with Medicaid Director Sarah Fertig about 90846, which is the Medicaid billable code for patients to not be in the room when discussions are taking place between the provider and let's say family. Sarah Fertig, who I told can intervene dramatically to correct me if I'm wrong here, but she provided an estimate of 3.1 million all funds. That would be worst case scenario for that. There's some confusion, some cloudiness about the billable code because with the introduction of CCBHCs, once CCBHCs are operational, the cost of providing 90846 services will be included in the facility costs. So they won't, the prospective payment will cover those costs and it'll be included in the CCBHC costs, not separate costs as we usually think of them for Medicaid, if that makes sense. So once CCBHC starts providing those services, if the code was to be approved, it would be included in CCBHC costs, not other Medicaid costs. So Sarah said, bottom line, costs are not prohibitive because if these are eventually included in CCBHC costs, then the cost would essentially be neutral as opposed to the 3.1 million all funds. I know that was a lot of numbers and a lot of data, but Sarah can clear some of those issues up. And last thing I wanted to mention, on one of the codes, one of the services that was mentioned specifically at the two-day Bethel Committee meeting was emergency medical services, so EMS. We heard from several EMS representatives on staffing shortfalls and the need for increasing Medicaid reimbursement. I just wanted to point out that so EMS, they noted that Medicaid and Medicare currently reimburse only for the provision of ambulance services when the transportation is involved to or from a hospital. So they gave the example of if it goes from a nursing facility to another nursing facility, then that could not be reimbursed. They also recommended Kansas consider and pursue a method by which ambulance services would be eligible for reimbursement for transporting to alternative destinations, for example, behavioral health clinics, crisis centers, urgent care, et cetera. So that's sort of the connection to what we were discussing today. But they were recommending a Medicaid rate increase yesterday. So I know that's a lot of information, but feel free to email me or ask me or talk to me afterward if you have questions about specific recommendations the Bethel Committee made or any of the data I threw out. Thank you, Madam Chair.
Thank you, Connor. Senator McGinn.
Just a follow-up to your last question, and I'm sure this would be an example too. So you talked about mental health centers, but what about substance abuse facilities as well?
As one of the potential destinations for the ambulance services.
People start at the hospital and they eventually need to go to rehab.
That might be, I'm not going to speak for them and say that's one of the destinations they're thinking of, but it was include, their categories were crisis centers, urgent care, behavioral health clinics, et cetera. So that might be something, but I can ask them if that would be something that they would consider. And that's a request that they made sort of secondary to the Medicaid reimbursement rate increase.
Thank you. Thank you, Madam Chair.
Are there further questions? All right. Connor, if you can, because I know we hit you on the fly with that, just kind of, write up what you've given us there, and then with the committee report that Arida works on, we can have that attached to it.
Sure.
That we kind of looked at those because they pertain to some of the stuff that we did, and that way it's staying above the water on both committees, so.
Sure. Yes,
All right.
Madam Chair.
Thank you. Okay, and now, committee, we had asked for KDADs to come over and join us and discuss beds. I know it's one of your favorite topics, Scott, and we appreciate you interrupting your day to come over and visit with us this day, and appreciate the secretary asking you to.
I was working from home, so.
Oh. Oh, Mike.
Sorry about that. Sorry. Scott Bruner, Deputy Secretary for Hospitals and Facilities at KDADS. I got a little bit about what questions you had, but I'm happy to take your questions about specific topics.
I wonder if that would be Senator McGinn. I believe it is. Senator McGinn.
Thank you, Madam Chair. We've had this discussion, it seems like every year at the committee level of the Budget Committee on talk about Well, just to give some that are new a little bit of background, Osawatomie was in such, disarray. We had to go in and fix is it the Adair buildings? I'm trying to remember. Yeah, Adair. And, we're patching facilities, in my opinion, that shouldn't have been patched. And so at one time I put in a hospital, 200-bed hospital, and just to start the discussion. And, but then as we learned more about the regional need of at least the 1 to 14 day beds, that seemed to be a good idea so that families don't have to travel as far, can help their family in short-term crisis. But then we have the long-term crisis as well. And instead of looking at a large hospital in the same places that we've always had, why don't we look at the cities or communities where many of those residents at the facilities are from, so their families can help them long term. And I know you and I have even had this conversation over the years, but so Sedgwick County would like to look at a 50-bed facility, 30, 50, because all of their folks are having to travel. We also have an increased amount of parolees that are being, dumped in our community. And it's, if you're from Western Kansas or somewhere, they've got to have a job to be successful. So that's why they're coming to our area. But so we're taking that kind of a load, which challenges our law enforcement. But at the same time, we can't help the people that are trying to stay on the right track or others in our community that just need some mental health help. And again, somebody said it earlier today about how families have to travel, I think it was Kyle, a couple hours to go try to help their family. Well, a lot of these families might be working 2 and 3 jobs, and they're supposed to go take off their little afternoon they have on a Saturday to do that. Sure. So I think we need to elevate this discussion because we have Larned, which has great facilities, has employment challenges. We have Osawatomie that I didn't know the numbers after COVID, but I don't know if they're having employment challenges, but they certainly have facility challenges. Sure. And instead of just continuing to throw money at what we already have or have had for 30, 50 years, it may be time that we move to the community that needs it the most. So I'd like to know, I guess, if you can speak for your boss a little bit about how we can start that conversation at a higher level.
I can speak for Secretary Howard. She apologizes for not being available today. I think everything you said, Senator, is right on the money and things that we experience from our perspective at both Larned and Osawatomie. I don't know that I've met with this committee before. I think I have, but my role is to help with management of the 4 state hospitals, including Larned and Osawatomie, and work with the superintendents there. And I'm actually on the Osawatomie campus every week and have been for the last couple of months. So know a lot about all the issues you talked about of both people getting discharged from DOC and needing a place to go, transport issues to Osawatomie from Sedgwick County, access to beds at Osawatomie from Sedgwick County or anywhere in the catchment area. All of that is true. So our couple of approaches to work with that, the state institutional alternatives was one that with the support of the governor and the support of the legislature over the last couple of years, we've added funding to build that new provider type. Via Christi in Wichita has been a great partner so far early on. To add to use some of their beds in their psychiatric unit as SIA beds and to serve people that need that higher level of acuity that would go to the state hospital, but we're serving them, or they're being served in Wichita by Via Christi staff, keeping them closer to home, closer to those community options when they discharge and are back in the community, or we need to find a longer-term bed for them at Osawatomie. So that's part of it. That it's been a little slower than we thought of building that capacity up, and it has tended to be focused on the eastern third of the state. Although we've got a couple of options in Sedgwick, one option in Sedgwick County, and then Arc City is another hospital that we're working with. But we've got to keep working on that, and we will, and that's one path. Because of that partnership with Via Christi, the secretary and I met with the leadership team of the hospital and got involved in the regional planning group that's operating there in Sedgwick County, that's looking at a lot of options: substance abuse treatment, peer support, inpatient capacity, and one of their proposals is a 50-bed, I believe, state, kind of a branch state hospital in Sedgwick County, and was excited to learn about that possibility. We don't have any objection to that as a proposal to consider. In the budget process for our role is to submit budget requests to the governor's office, and then she'll make a recommendation in January. Our budget request included some additional positions and enhancements at Larned and Osawatomie to kind of meet the needs that we had. We were asked to kind of retune some of those things to have a more regional focus, and we've done that, and we'll see how that comes out in the governor's recommendation in January. But I think you've got a willing partner at KDAS to talk about how that would work, to have a regional state hospital, either that we would operate as an extension of one of the other campuses, or through a partnership with community partners, private players. I don't know, but you've got a willing partner, at least at KDADS, to continue those conversations that we've been parts of.
And I do appreciate the efforts that you've done on the regional capacities out there. And that was one of the things we slowed down on the hospital, is because if you can take care of it at the 1 to 14 day at the regional, you don't need. So then you've got to figure out how many beds do you really need, you know. So I guess, Madam Chair, I would just encourage, and I don't know if we can put anything in this document, but you talked about Sedgwick County, you talked about Winfield. You could also talk about Harvey County, and I could tell you some facilities there as well. So I think the focus needs to be on South Central Kansas. It's really southeast central Kansas, but anyway, we all call it South Central Kansas, the 35 corridor.
I think and we do have an SIA hospital in Newton that's been a good partner, early adopter partner. I think, and that's part of why they're interested in that option, which is it is optional for hospitals to choose to do that. You do have to have some psychiatric capacity to start with, but I think why we've had good uptake from Harvey County, Sedgwick County, is because there's a definite need there that isn't being, I'm not saying Osawatomie's not meeting it, but it is at a distance and not addressing the community's needs for something close by. And so
and they probably have facilities that could be adapted.
Sure,
already.
Absolutely.
All right, thank you, Madam Chair.
Committee, are there further questions or comments on this issue? I'm kind of wondering, because I understand that KBC is setting at max down there, and that's a 54-bed, and that's just for our adolescents. It makes you kind of wonder, is 50 an underestimate for a new regional hospital?
While I've been in this role, that's been the question that I can't figure out how to answer, or what the right number is, and I certainly don't want to commit state resources to overbuilding and then having vacant space. Vacant space is what I have now because I can't staff it at the state hospitals, and if we could fill some more positions, and there's a pay plan that's in place the governor's recommended and the Spark Committee supported, so that might help us in the near term. But I don't want to overbuild. Our planning and construction at Osawatomie is pretty limited to use the buildings that are there. But part of that, it was small because of the SIA capacity that we were building at the same time, or building is the wrong word, but developing at the same time. So, but it's hard to figure out what the right number is. And Senator McGinn made a good point too. Is it the acute bed that we need, or is it the longer term placement for somebody who's out of their acute crisis, but they're not ready to go back to the community yet? Kind of step up, step down levels of care. It's incredibly complicated, and I say that as a former Medicaid director, which complexity was all I ever have dealt with. But this one, I can't get a good handle on. So, the willingness of the Sedgwick County area to say 50 beds is what we think we need is you know, I think that's informed by their experience, and I'm relying quite a bit on that as a reasonable place to start.
Well, because see, I can see that, Senator talked about, Southwest, but I see the Southwest, straight down the highway to Sedgwick County on it. And maybe it's a case of we come in with a 50-bed, but design it as such that it can either be added on top, unlike what happened with our jail many years ago. It was supposed to be a case of later on, as we needed to expand, we'd be able to build on top. The structure would be there. Well, guess what? It wasn't. But I think we need to look at, okay, this is what we know today, because it is a hard deal to figure out, but how do we make it feasible for expansion if needed for future bids? Senator McGinn.
So I guess a question I have is, because I think only a couple of years ago we started that whole regional bed, and it took a while to get you guys going and planning and that kind of thing. So where would you say we're at in that process? I mean, are we still trying to develop those regional beds, or have you already said all these different regions have X amount of beds and it's already set?
For the state institution alternatives?
For the
What took the time was to get the state plan amendment written and the kind of contractual relationships. Now that that's built, we can stand up new hospitals, new providers pretty easily. And we've been working, the Hospital Association has been a great partner to point us to hospitals that have psychiatric capacity, and we've reached out to everyone in the state that has a psych bed that's available to see if it's something they would like to pursue. So our ability to stand more capacity up is, we crossed that threshold, and now it's staffing, space. I mean, the same issues that we have, community hospitals have to face to reach out to them. But we do have a couple of new hospitals that are in the pipeline that are new, either not new to the state, but reopening facilities that have been closed. So that will be almost like new capacity, new beds that aren't in the system now. And that's been fairly easy for us to adapt to the SIA process, because it's a provider, you enroll as a provider through the Medicaid program. It's an additional provider qualification. So that's pretty easy. We are kind of limited by hospitals that have psych beds that either have the ability to go a little higher or convert some of those to a more acute level of care.
I would think that if you map that out, I mean, and we could see what the potential is for those beds, then you can back into, but here's how many people we have in Kansas that need more than 14 days, and you can start figuring out the numbers game, I would guess. But again, and then you guys have the numbers on how many people in Sedgwick counties in those hospitals. And I think you could just go look, or surrounding area, and I mean, you could just kind of back it out that way as well, so.
And 50 is close to what we would estimate too, as being what we would need for both involuntary civil commitments and some forensic capacity to deal with court-ordered competency evaluations and competency restoration. We think that's, I don't know that it's exactly right, but it's close.
And one more thing, if you don't, thank you, Madam Chair. And then the probation, folks that get into trouble, our sheriff and those folks have to drive them, out to Larned or to Osawatomie or wherever to get either tested or to get admitted. So our area could save a lot of money if we had a local facility. So, thank you.
Well, and even with this, talking about existing facilities and reopening them, then you still have the issue of how well are they blow molded, which is kind of what we refer to dealing with all the furniture and the ligature and connection, I mean, the whole thing. We ran into that out at Osawatomie. So it's not just a matter of opening up rooms. Are those rooms made for those clients?
For
Senator?
the 7 hospitals that we've enrolled, that hasn't been as much of an issue. And anything that's new, they're building with that expectation. Staffing's been more of the concern, but you're not wrong. If anybody else, that you can't just take a critical access hospital and turn it into a psych hospital.
Right. Senator Alley and then Representative Arnberger.
Thank you, Madam Chair. We did see a report the other day that said that we had about 10, I think, and maybe it was more than that, nursing homes that have closed throughout the state of Kansas. And so those are facilities that maybe we need to look at repurposing them, and they would be they could be regional beds in that location. I don't know if they had any in Wichita. I don't know whether there was in Wichita to do it, but repurposing those might be an alternative to letting them sit vacant.
Well, I think, again, the problem you run into is if we can consolidate in an area or 2 areas to reduce the staffing, administration, because, even if they wanted to open up 50 beds now, I'm not sure we could staff it if we had it ready to open up tomorrow. I mean, we are hitting crucial, dangerous points in the healthcare industry. I don't care whether you're in a nursing home or you're in a hospital. Can you imagine nurses having more than 2 patients in the ICU? That's happening right here in Kansas. And it's not because they want to do that. They don't have the people to cover it. So, I mean, it's hard, but we also know it's going to take a while to build it. But, it doesn't mean we don't look into nursing homes. And maybe there's some people out there in the private sector who can figure out how to do this. Because the other issue we have is with these, traveling nurse organizations out there that walk in and they ask Senator McGinn how much you make an hour, and she says $25, and they say, fine, we'll pay you 75. And she's like, okay, see ya, I'm gone. And that's what's happening all over the country. It's not just happening in Kansas. But it's a big deal, and you can't fault people for saying, hey, if I can make $75 an hour, I'm going to do it. I don't mind traveling. I don't mind changing hospitals. Well, the other thing you have, that also changes our quality of care when we do that, because you don't have the consistency of that staff working together and knowing their patients and knowing, their colleagues. So we're hitting critical in the whole healthcare industry, period. It's scary. Representative Arnberger.
Thank you, Madam Chair. I just wanted to write this down for my notes. How many beds are at Osawatomie, Larned State? And then I was writing down KVC, and then you mentioned, as I was writing that down, that there's 7, did you say 7 other hospitals that are not state-owned? So do you happen to know those numbers so I can just kind of get a rough idea? And then Hayes, is it 2023?
Yes.
Okay.
First part of 2023
That's
would be 50 beds. I think it's closer to 50 by the time they get
50?
completed.
For the kids?
I'll have to check.
The one that we heard about, yeah. Staff
that's-
shaking their
Or
heads.
Andy may be on the,
For the kids is 14, out in Hayes, yeah. And KBC in Wichita is 54 beds, and those are all youth beds.
54 youth.
And I think the one in Hayes are PRTFs.
It's going to be an acute psychiatric hospital.
Okay.
So to answer your question, Representative, so at Larned, for the kinds of beds we're talking about, we've got 90. We're currently staffed to support 72. At Osawatomie, we've got 52 acute beds and 110, we call them state certified, but they're longer term beds.
Okay. And then do you know KVC in Kansas City? How many are in there?
Though the SIA hospitals, we don't contract for a specific number of beds, they're available to serve our patients. So we don't actually have a bed count per hospital, but they do have. So for example, in a typical, or this week, or last week, reporting that one of our SI hospitals, Cottonwood Springs, that's in Olathe, I think, had 8 admissions that were SIA. Prairie View, that's in Newton, had 1, but they've been hovering closer to 3 or 4. And that's a pretty typical week.
Okay, and then isn't it true that for Larned, that it is built, though, it could have over 100 beds total? I remember my sheriff talking that back in the day, you could have a lot more patients there.
So the number that I gave you is for our psychiatric services program. So that's the part that serves civil commitments. So they're committed by the court. The state security hospital, which takes criminal cases. Our maximum capacity is 140. We're at 100 right now. I think we're a little under 100 today, but at 100. So we could be up at 140, but we've got a vacant unit that we can't staff.
Okay, thank you.
Committee, further questions or comments? All right, seeing none, Scott, again, thank you very much, and thank the
My pleasure.
secretary.
I don't want to leave Senator Alley with the impression that we wouldn't go a building unused if it was vacant, but the kind of beds that we're talking about for really acute psychiatric patients, they have to be secured, so we generally locked or have some ability to lock rooms, and we talked about ligature resistance, so you have to ensure that any place there's a corner or an attachment or a fixture or anything hanging on the walls that you can't, you couldn't risk ligature or hanging somebody from that. So it would require a lot of work. And then the security part, most nursing facilities aren't secured to the outside. So that we'd have to think about that.
Senator Alley.
Well, thank you, and I fully agree with that comment. But you have to do those building new, and new is a lot more expensive than remodel.
That's true. I just didn't want to. No stone goes unturned in our world. That's for sure.
Yep. Okay, committee, any further questions or comments? Did you have one, Representative Carpenter? No? Okay, I'm just checking.
I was surprised too, Madam Chair.
Again, Scott, thank you very much. No, he doesn't get to, he doesn't get to ask any more questions.
If you're going to dog me like that, then Scott, I just had a question. You're working from home. Do you always dress like that at home?
Yes. Yes. As far as I'm going to tell you, Representative, this is the way I dress when I work from home.
Very good. Very good.
None of us do. But thank the secretary as well. And again, appreciate you coming out to be here and answer our questions so we can move forward.
Our pleasure.
All right. Okay, so I think we've kind of done our roundtable discussion, wouldn't you say, Orida?
Madam Chair, I believe we've done a lot of discussion. I'm not sure it's as specific as what you had indicated on the topic. You had a roundtable discussion on key recommendations from 2020 Special Committee report and the proposed report. And it was with the idea of providing input from the roundtable as to what they believe the most impactful recommendations have been that have been implemented or have been proposed.
I don't know, I kind of feel, and I understand what you're saying, but I think that we can probably go into if you've got some more things that as staff want to go over with us on, I think the questions as we went along, I think was was helpful. And we can still have, as we work our recommendations, if we have some folks online or whatever that want to interject, or they say, hey, we did talk about yada, yada, but it just wasn't put in the report or the words weren't, so.
Of course, Madam Chairperson, that's at your discretion, whatever you prefer.
Well, but you're also good on guidance to make sure I stay on track. That's what makes me as good as I am, is because of staff. I don't do this myself. Okay. Nope. I'm down here. So now we're ahead. All right, committee, now it is time for us, and again, as those online that have been involved, if there's things that you hear us talk about or recommendations that you think a highlight could be made from your input, we will welcome those at this time. Or as we go through this process, we are going to start committee. If the way I tracked it on my notes is the way it was presented. So I'm going to go through each one of those items as they were presented and see what the committee feels that we should or should not do. So we will start on page 11. And we have 1.2, which was a request of a post audit. It would be my recommendation that we do request a post audit, and we'd have staff kind of review the writing in this report and see if there's anything else that we need to add to request of what we want post audit to do. And then what was discussed is we want to make sure that we include social workers and other mental health, behavioral health providers. And input can also come from staff. Senator Hawk.
When we mention the other mental health providers, my head automatically goes to BSRB, but I think we also have some nursing professionals that deal in behavioral health, and I wonder if there's some other professions that deal in that. It would seem logical to me to include those in BSRB as well as any psychiatric nursing professions, and I'm not sure if there are any others besides our traditional psychiatrists that we were thinking about originally in this area.
Kyle, are you still with us?
Yes, Madam Chair.
Okay, I think maybe between Kyle and possibly Andy is, do you have an answer for, and I understand where Senator Hawk is going, is making sure that we pick up all of those in this area. So if you have language for that, we would welcome it at this time.
Andy has been talking about this.
That was a big sigh, Kyle.
That was unintentional. I was gonna say, I think that Andy has been talking about this and working on it probably a little more comprehensively than I have. So I would defer to him, but
all right,
certainly
he's in the room. All right, he's in the room. Andy?
Andy Brown with KDADS again. And so we are, like to sort of try to answer that particular question, I think if you cover BSRB and the Board of Healing Arts, we would cover everybody that we need to have covered.
Okay.
Maybe the Board of Nursing as well.
Oh, Board of Nursing?
Yeah. Madam Chair, I had another question. I think you as chair are a lot more successful at getting post audits than perhaps I have been on some things that were near and dear to me. What if we don't get a post audit? Is there some other group that might logically help us with that? I agree post audit would be the best solution, but I wonder if there's some other group, be it KDADS or, and I don't want to ruin my relationship with legislative research by suggesting them, but.
Well, no, no, that wouldn't be fair to them. Last year, if I understand this correct, Carrie, and correct me if I'm wrong, is that we were wanting KDHE to do a study, and, either we dropped the ball or they didn't read the report or something. So I think that might be why we're on page 11, Carrie, is why maybe nothing happened with this. And I believe in the working group, it might have been my recommendation to do post-audit, wasn't it, Gary?
You are correct, Madam Chair. This is Carrie Breffett with KDADS, and I'm actually opening up last year's report. So it is, see, you can read these together. So the recommendation last year was, you're exactly right, require a study be conducted by KDHE with an educational institution to explore strategies to increase the number of psychiatrists, child and adolescent psychiatrists, and psychiatric nurses. So it was a little bit more limited recommendation, but it had that KDHE working with an educational institution.
But nothing happened with that, to the best of our knowledge.
Well, comment. I would guess because your previous report was so successful and impactful that you're likely to have enough interest from, and I don't know who's on post-audit. I think Senator Alley used to be, but nope. But I would hope that maybe we would get favorable vote on that in post-audit. And so I'm willing to leave it as that. If I guess if it doesn't go through, then maybe we want to regroup next time we do this and see if there's a university institution or an agency that could pull it off if we can't get it done. I think it's an important thing, and I want to make sure something gets done to look at it. So.
Well, and I agree with you. Yeah, I would have preferred the first one, but when it didn't happen, and the reason I don't know if my success on post-audit, because I don't request a lot of them, is any better than yours, but I could see that being more expedient than maybe the other. We could ask that if we don't get the post-audit, that perhaps our budget committees consider a proviso in their budget to make the same request of KDHE and a university.
Should we put that in the recommendation or just have that in our back pocket to see what happens?
What would be your preference, Representative Carpenter? Well, I know, but about adding language that if we don't get the post-audit, that we ask for the budget committees to put a proviso in the budget to ask KDHE and, okay. So is that as clear as mud, Orida? Is there further discussion, comment on 1.2, page 11?
Madam Chair, this is Kyle Kessler.
Really?
Well, better late than never. I think that my question on this also was related to the graduate student loan repayment program or graduate medical education piece. That might have been the specificity reference. And Dr. Warnes would maybe weigh in on that. But I think that was also someplace where the potential post-audit had tied in. I think that was even discussed on the Senior Care Task Force a little bit the other day. Because several years ago, psychiatry was added to the graduate medical student loan repayment program, which was through KDHE. And I don't know that there's been much in the way of progress through using that.
So are you recommending a different change than what we just talked about?
No, not very much. Really just this as an example, using it as an example.
Okay. So we're good with 1.2, everyone? Senator Fagg.
Thank you, Madam Chairman. You know, when I read through this, I know with us needing psychiatrists and in that field, we're kind of looking at the tree and I'm thinking the forest. And where I'm going with this is whatever psychiatrists we have in the state today, it'd be interesting, where did they come from? What brought them to Kansas? You know, see if they're Kansas-born people or not. Because I have a problem in getting a program and then moving out of state after we train them. Or do people come to the state for some reason? Just trying to understand the dynamics of how we got the people we got today. And maybe
That's probably a good question to add to that, Orida.
And that could be kind of something to maybe help build on.
To the post-audit.
Just a thought.
Okay. Anything else on 1.2? All right, seeing none. 1.4, page 12, investment plan for workforce. Oh, I know what I wanted on that one there. This was confusing to me during the work group, and it was also confusing today, and I did notice, was that Charlie that did this one? Is he cleaned it up? It should read this, on that first line there, Carrie, is the state should establish a University in Kansas partnership. Because we read that Kansas University, and we're thinking.
You're thinking KU?
Maybe,
Yeah.
I wasn't going to say that. I was going to say something that's blue and red. That's all I was going to say. But yes.
And we made that note during the working group meeting, but it's in the language below in the rationale, but it would be good to clarify your point in the recommendation itself.
Yeah, so that's the only note I had on there. Has anyone else got anything on 1.4, page 12? All right, seeing none. 1.3, page 13, the MAT training. I think the recommendation that we had through our discussion was to report data to CanCare Oversight Committee. In addition to what our report said, anything else, committee? 1.3, page 13. Unless I wrote a number wrong.
No, it's correct.
Carrie?
It's the one that's actually just in text. It's not in a box. It's a description. It wasn't a separate, it was additional report language.
It's not a 1.3?
No, you're correct.
Oh, okay. I said, man, my notes are bad now. Okay, moving forward, 2.4, page 16, the suicide prevention.
This was a, oh, no, it's fine, it's okay.
No, 2.4. I think, okay, the only comment that I added to that was that, I'm just not convinced that we can probably use the 988 funding. Would you be inclined to agree, Andy, or not? Doesn't mean that we're saying no. If we found out we could, that'd be fine, but we know we have a lot of other things.
Yeah, I think we're hedging our bets, right?
Yeah, so I would, yeah, so I guess, was that just brought up in discussion, or is that in that language?
Madam Chair.
Yes.
So this is Will Warren. So that telecommunication surcharge was pretty late to the party on the discussion on this recommendation. I don't think the working group was really aware that that was a conversation piece. So we put it in there, but we also tried to do some tap dancing in our language there. But that, because I think you've done a great job of communicating to us some of the difficulties with that surcharge, that if it wasn't implemented, that other funding would be needed. That was at least our thinking. And that language is there in the rationale for revision.
Right, down there towards the bottom.
Yeah.
Yep. Okay. Additionally, the working group clarified that one recommended source for the critically needed would be. Is there a big objection, committee, if we pull that line out? I don't want to give anyone a reason to be shooting down our 988 funding as we go through. So I just as soon remove that out of there so it's not tied to it whatsoever. I'm on page 17.
Okay. Gotcha.
Right down here. It's about a little over halfway. Just additionally, the working group clarified that one recommended source for the critically needed 1.5 million would be the telecommunications surcharge for 988 suicide prevention lifeline. Recommendation 4.1. Just strike that language from the report so it's not confusing. Is that all right, Carrie? Huh? Yes, the whole sentence.
And the next sentence refers back to that as well.
Oh, the next one too?
Yeah. But the rest of the last sentence is not, yeah, it could, is that what you're saying, Senator? The last?
Well, regardless of the source,
Right.
funding is needed.
Right, correct.
Senator Hawk.
We're going to deal with the surcharge or the in another recommendation, right?
Yeah, that's not, that's just saying we're not going to say this gets possibly funded with that surcharge because it shouldn't even be tied to
I
it.
just didn't want to not do that.
Oh, honey, I'm all over 988, let me tell you.
I had a sneaky feeling that was the case. Thank you.
CCBHC was it last year, this year it's 988. Okay, so I think Senator Erickson had, because we want people to understand that funding's needed for this. And I'm not reading where you were at, Senator.
The sentence that you recommended striking, the next sentence says the implementation of recommendation 4.1 will determine access to that funding stream. That should be struck. But regardless of the source, funding is needed, should be kept, in my opinion.
Yes, I would agree with that.
I would too.
Did staff follow us? I love it when everyone shakes their heads. That it's like we made sense to them. It's a wonderful thing. All right, is there anything else on the, what number was that one? That was the 2.4.
Yeah.
That would be nice to see that happen, huh?
Okay.
Senator Fagg.
Thank you, Madam Chairman. I was just trying to wrap my head around the 1.5 SDN, where we come up with the 1.5 number. I know where 250,000 that is, includes the farm. How do we come up with 1.5 million? Where'd that number come from?
I think that was that something from KDAD's? Okay, Andy's right here to answer that question, Senator.
Yeah, that's a KDAD's estimate, and it would include the staff position and the coalition funding.
So the 250,000, the 90,000, and is there one other?
Yeah, there's the remainder of the funds will be used for the KPICI
Yes.
program. Yeah.
Go ahead, Senator.
Okay. I'm just trying to say what the kind of budget for the rest of the money is what I was trying to come up with. Is that enough, not enough? Exactly how that was arrived at?
Right now, we're at 0, so 1.5's quite a bit to get started with, I think. And we'll be looking at how those funds get used across the state. And if we see that there's a greater need, we can come back and ask for more at another time.
I have Senator Hawk and then Senator Alley on the same thing.
Yes. In terms of funding, I don't remember exactly, and I thought we put general fund money in the AG's office for that app and social media suicide prevention program that we discussed earlier today in other meetings, but does anybody know what that was and if it was state general fund? And I might, it seemed to me like it was $250,000, but I'm not sure.
Oh, and we don't have
And-
budgets
and I
for
don't-
people.
From our discussion where we talked about trying to coordinate with these other things and they might all have a different piece of the puzzle, I still personally have doubt about whether it's smart to have a lot of different agencies dealing with this, but that's another discussion. But are we intending to keep all of the things we have going, the KDHE and KDADS and AG office? Is that all part of this, or is this strictly just that KDADS portion?
And I understand what you're saying, and it's also something that I try to pay a lot of attention to, is how do we reduce and not necessarily increase. I think that we can keep this here, but we as legislators then need due diligence with all the committees that we deal with and watching this process is if there is duplication as we go through our work. So some of it kind of comes back on us.
I mean, I'm sort of advocating in the short run that we keep doing all the things we're doing because I think it's a huge issue. I didn't want to leave something out if it was critical. And if it's just common understanding that we're going to keep the things we're doing, work hard to coordinate it, I'm good with that. I just didn't know if we needed to say anything in this recommendation to that effect.
I don't know that we do unless you see me use the word delete, and I'm pretty blunt when it, if I was going to delete something, I would come right out and tell you that I was going to do that, but that's not the intent right now. And I know that there was, we consider them small requests, but we know that they're big. $1 million here and $1 million there. Next thing you know, you're at $10 million real quick. And so we're very much aware of that, and we will be absolutely watching that as we go through the budget process. So even though, CanCare made recommendations, we make recommendations, it doesn't mean we're all going to get it. All right, thank you. Okay, so that puts us on 2.4, page 16 done. Wait a minute, I did have one question on that. Are we aware if there's any grant opportunities out there, Andy? So you'll be working on grants as well, possibly?
Yeah, so SAMHSA does offer some suicide prevention funding for things like youth suicide prevention and for suicide prevention that's targeted at specific populations. So
Let's make mention then, staff of the agency looking at grant funding as well, besides just SGF. This is why I had to make notes the whole time I walked through, because till I flipped the page, I'd forgotten that one. Senator Alley? Sometimes you got to wave and make sure Barbara sees you.
I can't see.
Oh, and then I forgot you. Oh, I'm sorry.
But thank you.
You didn't.
That's
tell me.
okay. Thank you.
I just saw it because he saw it.
Thank you, Madam Chair. I did get a email from Connor on that. Is that correct, on the funding from the AG's office? Could you give us that, please?
Madam Chair, I provided the memo to Senator Hawk and Senator Alley that was presented at, I believe, the October 28th meeting of this special committee from KLRD, which is an overview of the AG's youth suicide task force and the related office, and it includes at the end funding, and I'm sure Matt Moore could probably do it better, but I could literally read it.
Yeah, if you can just pull that up, that's fine. Because as you know, we see so much, and then we think we didn't see something, you're like, oh, yeah, I remember that. So I think he's just looking for the amount right now.
Yep.
Sure thing. Matt, please correct me if I'm wrong here. Youth suicide prevention with the Attorney General's office has been funded entirely from special revenue funds, the Victims Assistance Fund. Expenditures for the program through FY21 include total $72,635, which have been used to fund the part-time coordinator position. During the 2021 session, the legislature added $100,000 in FY 2021 and $50,000 for FY 2022, all from special revenue funds for the creation of the mobile phone application. RFP was issued in FY 2021 and currently remains open to develop the mobile phone application and associated website.
So with that, we do know that there's a special victims fund that funded $100,000 or so. But could we not just have a coordinated meeting between KDADS and the AG and say, let's get a recommendation from both organizations? That was a coordinated recommendation, because I don't see a coordinated effort here with the AG's office. I see us, from what I see here, we're going to take the lead, KDAD's going to take the lead, KDAD's getting the money. What's the AG's office supposed to do? If they're not supposed to do anything, if we're taking over that, so be it. But could we not get that clarified?
Okay, unless I'm misunderstanding things, and Andy, you can probably help with this, is that we're talking two different programs, and the coordination is with the, is it the suicide prevention? I've attended some of their meetings, and that's where the AG and KDADS and everybody and some providers are on that, correct? That's where the coordinated piece comes in.
The position is.
right, so Andy Brown with KDADS again, and we do have a regular meeting with AG's office and their suicide prevention coordinator. We do coordinate all of our work with them. They were part of writing the state plan. which includes this recommendation in the state plan.
Is the AG's office aware of this recommendation?
I believe so because they helped write it in the state plan.
Connor, I'm sorry, Rita, I forget, you're not. You have both been a great team the last few days. Let's see if we can get hold of someone with the AG's office and see if they got someone that could answer that for us. If they want to WebEx in, that's fine, but if they can run over, that would be good too. And then we can get some clarification for you, Senator.
Thank you.
Okay, so what we're going to do then is we will come back to 2.4, page 17 as an incompleted item. That way we can keep moving forward. Was there any more questions on that we needed to answer? Okay. Now we're on 3.3 and page 18. And I'm just, my notes are what can we do? What are we able to do with this? And I don't know whether, Jane Addams, are you still with us?
Yes, I am.
Do you have that report in front of you by chance?
No, but I'll look for it real quick.
Okay. And I don't know, Carrie, if you can maybe help us a little bit as to, because I'm just a little lost on what we can really do with this piece. I mean, I agree with this, but.
What's the legislature's role
Yeah.
and so on. So this is, and I don't know if Brenda Soto from Department for Children and Families might be on, but as I think Shane Hudson talked about earlier, part of the idea of this revised recommendation was to add to the idea of the previous recommendation to invest in the foster home recruitment and retention by adding additional steps in the recommendation. So it's sort of like recommended for DCF to do these things to help build up support for a system that supports foster families. So not just the education for foster families, but enhancing the system. And these individual elements were actually suggested after discussion with DCF on some of the things they're working on and trying to implement, and then other parts of the system that could be improved. But I'll stop talking and see if Brenda or somebody else from DCF might be available. But those 4 specific items came from discussion with Department for Children and Families.
Brenda, are you online with us?
Yes, Madam Chair. This is Brenda Soto with DCF. Thanks for having me. Excuse me. Yes, so we've been discussing future plans, and I've developed a strategic behavioral health plan that my team will be working on. And one of those things is we're looking over the next few years at the current clinical models that are being used through our CMPs, our case management providers, and seeing if there's any models that we can use to move forward across the state.
Brenda, I don't know, we've got a bad connection. If we can figure out how to fix that maybe, and it's because it's your audio. We can see you fine, it's your audio. Maybe turn off your video. Let's see if that helps it. Sometimes it changes the bandwidth. Talk to us now.
Can you hear me well now?
Nope, it's still garbled. Is there anything that we can do on our end?
How about now?
That's better, right?
That's better. We're using a microphone?
No, I just switched the, I don't know what it is, but they've shown us all these techniques to fix things and it worked.
All right, this works great. So now please, start over because it was pretty garbled, hun.
My apologies. I probably sounded like Minnie Mouse. So I've been working on a behavioral health strategic plan, and we're looking at building capacity and looking at foster homes and what type of additional foster homes we may need for our continuum of care in Kansas. And so with that, I have planned for the next year, really the next 6 months, to have conversations with Missouri and possibly Oklahoma, who have different types of foster homes that might meet the criteria that we're looking for here in Kansas, and be able to expand our ability to have foster homes that meet, that would be able to have higher levels of training, but also would take those higher level of need children. And then in addition to that, we're looking at building capacity for clinical models that are being used. So I also have, in the next 6 months, I'm going to be working with the CMPs, the case management providers, and looking at the clinical models that they're currently using that are evidence-based. Some of those might be PMTO, you guys have heard about parent training management, the organ model. There's PCIT, parent-child interactional therapy. Additionally, there's BI, the behavioral interventionalists. So we're looking at several of those to see if we can expand them possibly across the state as another mechanism of getting clinical services into homes versus having kids leave to go to higher level of placement to receive treatment. Does that answer kind of your guys' questions?
Well, I guess we're, it's like, okay, and this isn't against you, Brenda. It's like, I don't feel like I'm hearing anything new. We're going to try to do this, we're going to try to do that, and we're not succeeding out there. So I guess I'm looking for more definitive that this is the action that can be taken. Because we can sit here in Topeka all day long and talk about the welfare system. But until we actually have the frontline workers actually doing what we talk about up here, we don't achieve any change in the welfare system in Kansas.
So, Madam Chair, I completely agree. And so let me also add that our stability grants that we have started are focused on the BI intervention with Cornerstones of Care and with Foster Adopt Connect. And then the other stability grant was provided to KVC, and they're working that one through PMTO. So we have started the work and we're seeing good progress and good results. That's why we're looking at how do we take those models and possibly expand them across the state, and what would that take? And what would that look like?
Okay, did you have anything, Jane, to add to this?
I haven't been part of that discussion, but would like to call Brenda tomorrow and continue it. How's that?
That sounds like a good plan to me, if that's all right with Brenda.
I would absolutely love to have Jane call me.
Okay. Well, I just, we've got to figure out how to start resolving some of this stuff instead of talking about it, because I've been up here way too long and we're still talking. So I
Madam
guess
Chair.
Yes?
My apologies. This is Sandra Berg with United Healthcare. And part of the rationale for the 90846 code was to help support some of the interventions that Brenda mentioned, because for Medicaid recipients or Medicaid providers, they could not bill for some of the components of those evidence-based practices. And so it was difficult for them to implement them. But now with that being part of a proposed state plan amendment, those practices can be implemented across the state and get reimbursed for.
Okay, and I appreciate that, and we'll be discussing that here in a little bit. I won't hold my breath, but I will look forward to it. How's that?
Sure.
All right, thank you. So anything else on 3.3, page 118, or 118, 18? All right, then we have 3.4, page 19, and if I understood the solution here, as the CCBHCs come online, this may help address this issue. Does that sum it up properly? Carrie?
Carrie Breffa with KHI. I'm not sure if any of the co-chairs want to talk about it. So yes, I think the discussion was CCBHC will help address it, but the revision was to note that they also wanted to expand the availability of this to other providers other than CCBHC. So keep in mind other provider types, including SUD providers. So that was the primary purpose of that.
Okay, thank you. Any other comments, questions on that? All right. Next, we have 4.5 on page 20. comments, questions? I guess I'm just a little confused with this pilot project. Perhaps someone can elaborate. Whoever feels qualified is fine.
Charlie, are you there? Or is this 4.5 about trauma-informed?
Yes.
Trauma, yeah.
Yeah, so this is the establishment of the, sounds like it's already underway, working group to develop a potential pilot project for the dissemination of best practices in trauma-informed care, learning from those who have implemented those practices.
Okay, not something we have to do because it's already okay.
They're rolling.
Any other questions, comment, huh?
Yes, when the working group was talking about this, Wes Cole from the council had wanted the working group to know about the work that is being done at Osawatomie. And I know that a lot of the information from what's being done down there is going to guide some of this talk about a pilot. I'm not 100% clear if Osawatomie is the pilot or if it's going to lead to another pilot, but that's where the conversation is starting right now.
All right, thank you, Dr. Warnes. Committee, any?
Chairperson, this is Charles Bartlett again. And yes, we had started discussion on that. We will include the representatives from the hospital who has been working with the Addiction Technology Transfer Center in the project that they had that was set up. But also there's some other organizations in the state that have made tremendous forward movement with this also. So we're trying to get kind of a rounded piece around the state so we have a real good picture of what's going on and then look at recommendations from there.
All right, Senator Erickson.
Thank you, Madam Chair. Quick question on the potential for high impact section on this item. Increased behavioral health workforce capacity for implementing trauma-informed practices will help address inequities, particularly for those children in foster care. We see the word inequities a lot. Can you maybe expand on what specific inequities might be addressed through this?
This is Charles Bartlett again. I think that in trauma-informed that you really start looking at cultural specific ways of helping people within their environments, and also trying to look at the understanding across racial and ethical lines to make sure that their practices fit with the clients that's being served, as well as trying to make more of the workforce to reflect the client that is being worked with.
Thank you, Madam Chair. Just when I see the word inequities, it seems to me that someone is operating at a disadvantage. And I don't know that culture and race is necessarily, I mean, can you expand upon how those are inequities or disadvantages? I guess that's what I'm getting at. Thank you, Madam Chair.
I don't want to step on what you were saying, Charlie. This is Carrie Bruffett. So one of the components where this part of the report comes from is there's a checklist on that rubric which does ask about are there communities or there populations that are disproportionately impacted by an issue, potentially, and that this intervention, whatever it is, this is for all of the recommendations, might be able to help address. So I think here it was called out for children in foster care, so children who may be impacting some of the adverse childhood, or may be impacted by adverse childhood experiences, for example, or that enter adulthood and having been impacted by those experiences. So there's sort of the disparate impact on those folks who have experienced that, whether that's violence in the home, in the community, if that's the impact of separation from the family, for example, going into foster care as an example. So that was one that was called out by the working group as part of a sort of the survey process. It wasn't extensively discussed as the primary reason for the recommendation, but more like hey, this is why we would think it has a higher impact Even if it may have a smaller number of people impacted, it can have a big impact on the people it's impacting. I think that's part of the idea. But Charlie, I'm sorry if that's not exactly where you're going.
No, that's just where I was.
Well, and this is well warranted, and it could be fair that maybe a different word other than inequities would better summarize it. You know, help address the disproportionate impact on select populations, particularly for those children in foster care. That would be fair.
The senator liked that explanation, Dr. Warren. Okay, any further questions, comments on 4.5, page 20?
Representative Landwehr, I'd like to say something. This
Yes,
is Jane
Jan.
Adams. I'm really glad to see that this is a discussion item and an agenda topic, because I worked with several colleagues, some national, to look at like a 15-point, if you're getting or seeing trauma-informed care, if your child is getting trauma-informed care, would you, if you've seen these things in practice? And I haven't found a family yet who says, yes, I've seen that, or that's been part of what we've been given, either at a school or a mental health center. And so I've only talked about 25 families to date, so that's not a very big sample. But I worry that trauma-informed care is more of a buzzword than it is an actual practice. And so I think doing a lot around parameters of what is it and what isn't it. And so I've seen a elementary school principal chase a kid down a hallway here in Topeka and tell me, though, that he is a firm, devoted trauma-informed care person. I've seen a mental health center where the respite people don't have any training. So I don't know, and my experiences are limited to people who aren't getting the help they need. So I'm really glad to see this committee take on this.
Thank you, Jane. I think that we're hitting some highlights, and we just got to keep this ball rolling so that we can continue with mental health. Representative Ballard.
Thank you. I don't really have a concern with the word inequity, because inequity says to me it's not a level playing field, that we're not all the same, and that we're treated differently. I'll use an example yesterday, and we had, I can't remember the parent whose younger child, I think, has cerebral palsy or whatever it was, that she was undergoing with her child. And then her older daughter was actually being affected by the fact that the younger child was taking all the money, really. Mom was spending all this time with this child. She couldn't give the other one what she really needed. And mother was really caught in the middle of the time she has to spend with the child that has this extreme disability, and that the sibling is being affected by that too in the family. And so there wasn't enough money to do all these things. Well, to me, that's inequity, because the other child, it wasn't her fault that the other daughter was born that way, but it was less time, less money, less everything for her, and she was trying to make it up to the other child at the time. So I think sometimes when that happens because of a disability, often people will treat the other person a little differently. And I think we have to realize that it's not fair to the sibling, but it's no one's fault. It's just a situation in the family. And I think it's adjusting for a disability, for a mental problem that's going on in the family, not enough money to give to all of them. So I think that's what I read in this, is that we have to allow for those kinds of things. And I think that's what they mean by just not, I guess life's not fair, basically.
All right, committee. So we're going to go to, that completes 4.5, page 20. Unless there's objection, we're going to go to 4.6, page 21. And as I'm reading through this, I'm trying to, I understand the rationale, but who do we need to direct this to? I don't see where it's directed to anyone to necessarily address it.
This is Andy Brown with KDADS again, and I believe that's going to be our lead.
So do we need to put KDADS in here so that we know that it's going to, that KDADS is? Where? Oh. I'm not going down that far. I'm just reading in the body. So, okay, thank you. Okay, all of you, my copy was blurry. Yeah, okay, whatever. Remember, you got to work with me next year.
We did this yesterday. We got her yet.
Okay. All right, so that answers our question there. So is there any more discussion on Representative Arnberger?
Thank you, Madam Chair. I just have a quick question so I can understand correctly. I'm looking at the ease of implementation, and it says cost will be a barrier. But then you go on the other side, second bullet point, it says high potential for cost savings. So is the cost on the ease of implementation side, that would be extra funding going to KDADS? And then the high potential cost savings, would that be on the local level? If I'm understanding that correctly, or who's going to save money?
This is Carrie Bruffett, and I can defer to any of the co-chairs. But in general, the way that the working groups use the rubric is on the implementation side, it's sort of the frontline cost, the initial investment is what is the impact, what are you going to have to come up with? And then on the other side, the potential for high impact, they have an opportunity to try to identify, well, here's a way that investment could be paid off in the long run by lower costs. So yeah, potentially local, or maybe it's other programs outside of KDADS, other programs in the, maybe it's even hospitalization or something like that. So I think that's the idea. Then you see that throughout a number of recommendations. So I would defer to the working group members about this specific one, but that's why they can seem like they're contradicting sometimes.
Okay, yeah, I highlighted all of that in all of them, and I was going to discuss it earlier, but I just wanted to make sure that I fully understood it.
Representing Lynn?
Thank you, Madam Chair. I'm wondering if in 4.6, if it's the adoption of the screening tool that is assumed to be costly versus the importance to discuss the social isolation, because I almost feel like the social isolation could be combined with 4.7 with discussing the stigma with behavioral health. I'm not saying it should be, but I'm wondering, because I feel like the screening tool and the importance of discussing social isolation are two different things.
Carrie?
Carrie Bruffett again, but please, roundtable members, working group members, chime in. I'll just try to remember what you all had discussed. So I think the idea of the screening tool is just a way to increase knowledge, provider knowledge, and identify folks who might be impacted by social isolation, which is a different part of the strategy from let's do a campaign to talk about social isolation. So there may be different parts of a process to address social isolation. So once we're aware of it, how can we identify it? And so those particular tools were just examples that were given. And I think the idea is the awareness campaign would raise awareness among providers of using that tool. So not so much that, to pay for the use of the screening tool. But again, please, working group members, chime in.
Yeah, so those of you on virtual that worked on all of this stuff, it's, you can voice your opinions and what you heard and stuff, and it all doesn't have to come from Carrie, because she's just bouncing, we got her bouncing up and down to go to the microphone. So any more discussion on 4.6, page 21? All right, seeing none, that one's done. Committee, I'm going to call a 5-minute break, and then we will reconvene.
social isolation.
What's that?
Remember social isolation, that was one of the reasons for Meals on Wheels. Because people would deliver the meals and sometimes that's the only people they saw come in and out. And now we have fewer volunteers because the older people
It's a nice 73 degrees out there with the sun shining, but the wind,
Look at that wind out there.
yeah, but the wind is awful. Where was it, Tori, you said was shut down?
Great Bend.
70? Yeah. So that tells you what's happening out there.
Uprooting trees and stuff.
Who did?
Right there. It's uprooting trees.
Oh, really?
Yeah. Oh, you
Don't
have
say that stuff.
You have an alternative.
You're on recording, you know that.
I used to hope that when I needed a new roof.
All right, committee, we're going to go ahead and get back on target. Now we are on 4.7, page 22. This is build on success stories to help get rid of stigma, because everything mental health impacts, all these, other issues with the anxieties, the traumas, the migraines, diabetes, I mean, it just, heart disease, et cetera. So is there any language changes or anything that we need to address on this one? All right, seeing none, we will move on to 4.4, page 24. And I believe that, let's see, 4.7. I don't see any changes that, unless the committee does on that. All right, seeing none, we will go on to 5.3, page 25. Frontline capacity. And this was, part of this was in the CanCare recommendations, isn't that correct?
Yes.
Connor? Can you help us, Connor, as we go through here, when there's correlation to what CanCare recommended in their report, or they will once it gets finalized, that we could make just write a note of that, so we add that to our report, and then we make it aware, okay, there's two committees looking at this here. Let's pay attention to it. Is that good? What I CanCare oversight recommended as well. Okay, then that puts us to 6.6, and this is the Medicaid postpartum, page 25. And again, this would be a from the CanCare report. And I believe that we're looking at a $10.5 million fiscal note, all funds, and that will be changed in the report accordingly. Other than that, and adding the CanCare committee language, I don't think there's anything we need to do on this. Does everyone agree? All right. Then we are on to page 26, and I didn't put a number on that.
26.
Why did I not do that?
What do you mean, 26? Oh, this was just language.
On what, 26?
26, it was language only.
But why did I flag that?
Madam Chair, I think you'd asked about the autism task team.
Oh, that's what it
yeah.
was. Right, okay. Yes. But again, I want to add into this report the CanCare notation that it was also recommended from the the whole Bob Bethel, how to do, I just say CanCare, so. All right, and that ends the workforce working group recommendations, is that correct? Yes. All right, now we are 2.6, page 14. Comments, questions? Representative Arnberger.
Thank you, Madam Chair. I guess I'm confused. Is that the end of it, or do we need to go over on 27 and then all the way into telehealth on 10.6?
We are going in order that it was presented to us today.
Okay, okay.
And that's why my notes are in that same order, not in the order of the report. So we're bouncing.
You're just confusing me.
That's
Thank
not-
you.
Yeah, I'm not going to go there.
I'm so sorry. That's how I was doing mine too.
Here's one of the things that I'd like to discuss with the committee on that. I mean, I've been in support of expansion for a long time. And the success of this program is not in doubt. And I don't know if any of you have ever had the opportunity, and if not, we can get it for you. It's the quarterly report that's released on this program that tracks every single child. And even if the child moves, we can still track that child. And hopefully they go to a school that has this program in it. Because when you hear about 55 school districts, that doesn't mean the number of buildings. That's just the districts that are utilizing it, but they're not, all their buildings are not necessarily utilizing it. The only cost to the school on this program is the liaison. And the liaison is kind of like a traffic controller. They take information in, and then, you know, maybe it's a teacher, maybe it's even a student, but recommendations get made, and a decision, then they connect with the CMHC, and the services get started with the child, and they actually get started in the school building. And they happen in the school building. The difference between having, and the CMHC staff in there providing it there is, then the CMHC staff is available 24/7. So when the school's not open, they're still available. Many of these school buildings actually stay open late in order for services to be provided on site as well, because this is a true wraparound program to where you may find the problem that the child is having is mom or dad lost their job, or someone died in the family, and those family members need some assistance as well. Well, then the CMHCs can bring in the family unit. Maybe it's a fact of they're trying to figure out how to make their rent or buy groceries. Well, again, the CMHCs can direct them to the services that will help them with their situation at that particular time. When the program first started out, it was believed that the liaison needed to be a master level social worker. As we progressed through the program, we realized that that wasn't necessarily the need after we worked out all of our kinks, figured out exactly what their responsibilities are. And so we moved it to a bachelor level, and that means any degree of being a bachelor. Because again, it's just about being able to coordinate and organize and seeing that these kids are getting their services. When the program started out, we paid 100% of that liaison, the state did. And again, it was a pilot. We needed to know what was good, what was bad, what needed to change. Then some schools are now paying 25% of that liaison, and the state's still paying 75%. It was my intention when we expanded this that at some point the schools would take on the responsibilities of the liaison. And by lowering that to a master's level, then we're looking in the $40,000 to $50,000 range versus the $80,000 or $90,000 range of a master level. The schools have balked at that. And here's why I have a problem with it. We have not been able to put a pencil to it and say, this is how much money this program has saved a school building. But common sense tells you, if this child is now becoming productive in the class, is not tardy, is not absent, grades are improving, and they're graduating, and you don't have to have a teacher devoting a lot of time to that child because they're still acting out, et cetera, whatever it is that their issues present. That burden is put onto the CMHC. And the CMHC is paid by whatever they bill in Medicaid. And a CMHC can bill more Medicaid codes at a higher rate. And once these are FQH or CCBHCs, they'll be able to bill at a better rate. They can bill CHIP. A school district cannot bill CHIP, and CHIP is our children's Medicaid insurance program. They also can bill private pay insurance. And then the state does give a small portion out there to the CMHCs for uninsured. And for those that are not real familiar with our CMHCs, a CMHC has to take all people that walk in their door just like an ER. They cannot turn you away. They are required by law to do that. So, and I want if someone disagrees with me, I want to hear that discussion. Because I just struggle with, if we're doing, if we're providing this benefit, then why can't the schools, and we have school year after year after year come in and tell us how great and wonderful it is, but they don't want to pay that one liaison. Now, we've got some districts, especially out in our smaller towns, that they share a liaison. They'll spend a half a day in one district and then move over to the other one, but the bulk of the work goes on to the CMHC, and every year we're hearing the stories of not just the kids that we improved their lives, but the kids that we saved. And those are the ones that stick with me every year. We prevented a child's death. And if you've never lost a kid, that's pretty hard. So, my comment here, and again, like I said, I want full, honest discussion because we have it elsewhere, but it seems like I'm the only one that talks about this program, is would we like to make the recommendation if we're going to, we opened it up this last year. I will go to this. We started out with just the CMHCs. We have opened it up to other mental health providers, so it's not just the CMHCs, is that we make the recommendation that the legislature not only expand this and put it out permanent, but that the school districts are responsible for the liaison. And if we want to phase that in, I don't have a problem phasing that in to give them some time. But I also look at how many billions, not millions, billions that they've received in the last couple of years. And a lot of that has to do with COVID, et cetera. So, representing neighbors.
Thank you, Madam Chair. When there's been feedback on those that say, from school districts that say, we don't want to pay for this, what's the size of that school district? Because are they large, medium, or small?
Yes.
All of them. Okay. Because like in our particular district, we have 55 schools. So that would be 55 liaisons, or pretty close to it, because most of those are 350 to 550 in elementary, and middle schools 800 and 900, and high schools are 17 to 19 or 2,000. So I'm not sure about the sharing on that and how much you could accomplish by sharing one, which would have a significant impact. But we also have social workers in every school now. Those could fill that position. Is that correct? If they chose?
They could. The reason schools wouldn't do that would be the cost, because again, a bachelor level individual versus the clinical social workers, and our schools are hiring a lot of our social workers out of our CMHCs that have worked in this program in their buildings. And I don't blame them for going there. You can get more pay, less hours, better benefits.
And what I'm saying is, we have social workers in the schools now, in all of our buildings. They could then take that position into what they do in their daily work. Would that be correct?
No, because the liaison can only do the.
Liaison work.
Yes, the yeah, they can only work on that MHIT, because if you distract them from that, then you lose some of the data entry that's required, the tracking of the kids, and, coordinating the kids. There's a lot more that goes, I've simplified it by calling it kind of a traffic controller, but they do quite a bit, and they're a very important part of the process, because they're the connection for the child to get to the services of the CMHC.
May I ask a second question of you, because you've been with the program? What is the success rate? Because I think most of these, are they in Wichita and a couple other areas, or it's not across the state?
55 school districts across the state.
55 school districts. Okay, I thought you meant schools.
No,
Sorry about that.
no, 55 school districts, and that does not translate into the buildings. I can't tell you what that translates into buildings. So you have school districts that have chosen what buildings to have, because not every school building may have those same needs.
Right.
And at the beginning of the program, there was an alpha and a beta group, the alpha group being the foster care children. And we fought for a while to get the foster care children identified, and finally Secretary Howard stepped up to the plate and made that a part of her instructions, that you will identify those kids. Because one of the first kids that we identified with the issue was a child that no one was paying attention to. It was walking in every day into school with a trash bag. You know why? They didn't know where they were spending the night. And you know what they found out about that kid? That kid actually had enough credits to graduate, but nobody had tracked him. So those are the kind of success stories that are happening, because we can focus in on that. I still representing a neighbor, do not understand the need for as many social workers if you look at the increase in social workers just in the last 3-4 years. I'm not quite sure that I understand that if they utilize programs like this, and that's something that hasn't been explained.
As a former school board member, I think there's a reason for them, and a part of that is the demand by community, and that's probably because of where we live. And they handle a lot of cases during the day and across the spectrum. So it's not just this one area, but certainly there might be some overlap. But we found that when we did not have them, we had a lot more problems. And we went through a period of not having them because of cost. And it caused a lot of, I want to say, frustration in our communities. And it's one of those things that parents were demanding. So I think it was acquiescing to the community as much as anything else, and the wishes of the patrons. So.
But see, the counseling from the CMHC is done in the school building.
Right.
They come, and this is where these kids miss less school, because instead of them being picked up and taken to a counselor and then brought back, they're right there at the school. So the parent can say, oh, you only got 2 more hours, let's just, no, so they don't miss those 2 hours. And the other benefit has been their friends seeing the changes in them. And some of them had issues but didn't realize where they should go or how they should go. Or some of the stigmatism we talk about is starting to ease a little bit, where you'll have a kid come to the liaison and say, you know what, Johnny's in the bathroom and he won't come out. And he's just wrapped up in a ball. Would they have identified that before? We don't know. But this actually was in one of our rural communities. So do the schools probably need some social workers on board all the time? I agree with that. But the CMHCs are coming in, and they're handling all types of kids. So like I said, the alpha group was the foster care kids, the second group was the SED kids, and then any other kids. And it doesn't have anything to do with your ability to pay or not pay. You're not identified by that. You're identified by, do you have a need? You know, and some of these kids are able to get out of the system. And I think every time we save a life, anytime we graduate a child, you know, that's got to be huge. And this is an online database. Out of all the years I've been up here and in the work I've done with social services budgets, this program has more accountability than any program I know out there. And it's real time and it's real data. And we get that every quarter.
My last question is, what are some of the reasons that school districts have said the state should pay for it?
They don't have the money.
Okay.
And I'm
Thank you.
sorry, Representative, I'm not buying that one there. I've got Representative Erickson, Representative Reese, and then Representative Lynn, and Representative Ballard will keep track of that for me, please.
Thank you, Madam Chair, and I apologize if I missed this earlier. I was just reading in this section that I agree with the funding part. The thing that gives me heartburn is what the discussion may have been against incorporating this into the school finance formula. We know how touchy that can be with the Supreme Court ruling, and that always gives me a little heartburn. So were there specifics in how to incorporate that in the school finance formula? Thank you, Madam Chair.
And I'm sorry, because I had to address something here. Could you repeat what you?
Yes, it references the working group looked at integrating the cost into the school finance formula, and I was just wondering if there were specifics discussed as to how to incorporate that.
Well, and it's been a while since we introduced legislation to actually make that happen, but I think that we had kind of come up with one, but then you also have the issues that not all the school districts want them, not all the buildings need them. Because we still have to do a funding mechanism on it for and it's a small pittance for the uninsured piece. It's not like we're making the CMHCs whole whatsoever. And I might ask if Kyle Kessler, are you still on?
Yes, Madam Chair.
Is there anything that you would like to add or that I've missed or I misspoke on?
No, I don't think so at all. I think that one of the things that we've seen over time, really from where we started, and the example I would give is actually the Topeka School District. For folks who have followed this, it was one of the original 9 districts, and we had an extraordinarily difficult time staffing it up the first year, and people were really frustrated, and both at the school level and the public policy level. And so by the time the mental health center got it up and going last year, they really started making great success. And then the school district hired away 6 of their clinicians. So we simply can't keep up with being outpaced by $10,000 or $15,000 salaries and summers off. The alternative to that potentially is that school districts take on more responsibility for clinical services during the summers. And I don't know that they want to do that either. I think that we are very, very wedded to our roles as the public mental health safety net and the continuity that we can provide during the school year into the summers and back into the following school year. And I think other behavioral health providers are in that kind of in that same frame of thinking. So that's all I would add right now, Madam Chair.
Representative Reese.
I just want to kind of add to what Representative Neighbor was saying. I don't quite understand why a current school social worker could not do this, because they're doing a lot of that already. They may not be tracking the data the way it needs to be tracked for this program, but I would think that they would like that they could be, and the school districts would like to see this data. And you see outcomes, it's, the outcomes are much more apparent, I guess. And then the ability to track a child as they move on through, through the different grades. It's just, to me, it just seems like a no-brainer. And I mean, if you already have an existing social worker or social workers, depending on the districts, why they couldn't be this liaison. And for those schools who don't have the social workers, they could look at maybe not a master's level social worker, but look at a bachelor's level, and to be this, this liaison. But this is basic social work activity.
Well, you don't have to be a social worker to be the liaison. That's what we're saying. You can be a bachelor degree of anything. So Representative Arnberger, what's your degree in? She could be a liaison for the school because she's got her degree. This person is focused just on these kids. There's a lot of phone calls, there's follow-up with the parents, they're following up, why isn't this kid? So it's, because we dedicate that, I don't think that the existing social workers would have the time that's taken to this, and that data is, that's live data. So that we can pull up anytime on these kids what's going on. So I get what you're saying, and we've thought about that, but we haven't found out how that works. Would you agree with that or not, Kyle?
Yeah, I agree with it. I think that one of the things that Representative Reese brings up that could potentially work again is if the school social worker or clinical staff wants to do some of the liaison work, and in fact, we had a social worker who had worked for us, went to work for a public school in Douglas County, and she was not being used as a counselor, but was more in the role of a school liaison, and also monitoring bathrooms and halls and things like that, and is now back working with us, which I'm really pleased about. But yeah, there may be some opportunities for schools to use current staff for that liaison position.
And I'm not saying we don't look into it, Representative. I'm just giving you what our experience has been so far. And I would definitely want to have a conversation with the individual that works for the Department of Education, because they have a dedicated person that travels the state and works. She just doesn't like her name to be mentioned. That's why I'm not doing it. She travels the state and she visits with all of these liaisons, and she visits with the CMHCs. And she was very instrumental in the very beginning, because as she traveled amongst our pilot schools, we were solving problems like this. We didn't have to wait for the legislature to reconvene.
Yeah.
And she actually came from the school area. She understood schools. She's picked up on the mental health and has just done a phenomenal job. But I think, we could sit down and have a visit with her and have a visit with Department Ed, because I couldn't have asked for better partners across the street with our Department of Education. And we had money crossing 5 agencies, and it went like clockwork.
Yeah. And I think, and earlier you mentioned if we looked at a phase in, I think that's something to really think about. Thank you. Thank you, Madam Chair.
Representative Lynn, and then Senator Fagg. You're on the list.
Thank you, Madam Chair. Yeah, just to keep on that. So this recommendation says to expand the program, but it sounds like at least eventually you want to not require the school districts to do this. And if that's the case, is it to put them in every building? Is that what you want to expand it to?
No, we want to be able to put it out there so it's not called a pilot year after year after year after year. We would not mandate that any school has to do this.
Okay.
Because, give you an example, are you Olathe?
Yes.
Okay.
And Blue Valley.
Olathe did this last year because Olathe has had a program in place that they were using, but Olathe put some liaisons and joined this program in some of their other schools. So having it a choice by the school district and what buildings they need this in is what makes better sense. So we would not mandate that, no.
Okay, that's good. And then if I may, what do they do during the school? Do they open the schools for this, or do they work with just the community services and partner with community services for the summer? During the summer, or do maybe?
Some of it depends upon the school district, and if they've got summer school going on and stuff, they can do that. But the kids have got access to that CMHC worker 24/7, 365, because, you know, they don't have their meltdowns normally at 8 or 9 o'clock during the day. They have them at 8, 9, 10 o'clock at night.
Right.
And when the school's closed.
Exactly. So I was wanting to make sure that they would still have access to them.
Oh, no, they've got access to them. That was one of the things. I visited a school in my district, and as I sat there and I visited with the social worker after we had toured the school and looked at different programs, and one word kept coming to mind: disconnect, disconnect, disconnect. Okay, so this child talks to this social worker here, they go home, they have nobody. Well, tomorrow it might be a different social worker. Go home, they have nobody. School's closed, they have nobody. Holidays, nobody. Weekends, nobody. Midnight, nobody. And so I just sat down and actually started with my school district, visiting with them and with the CMHCs, and then we sat down and decided, okay, what school districts? We needed 3 urbans and we needed 3 rurals, and one of those had to have a co-op so that we could get a good sampling of the types of districts and the type of needs that we were seeing to kind of mirror what was going on across the state. And that's what we started with. And then we found out how great and wonderful this was. And just, you know, school districts were asking to be a part of it. And then they were wanting to put them into more of their school buildings.
Are the liaisons expected to be available 24/7 then?
No, the liaison is not. The CMHC employee is.
Okay. Thank you.
Mm-hmm. Senator Fagg, and then Senator Armberger.
Thank you, Madam Chairman. It's kind of interesting. Have you ever heard of community in schools?
Oh, yes.
Is that a good thing?
It is.
You know, first time I was exposed to one of them was 2 days ago.
Really?
And what you just described to me fit that a lot. You know, the guy gets paid about $41,000. Everything you said is what they kind of do. They're in a 4-state area. There's volunteers somehow around that kind of thing. But the thing caught my eye on their funding was that the city was throwing money into that. United Way was throwing money into that. The community was throwing money into that.
Yeah, because I don't believe it's funded by state.
No. And the school district was the least amount being funded in that deal, which I found interesting. So back to that. So I'm sitting there thinking, what if we had some kind of matching program where we encourage the school district to do something like what you're talking about? So I'm just giving you food for thought because I hear what you're saying and I'm on board with your thought. Thank you.
Oh, I'd love to see someone step up to a school district and say, hey, let us help fund this program for you, but that doesn't happen very often.
Well, they had people that was helping with that. I mean, that's how
Well,
they
yeah,
were
and that's
supported.
been a long-term, and it
Yeah.
was started that way with the communities and the schools.
Yeah, but the need for what's happening is there.
Mhm.
So we have to fulfill that need somehow.
Right.
And the school districts need to be paying their fair share of that. That's part of their job.
Representative Armberger and then Senator Hawk.
Thank you, Madam Chair. You called me Senator Armberger earlier, and I was offended by that.
I apologize. I am so sorry I offended you.
Oh, it's okay. I don't get offended easily.
No, that was happening a lot yesterday between me and Senator Gossage, calling each other senator and rep, so.
So just kind of an idea, JAG-K is a big model that has been almost, I don't know how many schools utilize it. And they do a 90-10 one year, the next year it's a 80-20 match to work their way down where each school district is the one funding it. Just thinking maybe if that's an idea that we want to look at in the phase-in approach or phase out, however you want to look at it. But every school district seems to be fine having JAG-K. Let's make it possible that they can fund this as well. Maybe in 8 years, their 9 years are at the 100% on their own. So just an idea I want to throw out there if we want to look at the JAG-K model on how they do their funding.
No, and I'm a big supporter of JAG-K, so I get that. Senator Hawk and then Senator Alley.
Thank you, Madam Chair. a piece of information that is old on my part, but I think it's still accurate. And I strongly support having social workers in the school, depending on what their duties are. At least when I was working in the school district and hired social workers, they were all special ed staff, and they qualified to be special ed staff. Therefore, they qualified for reimbursement, but their duties had to be specifically for those children that had IEPs. So to think that we could take social workers and give them this job unless those students had IEPs, and I suspect some of the effectiveness of this program is that maybe we head off some of the kids who might ultimately be identified as special ed because we intervene with them and their families in a timely manner so that they stay productive in school. So not all kids that exhibit some of these mental health kinds of hopefully short-term crises and sometimes long-term. So
Well, that's
in kind
something-
of your answer to why a school district might be hesitant to say, well, we hired a lot of social workers, but what we have to do to stay in compliance with special ed laws. So that's just one little piece.
Okay, well, we could have, and I'm going to pause you there as we go through your stages, we could have staff look into that. I mean, not necessarily you, but whoever's the education gurus, and because something tells me you're right, but it could have changed
Well,
because we're
it was
old.
right, because I got in trouble for it, because I had a drug and alcohol prevention program that seemed like really keen to me to use social workers to do that program. And I found out from my special ed director that I was putting her in a difficult position with her audit. So anyway, not a pleasant conversation that I had at that time. The other is, and you asked, why might not school districts do this? Going back to my superintendent days and long board meetings, I think school districts recognize that we want to educate the whole child, and there's a big focus on individual student success. But what is the school's job? The school's gone from reading, writing, and arithmetic and just educating kids in the basics, and we still get beat up, particularly during COVID, for not showing enough progress in those fundamental skills. And yet, if we look at what we've assigned to schools, we've assigned them essentially in local parentis, but not just your typical. We want schools to be perfect parents who feed the kids, provide childcare before and after school, transportation, now mental health services. So I think schools are legitimately concerned about, we want to keep a focus on our major mission, and that's educating the child. I think as a school person, I agree this is a critical part of it, and I've supported you every step of the way when you've come up with this. But I still believe more in a carrot than a stick, and I think an incentive program, I think you should be commended, and the legislature should be, and the Department of Education and the 55 school districts. I think this is a good recommendation. It's not where we ultimately want to be, but I think it moves us, and I'd like to see us increase that by at least another 25 or 30 school districts over a year. And I think one way to do that is to keep that incentive. I think it was a good idea that maybe if we have to get to matching money in terms of some of these liaisons, those could be things. But I think as a recommendation, we've kind of put the onus, if you look down here, on KSDE. I think we've been clear that we want this program expanded. We want more school districts. We've talked about the difficulty we have with our community mental health centers and having staff. So I don't think we can move it to 100% overnight, and I think this is a logical step, but I think we just have to keep pushing on it every year. And I think we ought to feel really good about where we are. It's not adequate for where we need to be yet.
Well, and we've been limited somewhat with with what gets appropriated. So that's why you haven't seen some of the expansion out there.
Yeah, and I thought the appropriation was supposed to be $12 million, and we got cut a little bit because of COVID and some of the things that were done in terms of balancing the budget. Now, at least until the session starts in and we go through our happy dance about whether we fund the programs we want or do tax breaks, and you know where I land on that. But I think this is a program that we ought to press our colleagues in appropriations and Ways and Means to fund this at a higher level so that we can have a proper incentives at this point. And then ultimately, I'm fine if we can, and we're saying in here, we want the schools to build this in their budget, and we want to see if we can figure out how we do this with the school finance formula. And I think Senator Erickson's comment about let's make sure we don't get in trouble with the good place we're in. But I think we're smart enough with the good staff we have and the Department of Ed to figure that out.
Right.
And we're saying let's figure that out.
Well, some of the problem that we have is, like I said, is some of our school districts have been hiring some of our best social workers from this program, and that's removing them out of it. So now they're no longer working with those kids, and they're not available. So that also creates a short staffing issue. A large part of the funding is for that liaison. Right. There's only a small portion of that money that goes to the CMHCs for unfunded. So we could add a whole bunch of schools if we went to where the schools were paying for the liaison, because we wouldn't have to be increasing funding, et cetera. And again, jump in, Kyle, if you hear me speaking out of school on this.
How much do we pay the liaison?
Well, it depends upon what level their salary is. If they're just a regular bachelor's, whatever, it could, I use the figure 40, I think it's around 45 plus, whatever the starting is for their teachers. Because it could be a brand new teacher that comes in and does that. So, and I agree with you. I wish that our schools weren't acting more like parents. I really do. I wish we weren't feeding the kids at school, but I understand why we do. And I think it's sad. I can tell you that during COVID, this program was a lifesaver to a whole lot of kids that had someone to reach out to when they couldn't reach out to their schools.
So was food service.
Oh, yeah. Senator Alley and then Senator Fagg.
Thank you, Madam Chair, and to echo my sentiments with Senator Hawk on special ed funding. There might be some issues by using special ed funding for this position. However, every one of those children that are in this program are at risk.
They may not, well, it depends upon your definition of at risk. Because
Well,
number
my
one,
definition-
at risk is free lunch, period. That's at risk. That's our definition in the state for at-risk funding. Second of all, not all of these kids have IEPs, and those are your at-risk kids, is with the IEPs.
My at-risk definition is that they're at risk of not performing as well as they should be in school because of other issues, and you've got to send them to this other. So, but why can't we use at-risk funding for those that are at risk? At-risk funding is available for them. They get 49% above state base aid for each one of those children, and you have that money available. They just have to use it for a program.
Right.
So identify that as, we'll go with your program to fund part of your.
Well, we don't get to do that because, again, it goes to, and I'm not I wish Representative Williams was here. I mean, she can spew this stuff off. Again, the at-risk is funded in our formula for anyone that has free lunch. That's it. Then the school districts decide where that money goes. So just because Johnny over here has free lunch, Johnny doesn't have an IEP, Johnny's making straight A's. Well, the money that came in because of Johnny is being spent then on another kid.
It's
And
on
maybe
the-
that kid isn't free lunch.
My question is, how many children you mentioned 4,700 participated last year, I think it was.
Across the state.
Number across the state. How many of those were at risk, identified as at risk?
That's not one of the criteria. We break them down by whether or not they're free lunch.
Okay. Funding is there for this program if we choose to use it, is all I'm trying to say.
Senator Fagg.
Thank you, Madam Chairman. I'd also talked to another school district in the last couple of days, and one thing I wanted to just quick comment, it stuck in my mind how the mental health centers were working with the schools. You know, that they would have, these people would come out to the school. So I just want to say kind of kudos to those people. Thank you.
Well, and one of the other benefits we found, especially in small towns, and we didn't even think about this, was for those of you that live in small towns, everybody knows your business, right? Yep. Well, if you walk into a mental health center, everybody knows your business, right? But if you walk into a school building to get mental health services, they don't know your business. And that was a positive. And that was actually a story that was shared by one of our representatives, that his wife happened to be part of this pilot program. So, Representative Ballard.
Thank you, Madam Chair. In fact, you just led off a few minutes ago with what I was going to say. We talk about the stigma, and one of the recommendations is not to talk about stigma, but to give the positives about it. And a lot of people just don't go because everybody does know your business. They know where you go, and whether we like it or not, they know kind of like what you were talking about when you were in there too, you know, and so it is a problem. But one of the things that I especially like about this program is that a school district does not have to do it. They can opt in or they can opt out. And so I understand the funding part, having served on, you know, the school board for 8 years in Lawrence. Anytime there's something outside of what the board or the superintendent has to do, it's sort of like, oh, that's somebody else telling us how to use our money. And I understand that. But if you know the statistics in Kansas, if you know that teen suicide rates are up, we know that mental health is extremely important. The same as we talk about our physical health and everything else, all of that is really important. The one thing I will say about this program that I think is very different than other programs is that it's effective and there are results, positive results from the program. And often people will say, well, what, you know, if we invest, what do I get for my money? Well, I think in this case, this particular program, and it's not because Representative Lansbury is my friend. What it is that you have data and it shows that it's making a difference. And that's the kind of thing we want with any of our programs, that we can show it is worth it to have it. The same as we put DARE in our schools, and I'm on the Bert Nash board, and we're fighting with the school district often, but will they offer the DARE program? You know, I think we have to get serious about what we're going to do, and if no one's making you do it, and you can decide if you want to do it or not, why would you be complaining? No one's forcing you to do it. And that is what I have said to my own school district. If it's a priority, we spend the money. If it's a priority. And if you say the students in this district is a priority, then we have to meet the students where they are and take care of their needs. For that reason, I would support adding this there, because school districts have an option. They don't have to do it. Thank you, Madam Chair.
Committee, further comments, questions, discussion? Representative Lynn.
Thank you, Madam Chair. Just quickly, I want to make sure that when we do discuss this, it's not just for the at-risk kids or who we would consider at-risk kids. I think
it's not, never has been.
Right. And I just want to make sure that that's realized, because some of the students that I work with would not ever be considered at risk, but are hurting just the same and need these resources. So thank you.
And that's why I didn't use, that's why I said where they are, you know. And may I just add another comment? A lot of times the parents don't even know what their children are going through. You know, and that doesn't make them a bad parent. Sometimes children can hide things so well that you don't know that you feel lonely at school, that you don't have anybody to hang out with at school. And the parents don't even know it. And then all of a sudden they're surprised when they find out that things are not really going well. Well, teachers, principals, assistant principals, social workers, they're with them every day. They get to see it. Unless they're so busy and have so many kids, they can't really take care of it all. But if someone was offering me a program that I could see results, and I don't know how much parents are involved once you start doing this and then they're made aware of it. But I guess I would say, aren't our students worth it?
Well, and just make it clear, parents do have to sign off on this. It's not something that happens without parental engagement. Senator Erickson.
Thank you, Madam Chair. Quickly, I just want to echo Representative Ballard's comments, especially about if it's a priority, again, spending 8 years on the school board, if it's a priority, that you will find the money for it. And I will make an offer of my personal time that if there's a school board out there that wants to implement this program and they're being told by their district office they don't have the money, I will be happy to sit down with that board and go through and help them do some priority-based budgeting to find the money for this program. Thank you, Madam Chair.
Further comments, questions? So I guess what I'd be looking at, and you know how to clean up the language, Urida, is that we look at making this program permanent in legislation, and let's fade in reducing the state portion for the liaison costs. That doesn't mean we're not open to other ideas, recommendations, and suggestions, because I think Senator Hawk brought up a good point, and something is telling me that you're right on that, because I doubt if they've changed that on special ed.
Madam Chair, question.
Representative Ballard.
I'm reading this again carefully. Does it clearly state here that this is not a mandatory program?
No, we can add that in. I don't know that it does. I have not gone through every single word on the rationale piece.
I think that
But
would
I
be
can
very
tell you it did in the legislation when we drafted it. So we can add that
At
to it.
one point, I've seen it, but I think it would be very important here because somebody looked and said, somebody telling me how to use my money. No, if it's not mandatory, you can opt in, you can opt out, or however we want to say that language. I think it's important that they see they have a choice.
Yeah, we can't make a parent opt their child into it.
No,
So,
but a school district either.
no, school district can't either. Huh? Representative Lynn.
Thank you. It does say, it says in the short term, school districts interested in participating.
Okay.
Yeah, I think it has to be stronger than interested in participating.
I think Urida's got the gist, and she'll figure out what that wording is. Correct, Urida?
Right.
Well, it's not like you got to have it right this minute. We get to the report. Senator Hawk.
Don't want to put words in your mouth, Madam Chair, but I detected that you and I would like to see us get back up to the level of funding it was supposed to be. I don't know if we want to put that in here, but the amount of money that was allocated was less than I think what it was at the high water mark, was it not? And I think if we want more schools, even though we may be reducing the liaison portion, I'd still like to see us fully fund this at the level that it was funded at one time, with the goal of increasing. Even though it's for those interested, I would like to see the number of participating schools. Was that mine? No. Oh, what a relief.
Mayor, hope we don't have 2 days tomorrow. I think I've got a senator and a rep that's going to have to bring cakes, not donuts.
Future
Cakes.
Senator Arnbarger has turned off every part of my thing. I'm going to call her senator from here on out. Anyway, I can't even get a phone call now.
I think the only reason I wouldn't necessarily agree with that, because is we have to come in and calculate, because then the only expense would be, of course, what we match in Medicaid. That's part of it. And then the other part is what we allot for uninsured to the providers. And that is an amount that's a hard calculation. But I think it's very well understood, and Kyle Kessler's on the line with us, and he's been involved in this from the very beginning. Our, oh gosh, Craig, because one is Newswander and one's Nineswander. They pronounce, huh? Because they pronounce them different. We learned that at the last meeting finally, because they were just letting us call them whatever. Craig's been involved with this from the very beginning because he worked with Dale on it and stuff. So everybody understands it, and they kind of tell me what the legislation needs to be.
I just want to make the point that whether we cut back the amount that goes to liaison, if we have more schools, we need to budget more money because there's still some other costs in terms of that.
Representative Barger, would you please help Representative Reese down there? Okay, so are we in agreement on 2.6, page 14, and Orida?
Just for clarification, this sounds more like a special committee recommendation as opposed to an amendment to the working group report. Is that the way you're interpreting what the will of the committee is?
I'd like it in both,
Okay.
if that's all right. Any further discussion? All right, now let's move to 2.2, page 15. Addressing inpatient capacity. Did we already have you respond on this, Andy? Oh, yes, because that goes back to Scott Bruner. Never mind. So I don't know that we have any new changes unless there's language, because it actually looks like 2.2 and 9.1 kind of tie together a little bit. So if staff feels like there's language we put in one place that belongs in the other, let's duplicate that. Does that make sense? Okay. Yes. Oh, you had some additional, I'm sorry.
That's all
Senator
right.
McGinn.
I want to make sure I was on the right one. On this one, I would like to add, I'm trying to think of the right words. I don't want to use the word investigate, but research, explore like that. The need for state certified beds in South Central Kansas. Thank you, Madam Chair.
Discussion, comments on the change? Senator Fagg.
Madam Chairman, would there be something, when you say the need, I wonder if they could look at the history or something too, because we might have a real need today, but 3 years from now, that might back off, through the trend. So it's just a thought.
Okay, I think I'm going to let Senator McGinn go because I was ready to jump on that. Go
I
ahead,
think there's
Senator.
a couple of us that have seen the long-term trend for some time now. And this isn't just new. This is a long-term problem. And so I think the discussion we had about the regional beds, they just set those up here in the last couple of years. So we kind of are still seeing who else is out there to help with that. But it'll be very easy when you go to the long-term beds to count how many people from South Central Kansas are in those other beds. Thank you.
Not my partner. Representative Carpenter.
Thank you, Madam Chair. We've dealt with this several years in social services budget, and that's been kind of the moving target, was really identifying how many beds we needed, but it certainly continues to increase.
Senator McGinn.
Thank you, Madam Chair. And to add to that, because I know you've been here a long time on that as well, we continue to look at trying to update old, inadequate facilities. And I think we just need to look a little bit more outside the box.
And, Madam Chair.
Mm-hmm.
And I don't
Representative
disagree
Carpenter.
with that. I think that that's been KDAD's issue with the regional beds, trying to enter into beds at various hospitals. And it's been a lot slower process than I would like, but I do think that they've done a good job identifying regional beds. And we could have a separate conversation about, where they have them. They have them in Manhattan. They're all over the place, regional beds are, but they still don't seem to be enough, so.
Senator McGinn.
And again, I mean, we're looking at those 1 to 14-day beds, but these are those beds that go past that 14 days, and then what do you do? Yeah, thank you.
All right, any further comments? Discussion? Staff, are you good? All right. Now we'll look at, okay, on 2.3, page 16, that was the reimbursement rate increases. I think on that, we can add the information from the CanCare oversight on the discussions that were there. Everyone agree with that?
Yep.
On the rate discussions that were there? All right. I could skip over this, but I think Senator Hawk would come back to it anyway. Page 18. Oh, he's sleeping. I could have slipped right over it.
Oh, no, he was straightening up. He was sitting up tall.
Funding and accessibility. Senator Hawk.
The only thing I probably want to change is in our subgroup discussion, there was another suggestion for recommendations that put in that there are some additional federal incentives out there for the expansion of Medicaid that is going on at this time, and I'd just like to see that wording in there. I think obviously it's a hot topic, and I was pleased when Senator Denning was here that we had what I thought was a really good compromise. We just couldn't get the mechanism of the Senate, and the House was able to get it passed, but we weren't able to do it in the Senate. So I think there's still a resource there that could help our Kansas citizens, and certainly in this area that we've spent a lot of good time talking about mental health, and it would help our community mental health centers, it would help providers, it would help our hospitals, it would help us with all the things that we've been talking about. And no, expanding Medicaid or CanCare does not solve all of our health care problems, but it does give us, I think the number is over $4 billion we've missed out on, and there's extra federal incentives. So I think it's good to have it in our report. I know it's not 100% agreement, but I think we ought to add that little extra bit that does factually show that there is even more incentive for us to do that from the feds.
And I struggle, and this was my discussion in the working group on this, is that potential money that's sitting there today in the, what is it called? Is that the ARA?
The ARPA?
ARPA.
What's called discretionary, well,
Yeah, whatever
there's some
it
other
is.
money on the
Yes.
side, but American Rescue Plan.
Right, that, that's temporary funding, and I think that's a problem that some of us have, really struggled with. And I think, you were on the CanCare Committee, Oversight Committee the last 2 days, and what's one of the things that we heard about over and over and over of a current need? Oh, you weren't on that? Are you sure? I swear you were bugging me yesterday.
I'm not sure about a lot of things, but I am sure about that one.
Okay, well, there's somebody down here that was, so we'll get to you. Probably will.
Some other handsome devil who cares about every citizen in Kansas, I'm sure. That sounds like Will to me.
Yeah, the issue is that we're not even funding our Medicaid existing programs at rates that we should, and we want to go out and expand it. And I hear people say, well, but it'll cover more children. Well, guess what? Medicaid does not cover children. it covers CHIP. The expansion will not cover children. CHIP is what covers children in Kansas. And I don't know what that level is at right now because I haven't looked at that for many, many years. What's the poverty level we cover at? 2 something?
It's variable. It starts at the poverty level of 24,000, 25,000.
No, but I'm talking about what is our percent, it's up to what, 200%? It's over 200% of poverty. Something like that, yeah. Which is above what our Medicaid, program does. But we're not even funding our current programs. We heard that time and time again yesterday, that we need to do rate increases. And I'm thinking, if we've got money to put somewhere, that's where we need to be putting it. And I've talked about that for many years. Representative Ballard and I've been on that bandwagon for a lot of years. So, I felt like those ARPA monies are a temporary deal, and that's why I'd asked for that to be removed. The compromise last year was to come back to this language in order for us to stay in a compromising mode, that we stay with this language as well. And I can come back to you, but I'm going to go to Representative Reese because I think she's excited to speak.
This is about Medicaid expansion, so I know it's not a hot topic or not, but, no, I just keep thinking in the back of my head, my mind of, when we were looking at this awesome mental health intervention program that we've got going in our schools, and we want to expand that, and I keep thinking about how many of those kids, family members, maybe even parents, would qualify for Medicaid, and you're right, kids, that's not, CHIP pays for the Medicaid for the kids, but I'm thinking about these social workers or, these liaisons that are trying to help the kids, and you find out that, there's medical issues with one of their caregivers, and there's no insurance, and maybe they do qualify for Medicaid. And that would help them so much. It would also help the community, mental health centers recoup money, the millions of dollars that they're spending. I know Johnson County Mental Health spends several millions of dollars on uncompensated services. And then if you can get some funding through Medicaid expansion for some of the adults, that gives them the ability to continue or even be able to be a part of this, with the school program. I love this program, and I think that's just another tool that these liaisons would have. That would be another option, another thing they could point to with trying to help families that right now don't qualify for Medicaid, but maybe they would with the expansion.
Well, there's also
Thank you, Madam Chair.
There's also some of those people that are the 100 to the 100, is 136? I haven't done the numbers in a while. 100 what?
You're talking about percentage?
Yeah.
Isn't it 138?
138. Well, I think there's there's a variant. But that from the 100 to the 138, if they're on Obamacare today, they have to stop Obamacare and go on to Medicaid. They don't get an option. You know what that means to them? New doctor, if they can find one. And the things we heard too yesterday was the inability to sometimes find someone to take the Medicaid. So what I want to discuss here is I don't want to discuss Medicaid expansion because that's not for this committee. All I want to discuss today, so I'm going to try not to go down that rabbit hole. It's really easy for us to do it because on both sides we're very passionate where we stand, is to have language that is a compromise. If I had my druthers, this wouldn't even be in here. So this language is a compromise for us to advance to the legislature, and then we let the legislature have that battle. So what we're discussing here is the language, not the expansion itself. Does that make sense? Senator Ballard, I was looking at Hawk when I said that. Representative Ballard, I'm sorry, I apologize.
Promoting everybody.
From our world, that's a demotion.
Well, look at it, there's different perspectives. You know what I just want to say? I'm looking at this because I played a big role in what you see right here last year. I mean, most of you were sitting here, but the people that were, no. that it was, and actually it came from the committee that Chairman Carpenter and I sat on. So for me, I'm sticking with it, and what I wanted was it to always be there so that we would be discussing it. And I think from that standpoint, it will, and she's, and the chairman is right. She really didn't want it in here, but she did compromise. And I think it's important that we have it because we know there are people that do want it, but I also know that there's a lot of people that are very skeptical about it as well. But at least it is here, it is important, and it is mentioned, and that to me is keeping it alive. I will stop at that. Thank you.
Senator Fagg.
Thank you, Madam Chairman. When I read this is just my personal opinion, that seems awful aggressive. My first question would be, when we say 10 to 15% for all providers, how much money are we talking about? You know, I'd be kind of interested in that kind of number. And the other thing is, I think you got to look at the holistic approach that if you gave everybody a 15% increase, there's 2.9 million people live in Kansas, and they're going to work somewhere. So all of a sudden, you're really incenting one group, then the other group's going to say, hey, we need help. I can name you 2 or 3 that'd be jumping all over this real quick. Do I think we need to increase it? Yes. But my thought was that maybe we put implement an increase for reimbursement rates. Don't put 10 to 15% in there. Let that be worked down, or somebody decide that? Huh? Okay. Do what now?
We're on,
I thought we was
We're
on,
just on a recommendation
we're on page 18, the top of the page. Right?
I'm sorry, I'm on 16. I'm 2 pages behind here. I'll save my speech till later then.
Well, what he ever say, it was important, boy.
Yeah. Have we discussed that area yet, or you went ahead and said okay on that, didn't you, Madam Chairman?
Which one?
16.
On page 16?
Yes, we did.
Okay. Well, I missed that one. I wanted to say that. So you understand, I hope, where I'm coming from, that I would like to have that 10, 15% out of that if I could. And we can talk about that. I just, when we throw immediate numbers, somebody needs to probably spend a little more time on that kind of number, and maybe somebody has. But I'm talking about page 16 under recommendations on 2.3. And I'm skipping around.
Oh, okay, I see what you're saying.
So on the recommendation part,
Well, we kind of operate in a couple of different ways when we're looking at those, and I'll let Representative Carpenter speak.
okay.
Thank you, Madam Chair. Well, we discussed this at length yesterday
Did you?
in Can-Care Oversight, and
Okay.
and although I don't disagree, what we've got is, well, for instance, yesterday we came up with, the EMS came up here, and we hadn't raised their rates in over 20 years, and we were paying, you know, probably a dime on the dollar for what their actual expense is. So I think we agreed in Can-Care Oversight that the director of KDHE, the medical director for KDHE, would take a look at some of these rates and just bring them kind of into line.
Okay.
It's not a blanket statement or anything like that.
Okay. That just seemed aggressive to me.
Yeah, I get it.
That's all I'm saying.
We get it too.
Did it? Okay. Thank you.
Okay,
I apologize, Madam Chairman.
that's all right. It's
I'll get
easy
up
to
to
get
page-
lost. I just got lost there for a moment and was trying to find my place.
I'll get it.
Senator Hawk.
Thank you, Madam Chair. I'm going to make one more appeal on one wording, but then I'm going to agree with you, just so you don't get nervous. In that sentence down there about 5 lines up from the bottom in the rationale, where it's 90% of Medicaid expansion costs would be covered by the federal government, that's true, except there are additional funds available. And I'm trying to think, and I don't recall exactly what that is, and relative to the statement you made previously, probably doesn't matter. But I think it's important that this committee is aware of that there are those additional incentives, and they're all short-term our highway dollars may be short-term dollars, but we still build highways. These are the working poor, and I won't debate that. But now back to the comment you made. I would much rather see this in here as it is than not see it in here at all, because I still think it's a substantial policy issue. And while we may differ on it, I think all of us, to be responsible to our constituents, need to think about it. And we need to think about what the impact is on our constituents and the people that we're trying to serve. And we may come legitimately to a different conclusion based on how we see it, but I think it's still a critical issue and it does affect funding. So rather than incur the wrath of people who may see this issue differently than I do, I would agree with you that it's good for us to have it in there, even though we have a difference of opinion about it. And I certainly would reluctantly acquiesce. I think it would be no more incompatible with other people's viewpoints that disagree with me to put the full facts in there. But I'm willing to keep it in there as long as the rest of the people sitting around here know there are additional incentives, and those people listening in know that it's even a sweeter deal for us economically as a state, certainly in the short run. So, and I would believe long-term, we've been debating this so long, we've missed out on a substantial amount of the tax money that we've sent to Washington that other states have gotten. And I'd like to, without debating, I'd like to see my constituents and all the people of Kansas have the opportunity for better health care. And at least if we debate this, we will have that opportunity when session starts. So I'm agreeing with you, Madam Chair. Thank you.
Well, no, you're not, because you can't find the doctors that are going to take Medicaid. I'm just saying. Nope, I get the last word. I can tell you that this is a tough one in this report, and I caught a lot of flack for this. So that's why I say it was a compromise, and I'd like us just to move on down the road.
You and I will catch flack from different.
Okay. Yeah, we have a different group. Yeah, I get that. Any further comments or discussion on this? All right, we're done. But I made it sure I highlighted it because you had said during the working group you wanted to make sure you had time to discuss, so.
Very much appreciate it.
You're welcome. All right, committee, now we are on 4.1, page 23. And this is the 988 Suicide Prevention Funding Hotline. I think what they put in the report, unless you've seen something, Andy, that doesn't belong in there, that we stay with that language because the bill that we had last year is still alive and ready to be worked. And like I said, I think it was probably in Care Oversight, is on the 988, we've got 2 out of the 3 major telecoms that have come to the table are willing to negotiate. We're willing, but we ran into the timing last year. So I think we come to a resolution because this thing goes live whether we choose to fund it or not on July 16. And it's important that we have services available for those people when they start receiving those phone calls. Someone have a question or a comment on this? So I think it's just the way it's written. Senator Hawk.
Just one comment, and I'm perfectly happy with it. I think it's critical of being here, and I've said before, I applaud the House for dealing with this last year, and I really hope the Senate will take this up soon. I personally am not, at this point, knowledgeable enough to be wed to how much it ought to be, and I'm certainly open to any kind of compromise between what it might be on our phone bills versus what we might supplement with general fund dollars just to get it done. And I'm particularly pleased in the other section of the report, and I don't remember what number it was, that we did recommend the $1.5 million and the $90,000 and the other $250,000 to get the basic part of the program done too.
Right.
So
Well,
I
and
think
this
we
doesn't-
covered our bases on both places.
Yeah, and by supporting what we have here, it doesn't put anyone in a position of saying that they're supporting the 50 cents. It just says they're supporting the 988 and that a funding mechanism has to be there. That's all we're doing. Right, right. And we agree with that. Any other comment? All right, let's go to 7.6, page 27. And this is on our, was that the special report? Oh, no, yeah, no, that's the outcomes data. Was cost discussed and what can we do? And I think you talked about, Andy, that SCAL and KDADS are working together on this. Is that correct? Is that noted in any of our wording here, Carrie?
Thank you.
Yeah.
Carrie Breffett, KHI. That SEOW is a working group that is convened by KDADS, but has other members, universities, other researchers, as well as folks from other agencies. I think part of the idea of the recommendation is that that group would actually work with key legislative committees on what are the measures that would matter. So that's why you see the collaborating partner, I think, being key legislative committees. So the step for the legislature and for the committees is, hey, let's meet with some of those folks and say, what are the data elements that you'd want to have updated every year to be able to understand how the behavioral health system and what outcomes look like. I will defer to Andy and then certainly other working group members, but that's the kind of the legislative piece is having that meeting or engagement with SEOW through KDADS about what those elements would be.
Okay. Any changes then we need to make? It doesn't look like it. All right, let's go to 8.5 on page 28, which is our specialty courts. Page 28, 8.5. And I believe that the recommendation on here was that we would recommend this to the Judicial Council Specialty Committee. Is that?
Madam Chair, and maybe Spence is on the line to remind us, but I think there's a special group that's called the Specialty Courts Committee that is actually convened in the judicial branch.
Right.
Yep.
So that's what we would, and I don't know what the process is for us to recommend. Staff, perhaps you can enlighten me, for us to recommend a topic for them.
Madam Chair, I'm not familiar with what the process would be, but I think we can look into it initially. It probably would just involve a letter requesting that kind of a review.
Okay, then let's make note in here that we're going to send a letter for that. Okay. And if it has to be by an individual legislator, I'm happy to do that, or if it can be done by the committee, but let's just make sure it gets done. Okay. All right.
Thank you.
And then on 8.6, page 28, which was Specialty Court Coordinator, and that's in House Bill 2361 in the Senate Committee, and I think we just leave that language the way it is. We don't have to touch all of that. Everyone agree? Okay. Then we have 8.7, page 29, competency evaluation and restoration.
That was when we had a long discussion.
So this one here, I think if I understand this right, is in the ease of implementation, we're talking about maybe recommending a pilot, but who do we need to do that to? Would that be KDADS?
Looks like it's KDADS. The updated with an average wait time. KDADS highlighted the days. 8.7 is KDADS.
Andy Brown with KDADS again, and yes, I believe that would be correct. We'd be willing to take the lead on that.
Okay, so, and again, Carrie, I have not gone through every word on that, so we would change that to recommend KDADS look at a pilot and then come to us in the 21 or 22 session. And that could go into our report as well, or Ida?
I think the action lead was identified as KDAD's, so that, I think that probably is sort of assumed, but I would again defer to Kyle or somebody else as well, who's part of those discussions. I think that was the idea.
Okay, but don't we have to, up here in our recommendation, is to recommend a pilot be done in order for us to show action on this? Yeah, so that's what I want. Yeah, that's what I want you guys, that's what I want you guys to change on this, and then staff here will add it into our other report that goes to the legislature.
An example could be a proviso, somebody's whispering in my ear, so that could be language
Well,
as well.
and
Yeah.
that sounds like a Representative Carpenter proviso, so it can be on their radar as well. Representative Carpenter.
Thank you, Madam Chair. Social Services Budget Committee stands ready, willing, and able to look into this at the very first, one of the very first items in this session. So.
Okay. Are we done? All right, moving on. So now we're down to 8.1 on page 30. Correction employees expand training to recognize substance and mental health needs. So what action do we need to take on that one? Or can we take on that one?
Madam Chair?
Yes.
For 8.1, 8.3, and to a certain extent 8.4, many of the remaining recommendations were clarifications of last year's recommendation or some expansion on those. So in this case, the working group was just saying, hey, they wanted to make sure it was clear that the previous recommendation that's already in process applied, could be applicable to local correctional employees, not just the state correctional employees.
So you're saying that we can take 8.1, 8.3, and 8.4 and be done? Unless there's objection from the committee.
I think most of those were clarifications or ways to further implement something that's already underway.
I'm fine with that. Is there objection, anyone? All right, so then we have 9.3 on page 31. I don't know that there's anything that we can do on that. I think that that's being looked at, because that's what, KDHE, isn't it? Yeah. So then if we go to 9.5 on page 32, that's enabling code 90846 under Medicaid. And we've got that recommendation also from the CanCare oversight, so we'll just add that into this report. Everybody's good with that, because that recommends that we open that code, which KDHE is already getting ready to do or doing. So they've gone through the process. Okay. Now, what Sunny has sat here all day long, waiting for us to get to for the second time, and I appreciate you being here, is the telehealth side of this. So 10.6 on page 32. And that's the recommendation on this committee, and the discussion that we had was, so my question to staff is, is there a way for us to make this an automatic recommendation to LCC every year so that this committee can stay structured the way that it is? I know we could put this structure into law, but I'm just not inclined to want to do that. I like the flexibility that we have of tweaking as we go along. I know I have unusual requests all the time.
Madam Chair, the way special committees are structured is that they operate interim period only typically. So they operate from sine die to the start of the session. And so each year the LCC would need to make that consideration. You would have a different chair and vice chair based on that. If it were to meet during the session, it would be a select committee. So I think your opportunity would be then each year you would have to make that request, and you would be subject to the LCC's consideration of the membership of the committee, where the number of members, where members would come from, or they could choose as a body to refer the topic to an existing standing or joint committee, which they have done in the past. LBC receives a lot of topics because they're budget related, or they have some component to them, or they might find if they're, I don't know that the Bethel Committee could take one more topic, but the Bethel Committee could be assigned some topics of this group. That's a risk reward that this committee would take, is the LCC's determination. Also, they have to consider the number of resources and the number of committees they may wish to appoint each interim. And the timing could be subject to when the LCC can meet and approve interim committees each year.
I think I'm prepared to take that risk each year, because I think that there's enough legislators that have an interest in this that they can always remind someone in our chambers to make that request to the LCC. My recommendation is, and again, I didn't go through looking at the exact language, but that it would be structured the same way that we have it structured today. Because today, different from last year, the only addition we made, well, besides changing the working groups, but that can be flexible, is we added the judicial branch, and I think now we've covered everybody that needs to be at the table. Everyone good with, oh, I'm sorry, go ahead.
I'm sorry, Madam Chair. I should mention that there was a special committee formed by proviso this year, and that also would be an option. I'm not an appropriations advisor, so I can say this, but the special committee on the federal 340B drug program was in a proviso in the legislature section of the omnibus appropriations bill. It specified the number of committee members, it specified the chairperson and the review topic assigned to the special committee, and then indicated the LCC would have to formally authorize the membership and the remaining members of the committee.
Okay. So we have two options. All right. But I just think that we need to make sure that our language stresses how important it is that this continue. Representing Neighbor.
I'm sorry to interrupt, but I think all of us got a message right now that the National Weather System has sent out a severe thunderstorm warning in effect for this area until 5 for destructive 80-mile-an-hour winds. Take shelter in a sturdy building away from windows. Flying debris may be deadly to those that don't. Get away from the window over there.
Okay. You could, I would close those blinds. No. It'll stop the glass from flying at you. If you feel, because we're in a sturdy building, we've got cars down in the parking garage, if you guys feel more comfortable moving to somewhere besides around the windows, please feel free to do that. It's your personal decision.
Sorry to interrupt.
Close them.
I remember a tornado thing when we met in the parking garage for a while.
Really?
Yeah, we did.
Oh, I don't remember that one. Well, I wasn't here for that one.
Computers down there from legislative research that just kept working away, and the rest of us were having a great time.
That's bad. Okay, so we're done on the mental health modernization, correct? Oh, Representative Arnberger.
Thank you. I had my hand raised.
Before they get
So my question is, if it's a proviso, then it has to be added in each year. Does it have to be connected to, if it's a proviso, does it have to be, because I don't know how that would work. On what I'm trying to get at is typically a proviso is part of a budget. So would it be part of the legislative budget? I was too busy worrying about dying, so. So would it be part of the the general budget for the legislature?
Yeah.
But then we just have to make sure that somebody makes that recommendation every single year.
Right.
I don't know, that just worries me personally, just, not all of us are gonna be here in 50 years, so I made that number high.
Maybe we resolve it, and it doesn't have to stick around for 50 years. Maybe someone gets on here and decides that the way that this here was designed, that they hate it, they don't like it, and they don't feel it is effective. You know, personally, I feel like it is. I like the way the structure is. I like the flexibility. I've had the privilege to do it for 2 years. Probably won't next year, unless I can beg a president of the Senate. Is the ability to tweak as we go along and add members and that type of stuff. So we'll just keep it like it is, and we'll take our chances on it. So now we are on 10.1 on page 33. Which is quality assurance. And the only thing I wanted to make sure on there, Carrie, is that we have a hyperlink to the Telemedicine Act, so that people want to say, well, what is the Telemedicine Act? Then they could take and go read it. Because I think it's, you know, we heard the question earlier, what's the difference between telemedicine, health, whatever, and I think that gets really complicated as we move forward. So I think if we all stay with the idea it's the Telemedicine Act, that's our basis, that's our core for everything that we do moving forward, and have that. That is on 10.1 on page 33. Yeah, it's just making sure we have a hyperlink in there on our report. Other than that, I think everything was good with that. Senator Hawk.
I'm sorry, again, something I should know. Is the Telemedicine Act time limited? Is it sunset? It's in law and it's there permanently. Okay, good.
Yeah, and it was while I was out, but it was a battle, so. It's one of those things that probably isn't going to get tweaked a whole lot. All right, so 10.2 on page 34. I don't know that we can add a whole lot more to this. I think it's just something that we have to monitor. And as CMS rules allow, I know that Sarah Fertig was real concerned that that gets out there so that, you know, we don't lock Medicaid and saying you have to do this, and CMS comes in all of a sudden and says, no, you can't do that, and then we're kind of in a pickle. So that's why that piece was put out there. And this is on the Medicaid codes added during the public health. And if you remember correctly, that they're not paying facilities and destination or all those other little fees that may or may not be out there. So we're good with that one? Unless you holler at me, I'm going to just keep going through this. So then now we've got 10.3, which is crisis services. KDHE is, what we heard earlier is KDHE is adjusting the state plan. And to be clear in here that crisis services and mobile crisis services are two different topics. Everyone good? 10.4 on page 36 is the originating and distant sites. I don't know that there's anything that we need to do with this right now. Representative Reese.
Do we need to just kind of define what originating means and what distant site means? That it's the
I
originating.
believe, Sonny, correct me if I'm wrong, that's in the telemedicine law, correct?
Yes, Sunny Mickle, Blue Cross Blue Shield of Kansas, it's in the law today.
So we would not have to do that. Okay. Okay, then we've got Oh, come on. 10.5, which, on page 37, which is the child welfare system. The issue is explore the continuity for a child moving from home to home. I also like the issue of trying to figure out how we address medication provider. But I don't think that there's anything that we need to add to this or change that doesn't address that. Would everyone agree? Guess what, folks? The end. Okay. Staff, is there anything that you need from us in order to move forward on the report? Or Carrie, anything else you need from us to move forward on the report? Is there any actions that this committee needs to do, or? Arida?
Madam Chair, would you like the report directed to any specific committees?
Who did we do that with last year? Probably Ways and Means, Senate Appropriations, Social Services, Health and Human Services, whatever the counterparts is, that's good English, are on the Senate side. Yeah. Huh? Oh, judiciary, because there's some stuff in there for them on both sides, yes. I think that's the only committees we touch in all of this. No, that's all judiciary or approps. Good catch. Melinda, or Melissa. Excuse me, Melissa.
I'll answer to either.
I know, but you shouldn't do that. You should say, Representative, I'm Melissa.
As part of your recommendation for distribution of the committee report last year, you requested that KLRD put together the crosswalk of recommendations. So would you like us in the appendix to include the crosswalk that has the agency's reports on where they were in adopting and implementing the working group report, and then separately the crosswalk we prepared, which showed all of the activities since this committee adjourned last year in terms of all of the different reports? Do you want those both included as part of the special committee's report?
I would, if that's not a big issue for you all.
No.
Okay. Is there anything else you need from me? Your second. Carrie?
I don't think so, Madam Chair. I just wanted to thank all the working group members and the committee, special committee, for working with KHI and letting us work with you again on this project. And then I'll follow up with KLRD. I know they'll be doing changes to reflect the changes that you all discussed to the working group report, but I also want to make sure we do the checklist thing. So if we need to assist with that, do that as well. Thank you.
Representative Arnberger.
Thank you, Madam Chair. Could we get staff to send everybody who was on the committee to Senator Hawk and Representative Ruiz for their phones going off for treats?
Yes.
Thank you.
You have to provide sweets to KLRD and the revisor's office. It didn't go off just once.
That's where I get my candy.
Yeah, you're going to be supplying that candy. That's what you're going to do. Okay, is there any other recommendations or things that didn't get discussed that you wanted? Okay, none. I like that very much. I want to also say thank you to all of the ad hoc members that joined us, because without their expertise, and these are people that are doing this job, that we've gathered all this information into this report. I appreciate their assistance and their time that they've committed to this. I want to thank KHI because I think they've been a wonderful team partner with us in putting this into a form that we can take and follow and click through. I still say that this report that we get with KHI and with KLRD from this committee is one of the best reports that I've ever had the opportunity to work with. And I like the ability to follow it and be able to talk to someone and say, well, go to page so-and-so. Well, you know where it says? No, we can do the 10.1s, the 3 point, whatever it is. and follow through this. And I want to thank each and every one of you for the time and commitment that you made, because you don't get paid attending those working groups. And I know some of you attended more than just the one subject that you chose to be on. So thank you. And I want you to realize that it's 4:30. It's not 7. And we got out of here. We're adjourned. Wow. Huh? Oh, hell no. No, I drove up with Renee, and she's got a meeting tomorrow, or